Hello everyone, I'm Dr. Ashish Kuragai and today we'll be studying about clinical anatomy of the lymphatic organs. So the lymphatic organs are primarily divided into two types, primary lymphatic organs and secondary lymphatic organs. So you need to understand that primary lymphatic organs, they are associated with producing and maturing the lymphocytes, all right? So they produce and mature B cells and T cells. So there are two primary lymphatic organs, bone marrow and thymus. All right. So bone marrow produces mature B cells. All right. And T cells are also produced in the bone marrow, but the T cells are matured in the thymus. All right. So the bone marrow produces mature B cell. The B cells are mature, but they are naive. That means they are not exposed to the antigen and they are not activated. So they are mature, right? They are capable of being active, but they are not activated because they are not presented with an antigen. They are not exposed to an antigen. So they are capable of performing their function, but they are naive. All right. Now, bone marrow produces T cell as well, but the T cell maturation occurs in the thymus. All right, that's all you need to know. Now let's talk about secondary lymphatic organs. So the only thing you need to understand about secondary lymphatic organs is that they activate the mature B cell and T cell. So B cell and T cell, when they are matured, they get collected in these secondary lymphatic organs. All right, and when they're exposed to an antigen, then they are activated and then they are fully capable of performing their function. And then they differentiate into different types of T cells and different types of B cells. All right. So this differentiation and activation occurs in secondary lymphatic organs after being exposed to an antigen. So let's look at some of the most important secondary lymphatic organs. They are spleen, lymph nodes, tonsils, and Peyer's patches. So these are the most important ones. So antigen presentation occurs via antigen presenting cells. So for example, let's say antigen presenting cells capture an antigen in the skin. All right. So via the draining lymphatics, these antigen presenting cells come to the lymph node and present this antigen to the B cells and T cells. All right. Then they divide into mature effector cells. All right. The mature naive cells divide into effector cells. All right. Now, we have talked about bone marrow, and from exam point of view, that's all you need to know. It produces B cells and T cells, but B cells, when they are produced, are mature. T cells, when they are produced, are not mature. And this maturation of T cell occurs in the thymus. That's all you need to know. All right. Now, talking about thymus, this is super high yield from exam point of view. Now, one of the most important things that they ask in exam is the embryology. So you need to understand that thymus has two origins. The epithelium develops from the third pharyngeal pouch, all right, the endoderm. E for E. Epithelium develops from the endoderm. And it's the third pharyngeal pouch. Super high from exam point of view. Now, thymic lymphocytes, they develop from the mesoderm, all right? Epithelium from the endoderm and the lymphocytes from the mesoderm. So in exam, they'll give you a question about myasthenia gravis. And you know that myasthenia gravis is associated with thymoma or thymic hyperplasia, right? And then they will ask, which of the following is the origin of this associated organ. All right. So first you need to identify that the patient has myasthenia gravis. Then you need to associate it with thymoma. All right. Then they will ask you which of the following is the origin of this thymus. All right. So this is one way of asking a question in the exam. Now, the most important thing that you need to learn from this slide is the clinical relevance. So they will ask you numerous questions about thymus, all right? So you need to understand that thymic hypoplasia is associated with DiGeorge syndrome and SCID, all right? Severe combined immunodeficiency syndrome, all right? So they'll give you a clinical scenario of DiGeorge syndrome, all right? They'll tell you there's immunodeficiency, the patient has recurrent infection, the patient has hypocalcemia, things like that, right? And then they will ask you which of the following organs will be hypoplastic, right? Or they might give you that on examination, thymus is hyperplastic. Which of the following is the disease? All right. So there are numerous immunodeficiency syndromes, and the clinical scenario or clinical presentation might be similar. But this point that there will be thymic hypoplasia will help you to narrow it down to DJOS syndrome or SCID. All right. So DJOS syndrome and SCID are associated with thymic hypoplasia, super high yield. Now, another clinical association that they love to ask is thymic hyperplasia. So, thymic hyperplasia is associated with myasthenia gravis, SLE, and rheumatoid arthritis. So, I talked about myasthenia gravis earlier, but they will ask you a question about rheumatoid arthritis, and they might ask which of the following organs are hyperplastic. All right. So, they'll give you a 25-year-old woman presents with joint pain, knee swelling, stuff like that. And then they will ask you which of the following organs are hyperplastic. All right. Another super high yield point is thymoma. So it's a tumor of epithelial cell. All right. It's a tumor of epithelial cell. And like I said, myasthenia gravis is highly associated with thymic hyperplasia and thymoma. All right. And other disease associated with thymoma are pure red cell aplasia and immunodeficiency with thymoma. All right. These three are super high yield and associated with thymoma. So now let's talk about the structure of a lymph node. Now, this is afferent lymphatics. This is where the lymph node receives the lymphatic fluids, all right? So it comes from the afferent lymphatics and then it leaves from the efferent lymphatics. The lymphatic fluids come from here and leave through here, all right? Now, the most important thing that you need to understand from exam point of view is cortex, medulla, medullary sinus, and the follicles, all right? Super high yield. Now, let's talk about cortex. So, cortex is also known as the B cell zone. All right. It's called B cell zone because B lymphocytes are stored here. All right. So, the B lymphocytes are housed in the cortex. All right. So these are follicles, all right? Now this is a secondary follicle. I have not shown primary follicle in this image, but the difference between secondary follicle and primary follicle is that secondary follicles are the active ones, all right? And primary follicles are inactive. The secondary follicle has this pale germinal center. Can you see this pale part, right? Compared to this purple, this is a bit pale. So if you see a pale follicle, it means that it's the active follicle, all right? It's the secondary follicle. If this follicle didn't have this pale area, let's say there were this purple area only, let's say this pale center was not present, then that would be primary follicle. Now, follicles have B lymphocytes, all right, super high yield. So, lymphoid follicles are the sites of B lymphocyte storage, differentiation, and proliferation. The way the question is asked is B cell activation occurs after an antigen exposure, right? Let's say you get a bacterial infection and you need to produce antibodies against that infection, right? Against that organism. So B cell needs to be activated, differentiated, and proliferation has to occur to produce those antibodies, all right? So this activation proliferation occurs in secondary follicle. So this is how they will ask you a question. They'll give you a vignette of the infection and then they will ask you which of the following locations of lymph node are involved in this process. All right. And then you need to understand that, okay, it's the secondary follicle where the action happens. It is where proliferation of B lymphocytes occur. All right. So that's one way of asking question in the exam. So secondary follicle is super high yield. And primary follicle, although there are B lymphocytes, they are naive. All right. So primary follicle, they house the naive B cells, but this activation occurs in the secondary follicle. Super high yield from exam point of view. All right. Now, this is cortex. All right. So follicles are present in the cortex. Now, this is medulla. All right. This is medulla. And the reason between cortex and medulla is called paracortex. Now, paracortex is super high yield from exam point of view because it is the T cell zone. The cortex was the B cell zone, but the paracortex is the T cell zone. All right. So it houses T cells. So it is the site of T cell activation. Cortex is the site of B cell activation. Paracortex is the site of T cell activation. Super high yield from exam point of view. Now this is medulla. So medulla has these medullary cords and the sinus, all right? And you'll get numerous questions about medullary cords and medullary sinus. And the way they will ask you question is that medulla houses the macrophages, all right? So specifically the medullary sinus, all right? Medullary sinus has macrophages and reticular cells, all right? So medullary cords, they have plasma cells and lymphocytes. So they are packed with plasma cells and lymphocytes. But sinus, medullary sinus is unique because it has macrophages. All right, medullary sinus is unique because it has macrophages, and you'll get numerous disease where macrophage activation occurs, right? So the way they will ask you a question is, let's say a patient has tuberculosis, right? And you know that in tuberculosis activation of macrophages is so important, right? And then they will ask you, where are these macrophages located, right? And then you need to know that it's the medullary sinus which has macrophages, all right? So these are the most important structures of lymph node from exam point of view, all right? So it's not possible to go into every detail of the structure of lymph node, but from exam point of view, all you need to know is cortex is the B cell zone, paracortex is the T cell zone, and medullary sinuses, they have macrophages, all right? So these three are the most important things, but other stuff that we discussed in this slide are super high yield, but the most important ones are cortex, paracortex, and medulla, all right? Now, lymph nodes, like I said earlier, these are the sites where antigen presentation occurs and the activation of B cells and T cells occur, right? So we have talked about cortex as the B cell zone, and we have talked about follicles, all right? We have talked about secondary follicle and primary follicle. Secondary follicles are the active ones, primary follicles are the inactive. So primary follicles, they are inactive, they are dense aggregates of the naive B lymphocytes. But secondary follicles are pale and the active B cells, all right, the mature active B cells are present in the secondary follicle. This is super high yield from exam point of view. Now, paracortex, the T cell zone, all right. Now, we have talked about medullary cords and sinus. Cords, they're packed with plasma cell and lymphocytes, and the sinus, they're composed of macrophages and reticular cells, all right. So now let's talk about the most important lymph nodes in the body and their importance from exam point of view. Now, before we talk about individual group of lymph nodes, let's talk about why lymph nodes are really important from exam point of view. Now, in exam, lymph nodes will help you to come to a diagnosis, right? It helps to narrow down the differential diagnosis and it helps us to stage the disease. Let's say if there's malignancy, lymph nodes help us in the staging of the malignancy. All right. Now let's talk about diagnosing first. Now, talking about diagnosis, let's say there is a question about an ulceration in the anterior part of the tongue. Now, there are numerous causes of ulceration in anterior tongue. It could be squamous cell carcinoma, it could be Crohn's disease, it could be a simple aphthous ulcer, it could be a viral infection, right? So, how do you distinguish what is the diagnosis based on the examination finding? Now, anterior tongue drains into the submental lymph node. Now, if the submental lymph nodes are involved, and let's say if they are tender, mobile, then we can be pretty sure it's an infective cause. All right, if it's tender and mobile. Now, if that lymph node is hard, fixed, immobile, then we can think about the more sinister cause, right? Then we can think about malignancy. So this is how lymph nodes help us to differentiate between a benign and malignant cause from the examination finding itself, all right? Now, another important feature of lymph nodes is the spread of malignancy, right? If the malignancy spreads, then the lymph nodes will be involved. Now, the most important thing you need to understand that there are something called sentinel lymph nodes. Now, sentinel lymph nodes of different malignancy and different organs are different. But the concept that the lymph node which will be involved first, right? The lymph node which is initially involved when the malignancy spreads is the sentinel lymph node. So let's take example of breast. If the breast cancer spreads, the first lymph node that will be affected is the axillary lymph node. All right. So for breast cancer, the sentinel lymph node are the axillary lymph nodes. So these are also super high yield from exam point of view. Now let's look at individual group of lymph nodes. All right. Now I won't be talking about each and everything in this table. You can pause the video and read the table yourself, but what I'll be teaching you is the clinical importance. So like I talked about earlier, submandibular and submental lymph nodes, they're important for the diseases of the oral cavity. All right. So I talked about tongue in the earlier slide, right? Now let me give you an importance of the draining lymph nodes from the example of the lips, all right? The lower lip and upper lip, they have slightly different drainage, all right? The upper lip and the lateral part of the lower lip, they drain into the submandibular lymph node. The medial part of the lower lip, it drains into the submental lymph node, all right below the chin. Now, if there is a lesion in the most medial part of the lower lip, you can understand that the submental lymph node will be involved. Whereas if there is a lesion in the lateral part of the lower lip, the submandibular lymph nodes will be involved. This is just an example why lymph nodes are important from exam point of view. It will help you narrow down to the location of the disease, all right? It will help you understand the spread of the cancer, all right? That's why lymph nodes are super high yield. Now, if the deep cervical lymph nodes are enlarged, then you can narrow down that there is some kind of disease either in the posterior tongue, oral cavity, or there is some kind of malignancy of head and neck. All right. So if deep cervical lymph nodes are involved, this is what it hints you towards. Now, like I said earlier, the way lymph node examination help us to narrow down the diagnosis is by its characteristic, all right? If it's an infection, the lymph nodes will be very tender and mobile. So let's take example of infectious mononucleosis, super high yield from exam point of view. In infectious mononucleosis, if you don't have lymphadenopathy, then it's likely that diagnosis is something else, all right? So infectious mononucleosis, lymphadenopathy must be present. Now, when you examine the cervical lymph nodes, if they're not tender, then your suspicion about infectious mononucleosis is wrong. All right. In infectious mononucleosis, the lymph nodes are going to be tender. All right. But let's say if it's a malignancy, then the lymph nodes will be non tender, immobile, fixed, hard. All right. So this is how you can distinguish whether it's infectious mononucleosis or it's a malignancy. All right. So another most important lymph node from exam point of view is the left supraclavicular, the Virchow node, all right? And it is involved in abdomen and pelvis malignancy. That's why it's super high yield. Now, another highly tested question in exam is tuberculosis, all right? Now, in tuberculosis, mediastinal and hilar lymph nodes are involved. So whenever you have a patient with cough and hilar lymphadenopathy, you can narrow it down to these causes, all right? You can narrow it down to TB, sarcoidosis, malignancy, and granulomatous condition, right? So TB and sarcoidosis are the granulomatous conditions. So if there is cough and other respiratory symptoms, and if these mediastinal and hilar lymph nodes are involved, then you can narrow it down to these diseases. All right. We talked about breast cancer, right? And how axillary lymph nodes are involved. Now, another super high yield lymph node is epitrochlear. Whenever you have involvement of epitrochlear lymph node, you can definitely choose the option of syphilis, all right? Super high yield. If epitrochlear lymph nodes are involved, you can narrow it down to syphilis. Now let's look at other important lymph nodes of the body, all right? So celiac, superior mesenteric, and inferior mesenteric lymph nodes are involved in disease of the bowel. All right. So if there is a malignancy of colon, let's say if there's colon cancer, then you need to understand that these lymph nodes will be involved. Now, depending on which part of colon, the lymph nodes involved will be different. All right. And these lymph nodes have to be removed if there is a surgical procedure. All right. So you need to understand that. Now, the most important thing from exam point of view is gastric cancer. All right. In gastric cancer, the periumbilical lymph node. All right. So the periumbilical lymph node. So it's present here. All right. So periumbilical, that means around the umbilicus. All right. So if the lymph nodes around the umbilicus are involved, and if you can feel that during examination, then you have to be suspicious about gastric cancer. All right. Super high yield, Sister Mary Joseph lymph node. periumbilical lymph node, super high yield. So let's assume there is a mass in testis or ovaries. The lymph node involved will be para-aortic. Although location of testis is here, you might be wondering why there is para-aortic lymph node involvement, right? So for this, you need to understand that testis, it develops here, all right, as an intra-abdominal organ. Then it descends down here to the scrotum. That's why even if there is involvement of testis, which is located here, the lymph node involved will be para-aortic, super high yield from exam point of view. If there is any malignancy in the testis, they will spread to the para-aortic, all right? They'll spread around here, around the para-aortic lymph node. Now, another really important lymph node is the external iliac, all right, and the internal iliac. So external iliac and internal iliac, they are present around the iliac artery, so somewhere around here, all right? Now, if there is a malignancy of cervix or let's say vagina, right, they will spread to the internal iliac, all right? So that's why you need to understand the importance of these lymph nodes. They help us to identify metastasis, the staging of the malignancy, all right? So super high yield. Now, another really important point from exam point of view is the involvement of anal canal below the pectinate line and involvement of anal canal above the pectinate line, all right? Now, if there is any disease condition below the pectinate line, it will drain to the superficial inguinal lymph node. But if there is involvement above the pectinate line, it will involve the internal iliac. All right, super high yield from exam point of view. Now, another highly tested question is the involvement of the foot. All right, if the medial foot is involved, it will drain to the superficial inguinal lymph node. So if there is any infection of the medial foot, you need to understand that it will drain to the superficial inguinal. Now, if there is involvement of the lateral foot, all right, then the popliteal lymph node will be involved. All right. So the posterior calf and the lateral foot, they drain to the popliteal. But the medial foot, it drains to the superficial inguinal. This is super high yield from exam point of view. All right. Now, this is a small mnemonic. The popliteal, the letial sounds like little toe, all right? And little toe is present in the lateral foot, all right? So always remember, lateral foot involvement, there'll be drainage to the popliteal. But if medial foot is involved, it will drain to the superficial inguinal. All right, super high yield from exam point of view. Now, another important point that I want to repeat again is the anal canal. If there is any disease condition below the pectinate line, the superficial inguinal lymph node will be involved. But if there is involvement above the pectinate line, the internal iliac lymph nodes will be involved. All right, above the pectinate line, internal iliac. So now let's talk about spleen. So first, we need to know the important function of spleen. So the most important function of spleen is to filter and clear old and misshaped RBCs and platelets. And another function of spleen is similar to the lymph node, all right? It initiates the humoral response. So you need to understand how spleen clears and filters misshapen RBCs. So misshaped RBCs, they cannot bend or they are not flexible like the normal RBCs, all right? And in spleen, there are these really narrow arterioles in the red pulp. And if the RBC is abnormal, it cannot squeeze through these narrow arterioles, all right? And when they cannot squeeze through, they get stuck and they are cleared by the macrophages, all right? That's how misshapen or old RBCs and platelet are cleared via spleen. Now, similar to lymph node, it is really important in initiating the humoral immune response via B cells and T cells. Now, another really high yield point from exam point of view is the location of the spleen. The spleen is located in the left upper quadrant, all right? And if there is a question about trauma, and if the impact is on the left side of the body, we have to be suspicious about the splenic rupture, all right? And if there is particular mention of the fracture of 9th, 10th, and 11th ribs, then you have to be more careful about the risk of splenic rupture, all right? So let's look at the structure of the spleen. So the structure of the spleen is divided into red pulp and white pulp. So here I have highlighted this small section which shows both the red pulp and the white pulp. All right. So this area outside is the red pulp. All right. And this whitish peel structure is the white pulp. That's why they are called white pulp and the red pulp, right? So I've highlighted this structure which shows both the white pulp and small part of the red pulp here. All right. The white pulp is divided into follicles, or which are also known as the B cell zone. All right. The follicle are known as the B cell zone. And there is a T cell zone as well. Now you can imagine that B cell zone or the follicles have a lot of B cells, right? That's why they are called B cell zone. And the T cell zone has huge storage of the T cells. Now the follicle has a germinal center where the major activity or the major activation of the B cell occurs. So this is the germinal center where the active B cells are present, all right? And this is the marginal zone. Now let's look at these structure in more detail. So the white pulp is the reason where antigen filtration and presentation occurs. Now you can imagine that the white pulp has both the B cell zone and the T cell zone. So it's obvious that antigen presentation occurs here. All right. Now, like I said, this lymphoid follicle is the B cell zone. It has a lot of B lymphocytes. Now, T cell zone is also called periarteriolar lymphatic sheath. All right. And this marginal zone contains the macrophages and specialized B cells. All right. So when B cells are differentiated into effector cells, they're present here. So the specialized B cells are present in the marginal zone and it contains a lot of macrophages. Now you can imagine that antigen capture, all right, occurs here. Why? Because it has a lot of macrophages and B cells. So antigens are captured here and then they get presented and the B cells are activated in the germinal center. Now let's look at the red pulp. So red pulp is the area here, all right, outside the white pulp. So the white pulp is present more centrally and the red pulp is more on the outside of the white pulp. All right. So this is the red cell zone. All right. And it is involved in the capturing of the abnormal RBCs and platelets. Like I talked earlier, if the RBCs are misshaped or if they are old, they cannot squeeze through the narrow arterioles. All right. And then they are captured by the macrophages and they undergo phagocytosis. Now, splenectomy. This is super high yield from exam point of view because you'll get a lot of questions about splenectomy. So the most common conditions for splenectomy are trauma, sickle cell disease, thalassemia, hereditary spherocytosis, and refractory ITP. We won't be going detail into the absolute indications and, in detail of these diseases because it's not the scope of this video, all right? So these are just common conditions where splenectomy is necessary. Now, super high yield point from exam point of view is how our body adapts or what are the changes in our body after splenectomy. This is super high yield. Now, spleen is such an important organ for our immune system, right? It's a really important place where antigens are captured, where bacteria are destroyed, all right, where a lot of phagocytosis by macrophages occur. Another reason why spleen is important because it contains a large pool of B cells and T cells. And when we remove this large pool, there'll be deficiency of B cells, all right? And when we remove this large pool of B cells, obviously the IgM production is going to decrease, all right? Now, when IgM production is decreased, obviously the complement activation won't occur because we don't have this IgM, all right. And IgM and IgG antibodies are one of the most important antibodies for complement activation. Without complement activation, there won't be C3b opsonization because remember, C3, complement C3b is an opsonin, all right. It tags the cell or abnormal cells and bacteria so that the macrophages and natural killer cells recognize them and they can phagocytose them, all right? So there is decreased clearance of opsonized bacteria because there's no opsonin, all right? There's no C3p. So this increases the susceptibility to infection, especially by the encapsulated bacteria, because clearance of encapsulated bacteria depends on opsonization and phagocytosis. Without opsonization, the macrophages and natural killer cells, they cannot recognize bacteria, all right? So phagocytosis will be impaired. And this is one of the most important defense mechanism to destroy the encapsulated bacteria. So without spleen, there's increased risk of encapsulated bacteria. Super high yield from exam point of view, all right? They love to test you about decreased IgM production, decreased complement activation, decreased opsonization after splenectomy. So you need to understand this concept. IgM production is decreased because there's decrease in B cell, all right? And without IgM production, there won't be enough or adequate complement activation, decrease C3b, and without C3b, there won't be opsonization. So now let's talk about post-splenectomy findings. So these are highly tested questions in the exam, all right? They will love to ask you about post-splenectomy finding in the exam. So let's look at the post-splenectomy findings in the peripheral blood smear. So the first high yield finding is the Howell-Jolly bodies. So Howell-Jolly bodies are nothing but RBCs which contains the nuclear remnant. So normally RBCs don't have any nuclear remnant, but when they are present, they are called Howell-Jolly bodies. So normally spleen clears any RBCs with the nuclear remnant, but after splenectomy, this function is impaired. So you'll see RBCs with nuclear remnant or the Howell-Jolly bodies in the peripheral smear after the spleen is removed. So this is Howell-Jolly body. All right, this is an RBC with a nuclear remnant. All right, another high yield cell that you'll see in peripheral blood smear is the target cell. So target cells are RBCs which look like this. All right, so this looks like a target sign. That's why they are called target cells. So they are nothing but RBCs which have mismatched RBC volume and surface area. All right, normally target cells, when they form, they are removed by the spleen. But like I said earlier, after the spleen is removed, this clearance function of the spleen is not present, right? We don't have that feature. Then target cells and Howell-Jolly bodies, they appear in the peripheral blood smear. Super high yield from exam point of view. Now, another finding in peripheral blood smear is thrombocytosis. Now, you might be wondering why there'll be thrombocytosis. It's because of loss of function of storage, all right? Spleen normally stores a lot of thrombocytes and B cells and T cells, all right? When this sequestration feature of the spleen is gone, you'll see thrombocytosis, all right? Because there's no sequestration of the thrombocytes in the spleen. Another feature is lymphocytosis. Again, this occurs because of loss of sequestration. Now, you might be wondering, earlier I told there is loss of large pool of B cell, but here I'm saying there'll be lymphocytosis. You need to understand that this loss of large pool of B cell is loss of large pool of active B cells. In the blood, you don't have active B cells. They are mature B cells, but they are not active. The activation occurs in the spleen, all right? When this loss of active B cells occur, there is decreased IgM production, all right? So remember, it's the follicles where activation, proliferation of the B cells occur, right? And without spleen, this follicle is lost. So that loss, that loss of large pool of B cell means the loss of active B cells, all right? So you need to understand that. So now let's talk about vaccination, all right? And this is vaccination against the encapsulated organism when you're undergoing splenectomy. So if this is an emergency splenectomy, you do this vaccination after the splenectomy, all right? So post splenectomy. But if it's an elective splenectomy, let's say for sickle cell disease, or let's say for thalassemia, then you need to give this vaccines 2 weeks before the splenectomy, all right? So you give vaccination against the encapsulated organism. Like I said earlier, encapsulated organisms are destroyed by opsonization and phagocytosis. Without spleen, there's decreased IgM production and there'll be decreased opsonin, all right? So there's a risk of encapsulated organism infection. So you need vaccinations against strep pneumo, all right? So you administer pneumococcal vaccine against strep pneumonia. Then against Neisseria meningitis, you need meningococcal vaccine. And for Haemophilus influenza type B, you need the vaccine against it. All right. So these three are the most important vaccination for encapsulated organism. And this is super high yield from exam point of view. Now let's do some USMLE style questions. So let's look at this first question. So a 32-year-old man is admitted to ICU due to sepsis. His past medical history is significant for a motor vehicle accident 4 years ago, for which emergency laparotomy was done due to internal bleeding. All right, so there was a ruptured organ and he needed emergency laparotomy. Since then, he has had multiple episodes of infection due to Streptococcus pneumoniae. Currently, he's in sepsis and his blood pressure is 80/40, so he's in shock. There's tachycardia, and the blood culture obtained on admission grew Streptococcus pneumoniae. So he has had recurrent strep pneumo infection, and again, there's Streptococcus pneumoniae isolated in the blood. All right. Impairment of which of the following mechanism most likely contributed to this recurrent infection? Now you need to understand that the patient probably had splenectomy. All right. So there was internal bleeding because of ruptured organ. Since then, there is recurrent encapsulated organism infection. So most likely there was splenectomy. So what function was impaired after splenectomy? So let's look at the options. Is it decreased complement production, or impaired T cell activation, decreased opsonization, or decreased interferon release? Now, you might be confused with option A and C because I said complements are needed for opsonization, especially C3b. So you might be confused with decreased complement production, but you need to understand that complements are produced in the liver. The activation needs IgM. All right, so antigen antibody triggers the activation of complements, but they are produced in the liver. So option A is wrong. Now, decreased opsonization, all right, this is the answer, and we just talked about it, all right. Without spleen, the active B cells are decreased, and there'll be decreased production of IgM, without which there won't be activation of complements and there won't be C3b, which is one of the most important opsonins beside IgG. All right, so the right answer is decreased opsonization is causing recurrent encapsulated organism infection in this patient. All right, so now let's look at another question. A 22-year-old man comes to your office because of 5-week history of cough, weight loss, fever, and night sweats. Now, he migrated from Nepal 8 months ago. His temperature is 100.5. Physical examination shows a thinly built man with enlargement of right supraclavicular lymph node. Chest and abdominal examination are normal. However, PPD test is positive. Biopsy specimen of the supraclavicular lymph node is most likely to show causative bacteria in which of the following lymph node locations? So if you remember what I taught earlier, tuberculosis causes involvement of the macrophage. All right, macrophages engulf the mycobacterium. So you need to understand which of the following location has excessive macrophages. All right. So let's look at the option. Is it the primary follicle? No, right? Follicles, they contain B cells. Is it the paracortex? Paracortex contains T cells. Now, the right answer is medullary sinus, because if you remember, medullary sinus houses macrophages. All right, so the right answer is medullary sinus. Thank you. Hope you enjoyed the video. Hello everyone, I'm Dr. Ashish Guragai, and today we'll be talking about innate versus adaptive immunity, and then we'll be talking about B lymphocytes and T lymphocytes. We'll be focusing on their development and their activation. So let's get this started. So let's start with innate versus adaptive immunity. So what is innate immunity? Innate immunity is nothing but our body's defense mechanism against all the pathogens that we encounter from minute to minute in our daily life. So why do you think we don't get upper respiratory tract infection all the time? Or why do you think we don't get skin infections all the time? It's because we have this innate immunity components such as physical barriers, for example, skin and mucosa. And we have ciliary motility and cough reflexes, which prevents us from getting infected by inhaled pathogens. So when we inhale a pathogen, ciliary motility and the sputum traps the bacteria, and then ciliary action expels the sputum, which has the trapped bacteria inside them. Similarly, the cough reflexes also help us to remove these pathogens from invading our respiratory tract. Now, the cellular components of innate immunity are macrophages, neutrophils, dendritic cells, natural killer cells, and complement proteins. Similarly, we have secretions like our saliva, which contains lysozymes. Similarly, we have gastric acid secretions in our stomach, which protects our body from being invaded by the pathogens that we consume. Now, the components of adaptive immunity are T cells, B cells, and the circulating immunoglobulins. So let's talk about the response to pathogens in innate immunity. This response is non-specific, which means our components of the innate immunity, they cannot distinguish whether this is bacteria, whether this is virus, or they cannot distinguish whether this is gram-positive bacteria or gram-negative bacteria. All they do is they recognize that these proteins or these antigens in these pathogens are foreign and they are trying to invade our body. That's all innate immunity does, all right? They know these proteins or antigens are foreign and we have to destroy them. That's all they do, all right? And the response they create is non-specific. Now, another important thing about innate immunity is that these reactions occur rapidly, all right? So let's say you get a cut in your hand, all right? Inflammation occurs within minutes. Similarly, because of the disruption of the physical barrier, that is skin, now the bacteria can invade our skin. But do we get an infection after every cut? No, right? We don't get an infection after every cut. Why does that happen? Because neutrophils and macrophages will rush to the site of inflammation and any bacteria which invaded our skin will be phagocytosed. All right, and this happens within minutes to hours. Now, talking about memory response in innate immunity, there's no memory response. That means our innate immunity does not remember whether Neisseria caused the infection in our body or there was a streptococcal sore throat. All right. Our body does not remember the pathogens. All right. Now, let's talk about adaptive immunity. The components of adaptive immunity are T cells, B cells, and the circulating immunoglobulins. Now, compared to innate immunity, the response to pathogens in adaptive immunity is highly specific. For example, if there is a streptococcal sore throat, there will be a specific response to that particular strain of streptococcus. All right, it will be highly specific, and that response won't be same to another bacteria. It will be completely different and unique. The immunoglobulins that were produced against one strain of streptococcus won't be same compared to another strain of streptococcus. So that's why adaptive immunity is highly specific. But the thing is, this specific immunity develops over long periods of time. It does not happen rapidly. And during that duration, it's innate immunity which protects us from the pathogens. All right. During the development of adaptive immunity, we need some kind of protection, and that protection is provided by innate immunity. Now, unlike innate immunity, the memory response in adaptive immunity is vigorous and quicker, right? In innate immunity, there's no memory response, but in adaptive immunity, the memory response is really robust. Now, what does that mean? It means if we get infection from the same streptococcus after, let's say, 2 months, our response will be really quick and we don't need a long period of time to adapt. The response will be robust and there'll be specific immunoglobulins to destroy that particular strain of streptococcus. Now let's talk about pathogen recognition. So we talked about how macrophages and neutrophils go to the site of inflammation, but how do they recognize bacteria or pathogens? How do they recognize, okay, these are not our normal cellular components of our body, they are foreign. So how do they recognize it? Now, this happens from toll-like receptors. So toll-like receptors are a pattern recognition receptors. That means they recognize different proteins or different molecules in bacteria via these toll-like receptors. Now, let me give you a specific example. So, toll-like receptors can recognize pathogen-associated molecular patterns or PAMPs. All right. Talking about gram-negative bacteria, they have lipopolysaccharide. And our toll-like receptor recognizes lipopolysaccharide and knows that this is a foreign pathogen, this is a bacteria, and the body knows that we need to destroy these pathogens. Similarly, there are other PAMPs like flagellin, nucleic acids, right? And our body is able to recognize these proteins via the toll-like receptors. Now, in adaptive immunity, this pathogen recognition occurs via immunoglobulins. Each immunoglobulin has a unique binding site to a particular antigen, and when that antigen is exposed, our immunoglobulins go and bind to that antigen and then trigger adaptive immunity. Similarly, like immunoglobulins, there are cytokines which are able to recognize the pathogen and initiate the adaptive immunity. Now let's talk about functions of natural killer cells. Now you might be wondering why I am only focusing on natural killer cells which are part of innate immunity, but there are other cells as well, right? But the reason I'm focusing on NK cells or the natural killer cells is because from the exam point of view, these are super high yield, all right? So what are natural killer cells? They're nothing but a type of lymphocytes which secretes porphyrins and granzymes to induce apoptosis of virally infected cells or tumor cells. Now, this image shows how natural killer cells identifies a pathogen and then releases porphyrins and granzymes. Now, if you look at this image, you can see that there are immunoglobulins which are binding to the antigens, right? Now, this will form an antigen-antibody complex, and our natural killer cells in the body are able to recognize this antigen-antibody complex, and then it will know that it needs to destroy the cell, right? This way, natural killer cells release porphyrins and granzymes and cause apoptosis. Besides this, natural killer cells are also able to recognize pathogens via PAMPs, right? Now, the activity of natural killer cells are enhanced by interleukin 2, interleukin 12, interferon alpha, and interferon beta. Now, these are super high yield information. Now, from the exam point of view, how they will ask a question about this activity enhanced by these interleukins is that they'll give you a question of viral infection. They'll explain how a kid got virally infected, and then they will say that natural killer cells were able to destroy this virus infected cell. Which of the following interleukins enhance the activity of natural killer cells? So this is how they ask question, and there'll be different options, and you have to choose one among these four. The high yield ones are interleukin 2, interleukin 12, interferon alpha, and interferon beta. So these enhance the activity of natural killer cells, all right? And these are super high yield from exam point of view. Now, there's one more really high yield information. These cells are also able to destroy any cell which lacks inhibitory signals such as MHC1 on the cell surface. Now, these are really important in tumor cells. Tumor cells, if they lack MHC1, it will signal natural killer cells that these cells do not have inhibitory signals. So these are definitely some kind of abnormal cells and natural killer cells need to destroy them. All right. Now these inhibitory signals are really important because these signals protect our normal cells from being destroyed by natural killer cells. All right. Similarly, natural killer cells play a huge role in type 2 hypersensitivity by destroying cells via antibody-dependent cell-mediated cytotoxicity. We'll be talking about these in detail in our hypersensitivity video. As it is really important, I want to highlight this destruction of tumor cells by natural killer cell one more time. So the tumor cells, they lack MHC1, all right? And MHC1 is an inhibitory signal. If this inhibitory signal is absent, then it tells natural killer cell that this cell is some kind of abnormal cell and it needs to be destroyed, all right? Super high yield, that's why I repeated it multiple times. I want you to really remember this function of natural killer cells. Now let's talk about major functions of B and T cells. So these are just a basic overview of the function of B and T cells. So B cells, they initiate adaptive immune response via humoral mechanism. All right, the humoral immune response of the adaptive immune system is initiated by B cells. Similarly, they recognize and present antigen as well. The most important function of B cell is to produce antibody and also to maintain an immunologic memory. Similarly, the functions of T cells are to initiate cell-mediated immunity. There are different types of T cells. The most important ones are CD4 T cells, which helps the B cell to make antibodies and also produce cytokines. Similarly, there are CD8 positive T cells, which directly kill virus infected and tumor cells. Now, T cells play a huge role via cell-mediated immunity to cause delayed hypersensitivity, which is also called cell-mediated hypersensitivity. It is a type 4 hypersensitivity reaction. Now, T cells also play a huge role in acute and chronic cellular organ rejection. So this was just a brief overview of function of B and T cells, and we'll be talking about them in great detail as the video goes on. But this was just an overview for you guys. Now, before we talk more detail about function of B and T cells, we need to understand HLA gene complex and MHC proteins. So our body has these gene complexes called HLA, human leukocyte antigen. So these gene complexes, they code for MHC proteins, major histocompatibility complex. All right. Now, MHC proteins, they play a vital role in initiating immune response as they present antigen fragments to T cells and bind to T cell receptors. Now let's look at this figure. This is MHC class 1. It has alpha 1, alpha 2, alpha 3, and a beta 2 microglobulin. All right. They are also called HLA, HLA-B, and HLA-C. All right. And this is the cleft where antigens bind. Now let's look at the structure of MHC class 2. They also have similar antigen binding cleft, but their components are different. Unlike MHC class 1, MHC class 2 has two beta components, beta 1 and beta 2, and they have two alpha components, alpha 1 and alpha 2. All right, they're also called HLA-DR, HLA-DQ, and HLA-DP. Now let's talk about MHC class 1 and MHC class 2 in detail. So what is the loci that produces MHC1? It's HLA-A, HLA-B, and HLA-C. All right. And did you notice this mnemonic? One letter. If you notice, all the HLAs which produce MHC1 or which codes for MHC1, they contain only one letter, HLA-A, HLA-B, and HLA-C. Now, if you look at the loci that codes for MHC2, they contain two letters, HLA-DP, HLA-DQ, and HLA-DR. Now, this is really high yield mnemonic, all right? The USMLE exam loves to ask you about these components. So you really need to know this. Now, let's look at the structure. Like I said earlier, MHC1 has a heavy chain and a beta 2 microglobulin, and this heavy chain is formed by alpha 1, 2, and alpha 3. All right? Now, compared to the structure of MHC1, MHC2 has two equal length chains, two alpha chains, alpha 1 and alpha 2, and two beta chains, beta 1 and beta 2. Let's look at the structure one more time. So, this is the long chain or the heavy chain, which contains alpha 1, alpha 2, and alpha 3, and it contains a beta 2 microglobulin. Now, MHC class 2, it has two components, alpha and 2 beta. All right, alpha 1, alpha 2, beta 1, and beta 2. So, this is MHC class 2, and this is MHC class 1. Now, let's talk about the binding that occurs between MHC and the T cells. Now, you need to know that MHC1 presents antigen to only CD8 positive T cells, whereas MHC2 presents its antigen to only CD4 T cells. All right. Now, this is super high yield. It looks like a simple information, but this is really tested on the USMLE exams. All right. MHC1 binds to CD8 positive T cells. MHC2 binds to CD4 T cells. All right. Now let's talk about expression. Which cells express MHC1 and which cells express MHC2? So you need to know that all the nucleated cells, antigen presenting cells, and platelets, they present MHC1 on their surface. All right, they all express MHC1 on their surface. But the unique thing is, RBCs do not express MHC1. Now, this is again a high yield information for exams. Now, unlike MHC1, only antigen presenting cells express MHC2, another high yield information. All right. Now, what is the function of MHC1? Like I've said earlier, its function is to present antigens to CD8 plus cytotoxic T cells. All right. Now, did you notice this mnemonic? 8 times 1 equals to 8. So, what does that mean? Now, you need to remember this mnemonic that the interaction between MHC and the T cells will give you a number 8. If MHC1 interacts with CD8 positive T cell, how you'll remember this is 8 times 1 equals 8. All right. The ultimate goal is to form number 8. That's our goal. We need to somehow get the number 8. Now, if you notice in MHC2, they present antigen to CD4 T helper cells. All right. Now, like I said, our goal is to form number 8. Now, what is CD4, right? 4 times MHC2. So what is 4 times 2? That's 8. So this is the mnemonic. MHC1 interacts with 8 to give you number 8. 8 times 1 equals 8. Now MHC2, 2 interacts with 4 to give you the number 8. All right? I'm saying you one more time. The goal is to form the number 8. If 8 interacts with 1, it gives you 8. If 4 interacts with 2, it gives you 8. All right? Now let's talk about antigen loading. Let's look at the figure. So let's talk about MHC1 pathway of antigen loading first. All right? So let's look at this figure. In MHC1, the first thing you need to notice is that MHC1 pathway presents intracellular antigen. All right? So when a cell is infected by a pathogen, it has different antigens in its surface, right? So these antigens are peptides, they're proteins, which are cleaved by proteasome into small peptides, right? The larger proteins are cleaved by the proteasome into small peptides. Now, these peptides are loaded into rough endoplasmic reticulum via TAP, which is transporter associated with antigen processing. All right. Once these peptides are loaded into rough endoplasmic reticulum, they're attached with the MHC2. Once they're attached to MHC2, they form a small endosome, which is then released into the cell surface, and MHC1 is able to bind to the cell surface of the. Now, after the peptides are loaded into rough endoplasmic reticulum, they bind to the MHC1, which is present inside RER, and then it forms a small vesicle. Now, this vesicle will bind to the surface, right, and release the MHC1 to the surface. Now, MHC1 will now finally be able to interact with T cell receptors of CD8 positive T cell and presents its antigen to CD8 plus T cell. All right, this is MHC1 pathway of antigen presentation. Now, let's look at MHC2 pathway. Now, this is slightly different. If you notice, in MHC1, it was intracellular pathogen, but in MHC2, the pathogen is extracellular. Now, this extracellular pathogen is first phagocytosed, all right? And then this phagocytosed pathogen will be destroyed into smaller pieces by a acid-filled lysosome. Now, this lysosome will come and fuse with the endosome and will destroy the pathogen, right? And then it will break different proteins into smaller peptides which can be loaded. Now, once this acid-filled endosome interacts with the MHC2, the invariant chain will be destroyed, right? And finally, the antigen will be able to load into the MHC2 molecule. Now, after the loading of antigen to MHC2 molecule, this vesicle is finally able to fuse with the cell surface. Now, after the fusion with the cell surface, MHC2 receptors can present its antigen to CD4 positive T cell. All right. Now, talking about exam, there are numerous ways to ask a question, right? Sometimes there are numerous ways to ask questions from these two pathways. All right. Let's look at MHC1 pathway first. So the examiners will ask you questions like, there's a defect in TAP protein inside a cell. Which pathway of, you know, MHC presentation will be affected, or which T cell will not be able to recognize antigen, right? So we know that if there is a mutation in TAP, MHC1 won't be able to load antigen and present its antigen to CD8 plus T cell. So they can ask question in such pattern, or they might ask there is a problem in acidification of the lysosome, right? Which of the following MHC or which of the following cell will not be able to recognize antigen? If this acidification of the lysosome is affected, it cannot release the invariant chain. The only way to destroy or release the invariant chain, which is attached to MHC2, is by acidification. Now, if there's a problem in acidification, the invariant chain will keep on blocking the loading of the antigen into MHC2. So, the interaction between MHC2 and CD4 T cells will be affected. So, this is how they ask questions in USMLE Step 1. All right. Now let's talk about T cell development and maturation. So T cells, they originate from lymphoid progenitor cells in bone marrow, but they mature in the thymus. That's why they are called T cells. All right, T for thymus. Now one thing you need to know that when they are formed in bone marrow, they do not have CD4 receptors or CD8 receptors. All right, these receptors are attached to T cells when they mature in the thymus. All right, let's look at this. Now, this maturation has two steps. They're called positive selection and negative selection. Now, let's talk about positive selection first. Like I just said, immature T cells which are formed in the bone marrow, they are CD4 negative and CD8 negative. All right, but they acquire CD4 and CD8 in the cortex of the thymus. All right. Now, thymic cortical cells also express MHC class 1 and MHC class 2, right? And if you remember from our video, MHC class 1 interacts with CD8 and MHC class 2 interacts with CD4, right? Now, what happens in positive selection of T cells in the cortex is that it makes sure that the T cell receptors can bind to the MHC appropriately. Now, this appropriately means neither too strongly nor too weakly, right? It has to be just the right amount. Now, the T cells, which has both CD4 and CD8, they're also called double positive, they receive a survival signal. That is, any T cells which contains both CD4 and CD8 can move to the next process of selection, all right, and maturation. Now, if there are some T cells which have some kind of abnormal binding with CD4 and CD8, they undergo apoptosis and they're destroyed. All right. We do not want T cells which have abnormal CD4 and CD8 receptors, right? Do we want that? Now, let's talk about negative selection of T cells in the thymus. Now, the positive selection occurred in the cortex, right? In cortex, they received CD4 and CD8. Now, in the negative selection of T cells, what happens is there is a test which occurs to determine whether the T cells bind to self-antigens presented on MHC by thymic medullary cells. All right. Positive selection occurred in the cortex, negative selection occurs in the medulla. All right. Now, like I said earlier, MHC class 1 presents its antigen to CD8 and MHC class 2 presents its antigen to CD4. Now, in negative selection, what we are doing is we are presenting self-antigens, antigens which are present in our own cells, right? We are presenting these antigens to the CD4 and CD8 positive T cells. Now, if there is a binding of T cells with self-antigen, that's pretty bad, right? If that binding occurs and if these cells are released into the bloodstream, they will cause inflammation and immunologic reaction against our own body. All right, and we don't want that to happen. So, if there is binding of T cells with self-antigens in the medulla, these cells are again destroyed. All right. T cells that do not bind receive a survival signal, but T cells that bind to self antigens undergo apoptosis. I know this is complex. That's why I want to explain everything once again by describing it in a figure. All right? So here comes the immature thymocytes. All right? They do not have CD4, they do not have CD8. They are double negative, right? CD4 negative and CD8 negative. Now, in the thymic cortex, they receive both CD4 and CD8. So they are CD4 positive and CD8 positive. Now, like everything, there might be some kind of mishap in this process, right? And we do not want abnormal T cells to mature. So any T cells which does not have CD4 and CD8 are destroyed, and T cells which have both CD4 and CD8, or also called as double positive, they are selected for survival, and they go to the next step in the thymic medulla. In the thymic medulla, negative selection occurs. So, in negative selection, it ensures that thymus does not produce self-reactive T cells. Now, in the cortex, they received both CD4 and CD8. Now we know CD8 interacts with MHC1 and CD4 interacts with MHC2 for antigen presentation. Now, there are numerous millions of antigens in our body as well. Do we want a T cell which can interact with our own antigens? No, right? We don't want that. It will cause autoimmune diseases. All right? Now, in thymic medulla, any T cells which binds to our own self antigens, they are destroyed. Now let's talk about antigen-specific T cell activation. Now, as we discussed, dendritic cells, they phagocytose antigens in different tissue, right? Let's say, for example, the skin. Now, after they phagocytose the antigen, the dendritic cell then moves to the lymph node, all right, the draining lymph node. Now, in the lymph nodes, they interact with T cell. Now, let's look at this example where it's interacting with CD4 T cell. All right. So how do I know this is a CD4 T cell? Look at this, MHC2, right? MHC2 interacts with CD4 cell. Now, this is a naive T cell. That means it has not been activated. All right. So this antigen on the MHC2 receptor will interact with TCR, the T cell receptors in the CD4 T cell, right? Now, this interaction between MHC2 and TCR is not enough to activate a naive T cell, all right? We need something called a co-stimulatory signal. And this interaction between B7 and CD28 is called co-stimulatory signal. Now, this co-stimulatory signal helps to prevent unwanted T cell activation. For example, if there is a self-antigen and if there is presentation of self-antigen to a T cell, this alone will not activate T cell. Our body needs another co-stimulatory signal to activate the T cell, and this is the interaction between B7 and CD28. Now, after this interaction between the primary signal and the secondary signal, there'll be release of cytokines from the antigen presenting cell. Now, depending on the type of cytokine, there'll be activation of different kind of CD4 T cell, which we'll be talking about later. Now, let's look at what happens if there is activation of T cell without a co-stimulatory signal. Now, there are things called super antigens, all right? These antigens are unique because they link MHC2 antigen presenting cell and T cell receptor and cause activation of T cells without the co-stimulatory signal. This is why they are called super antigens. And a common example is toxic shock syndrome toxin. All right. Now, this will lead to a severe inflammatory reaction, which can cause shock. Now, let's look at how cytokines released from antigen presenting cell will cause differentiation of CD4 T cells. Now, I have included Th1, Th2, Th17, and T regulatory cell in this image, but you need to remember that T reg cell is not a type of T helper cell, all right? It is not a CD4 T cell, but there is a huge importance of T regulatory cell. That's why I have included this in the image. But there are mainly Th1, Th2, Th17, and follicular T cells, which are the main subtypes of CD4 cell. All right. Now, depending on the cytokines, If the cytokine released from antigen presenting cell is interferon gamma or interleukin 12, it will cause differentiation of CD4 cell into a Th1 subtype, all right? And this Th1 subtype will produce interferon gamma and TNF alpha. Now, this is really important. Now, from exam point of view, how they will ask a question is, in infection, macrophage and cytotoxic T cells were activated. Which of the following cytokines were released which induced the activation of macrophages and cytotoxic T cell? And in that situation, the right answer could be either interferon gamma or TNF alpha. So this is how the question will be asked. Now, this is a high yield table, all right? There's one more type of question they ask. There was activation of Th2 cell. Which of the following interleukins activated Th2 cell? Now, I'm oversimplifying the question, but you get what I'm trying to say, right? Now you need to know which cytokines activate these T helper subsets and what are the cytokines produced by the subsets itself and what is their function. All right, this is super high yield table and you need to memorize each and every interleukins. But we'll be talking about interleukins and their function in a separate video, but this is a gross overview. All right, so once Th1 cells are activated, they will release interferon gamma, TNF alpha, which will activate macrophages and cytotoxic T cells. And this is really important for granuloma formation. All right, macrophages play a huge role in producing granulomas. Let's talk about how Th2 cells are activated. If there is release of interleukin 2 and interleukin 4 from the antigen presenting cell, the CD4 cell will divide into Th2 subtype. All right. And what is the function of Th2 cell? It will secrete interleukin 4, interleukin 5, interleukin 9, and interleukin 13. Now, the role of these interleukin are to activate eosinophils and produce IgE. All right. So they help in IgE class switching. We'll be talking about class switching and immunoglobulins in a separate video, but you need to know what activates IgE formation, and it's interleukin 4, 5, 9, and 13. Now, like I said earlier, you also need to know what activated Th2 subtype. It's interleukin 2 and 4. Now, the mnemonic is 2 times 2 is 4, right? 2 times 2 is 4. So, interleukin 2 and 4 will activate Th2. Now, the mnemonic for Th1 is, if you notice, this interleukin 12 has a 1, right? So it will activate Th1. Now, let's look at what happens if interleukin 6, interleukin 23, and TGF beta are secreted from the antigen presenting cell. These interleukins will activate Th17 subtype of the CD4 cell. All right, so what is the function of Th17? It will secrete interleukin 17 and 22, which will induce neutrophilic infiltration. So their role is to induce neutrophil infiltration. Now the mnemonic for this is, if you subtract 6 from 23, you'll get 17, right? So interleukin 6 and 23 will activate Th17 subtype, all right? Now, the function of Treg is to maintain tolerance or maintain immune tolerance, all right? They prevent excessive activation of T cells. They downregulate the inflammation by suppressing the activation of T cell. And once an infection is controlled, once the body recognizes that the inflammation needs to be reduced, there'll be production of interleukin 10 and TGF beta, right? Now, this interleukin 10 and TGF beta will cause the Treg cell to be activated. And once Treg cell is activated, it will again produce interleukin 10 and TGF beta, which will cause positive feedback inhibition. Now, Treg cell will itself produce interleukin 10 and TGF beta, which will cause feedback loop, right? Positive feedback loop and help to maintain immune tolerance. This is really important for preventing autoimmunity, all right? If there is unwanted activation of T cell, body will try to produce interleukin 10 and TGF beta, which will try to downregulate the autoimmune response. Now, as I mentioned, cytotoxic T cells in this figure, let's talk about cytotoxic T cells. Now, the function of cytotoxic T cell after activation by Th1 cell is to cause apoptosis of virus-infected cell, neoplastic cell, and donor graft cells. They release cytotoxic granules containing perforin and granzymes, and they destroy these infected and abnormal cells. Now, like I said earlier, cytotoxic T cells are further activated by Th1 cells. All right. Now, as we talked briefly about regulatory T cell in the earlier slide, now let's talk about regulatory T cell in further detail. Like I said earlier, Treg cell maintains immune tolerance by suppressing T cells, right? They suppress CD4 and CD8 T cells. Now, how do you recognize regulatory T cells? They are recognized by expression of CD3, CD4, CD25, and FOXP3. So these FOXP3 and CD25 are unique to regulatory T cells. Now, activated regulatory T cells produce anti-inflammatory cytokines like interleukin 10 and TGF beta. So what happens if there's dysfunction of Treg cells? Mutation in FOXP3 leads to unregulated T cell activity, and it is associated with IPEX syndrome. The full form is immune dysregulation, polyendocrinopathy, enteropathy, and it's X-linked disease. All right. So, what are the clinical features of IPEX syndrome? It's endocrinopathy. That means there could be diabetes mellitus, hypothyroidism, and other endocrine diseases, right? The hallmark feature is enteropathy. In immune dysregulation caused by dysfunction of Treg cells, there'll be chronic diarrhea because of autoimmune enteritis. Now, besides endocrinopathy and enteropathy, you might see nail dystrophy and eczematous dermatitis. Now, if you perform a biopsy of the intestine, you might see lymphocyte infiltrate and atrophy of the intestine, right? Now, like I said earlier, as there'll be endocrinopathy, the presenting feature could be diabetes in infants. Now, as it is an X-linked disease, only males are affected, all right? Now, let's look at the activation of CD8 plus T cell. We have talked about CD8 plus T cell, which is also called cytotoxic T cell, numerous times in this video, but let's look at this image one more time to consolidate our concept. So the activation of CD plus T cell is exactly similar to CD4 T cell, but there's only one difference. Instead of MHC2 presenting the antigen to CD4, in CD8 T cells, the antigen will be presented by MHC1. All right, that is the only difference. The dendritic cells will present the antigen via MHC1. Let's talk about B cell formation. Unlike T cell, which was formed in the bone marrow and matured in the thymus, B cell formation and maturation occurs in the bone marrow itself. So once a mature B cell is formed, it will be called naive B cell. It's mature but naive. That means it has not been exposed to an antigen. Now, the unique thing about B cell is that it expresses CD19, CD20, CD21, and CD40 receptors. And they also express MHC2 and B7, all right? So the unique thing is CD19, 20, and 21. This is super high yield. In exams, sometimes they will not mention that the cell is B cell, but they will mention something like the cell is CD19 positive. And you have to understand that they are talking about B cell, all right? Now let's talk about B cell activation. Now, the unique thing about B cell is that it has an ability to endocytose an antigen and present that antigen via MHC molecule, MHC2 molecule to be precise, and activate follicular T cells. All right. Now, once antigen is presented by MHC2 to the follicular T cell will be activated. Now, it will release cytokines which will activate the B cell. All right. Let me repeat it one more time. B cell will endocytose an antigen and present that antigen on MHC2 molecule to the T cell receptors. These T cell receptors are in T follicular helper cells. All right. It's a type of CD4 positive T cell. Now, this presentation will activate follicular T cells. Now, once follicular helper T cells are activated, it will produce interleukin 4, 6, and interleukin 21. And these cytokines will activate B cell. Now, the interaction between MHC2 molecule and T cell receptors is not enough for activation of B cell. There must be interaction between CD40 ligand and CD40 receptor. After the activation of B cell by different interleukins like interleukin 4, 6, 21, and the interaction between different receptors like CD40 ligand and CD40, and the interaction between MHC2 and T cell receptor, B cell will be activated fully, right? And it will undergo proliferation. Now, B cells are activated and they produce IgM. This happens initially. The initial immunoglobulin which is produced by activated B cell is IgM. Now, depending on the cytokine produced, there'll be different type of class switching and production of different type of immunoglobulins like IgA, IgE, and IgG. And there'll be affinity maturation. Now, these topics can't be covered in this video, and we have a separate video for class switching and affinity maturation. Now, after the activation of B cell, there'll be production of two types of B cell, plasma cell and memory B cell. The function of plasma cell is to produce immunoglobulins, whereas the function of memory B cell is to recognize the specific antigen which triggered this particular B cell to recognize the antigen in the future as well. Now, if this antigen is exposed once again in our body, in the future, there'll be robust activation of B cell and there'll be quicker production of immunoglobulins. Now, time to do some USMLE style questions. So let's look at this question. A 1-year-old boy presented with a history of chronic diarrhea, failure to thrive, and recurrent pneumonia. Genetic testing reveals a mutation of a receptor on a lymphocytic cell. In order to activate this lymphocyte, APC presents antigen via MHC2. Further testing revealed that this lymphocyte is CD19 positive. Which of the following receptor is most likely mutated? Now, like I said earlier, this cell is CD19 positive. Now, if you remember what I told you, CD19 positive means this is a B cell, all right? Now, we talked about activation of B cell, right? Now, let's look at the option. CD40L means that it's a ligand, it's not a receptor. So we can rule that out because the question is asking which receptor is mutated. So it's definitely not A. Now, our options are CD40, CXCR4, and CD80, 86, right? Now, if you remember what I told you, the activation of B cell is dependent on interaction between CD40 ligand and CD40 receptor, right? So, in this question, there's mutation of CD40 receptor, which caused failure of activation of B cell. All right? Let's look at another question. Some scientists in a lab decided to prevent acidification of lysosomes within antigen-presenting cells in an experimental setting. The modified cells show impaired interaction with T lymphocytes when exposed to an antigen. The observed effect most likely results from a low surface expression of which of the following molecule? Is it MHC class 1 or MHC class 2, T cell receptors, or toll-like receptor? Now, if you read the question carefully, it says there is problem in acidification of the lysosome, right? The scientists, they prevented the acidification of lysosome. Now, if you remember from the video earlier, the acidification of lysosome is really important for MHC class 2. All right, so the answer is MHC class 2. Now let's look at the third question. A 2-year-old boy was diagnosed with type 1 diabetes mellitus 2 weeks back. He has also had chronic diarrhea, failure to thrive, dermatitis since infancy. Genetic testing reveals a missense mutation affecting FOXP3. Which of the following is most likely cause of this patient's condition? Now, we talked about this earlier, right? The mutation in FOXP3 will cause IPIC syndrome, and the patient has classic feature. The child is a boy, that is X-linked, right? The patient has type 1 diabetes mellitus, there's endocrinopathy, there's chronic diarrhea, which stands for the E, right? The E in the IPEX stands for enteropathy, and this patient has chronic diarrhea. And he also has dermatitis, which is a feature of IPEX. So this is a dysfunction of regulatory T cells. All right. Now let's look at the fourth question. A 9-year-old female child is brought to her pediatrician's office by her mother, who appears really anxious. The child has had a runny nose, sore throat, cough, low-grade fever of 100.2 degree Fahrenheit for the past 2 days. The doctor explained that these are features of a viral illness and reassured the mother. The doctor explained to a medical student who was listening that the cytotoxic CD8 plus lymphocytes are able to kill virus infected nasal epithelial cells, right? And these cytotoxic CD8 plus lymphocyte receptors recognize foreign proteins presented on epithelial cell surface by MHC molecule. These MHC molecules comprise of which of the following components? Now, this sounds like a tricky question, but it's pretty easy. Now, if you remember my mnemonic, MHC class 2 interacts with CD4, right? 4 times 2 is 8. Here in our question, the CD8 plus T cell are interacting with the MHC molecule. Now, 8 times 1 is 8. Our ultimate goal is to get the answer 8, right? In this question, the CD8 positive T cell will interact with MHC1, right? So this has to be MHC1. Now, is that knowledge enough to get this answer correct? No, because all the options have MHC class 1, right? So now you need to know the structure of MHC class 1. So let's look at the option MHC class 1 heavy chain and IgG, right? MHC class 1 heavy chain and beta 2 microglobulin, MHC class 1 heavy chain only, and MHC class 1 heavy chain and IgM. Now, if you remember what I've taught you so far, the components of MHC class 1 includes beta 2 microglobulin, all right? So the right answer is B, MHC class 1 heavy chain and beta 2 microglobulin, all right? So the right answer is MHC class 1 heavy chain and beta 2 microglobulin. Thank you. Hello everyone, I'm Dr. Ashish Kuragai and today we'll be talking about immunoglobulins. So let's get this started. So before we talk in detail about immunoglobulins, we need to understand their structure. This is one of the most important things for USMLE Step 1 exam, all right? The structure of the immunoglobulin. Now, the structure is divided into FC region and FAB region. So let's talk about the FC region first. Now, if you look, this is the FC region and this is the FAB region, all right? The FAB region is composed of the light chain and the heavy chain, whereas the FC region is only composed of the heavy chains. So this blue chain is the heavy chain, all right? The FC region is held together by these two disulfide bond which holds these two heavy chains, all right? And this holds the FC region together. Now, the FC region is composed of carbohydrate side chain. Although I have not shown the carbohydrate side chains, you need to understand that there are carbohydrate side chains in the structure, all right? Now, the most important thing that you'll be tested on your USMLE Step 1 is that the FC region determines the antibody isotype, all right? So whether an antibody is IgA, IgG, or IgM is determined by the FC region, and this is a high yield point. Similarly, the exam will test you on the function of the FC region. Now, the FC region binds to the complement, all right? Specifically, IgG and IgM. These are the two antibodies or immunoglobulins that binds with the complement. Now, just knowing this is not enough. You'll be tested on exam where will these complements bind. Now, they'll bind to this second portion, all right? They'll bind here. This is where the complements bind. Now, another question you'll be asked is where will the macrophage or the B cell attach to the antibody? And that's here. This is the third part, all right? The heavy chain part 3, all right? So this CH3, this is where the cell such as macrophages and B cells, they bind here, but the complements bind here. And this is a high yield point, all right? Another function of FC region is opsonization. Now you can understand that for opsonization to occur, the macrophages need to recognize the abnormal cell. So when these antibodies tag the abnormal cell, then phagocytosis can occur because the macrophages they can recognize that okay, I need to destroy this cell or I need to phagocytose this cell because this has been tagged by the IgG. All right, the opsonization occurs by IgG. Okay, so let's move on. Now let's look at FAB region. Now FAB region, we talked about it previously, FAB region is composed by the light chain and the heavy chain, but it has two portions. The variable region, all right, this is the variable region where the antigens bind. So these are the sites for antigen to bind, all right, and they undergo mutation and they change a lot. That's why they are called variable region. So this is the variable region of the FAB portion, and this is the constant. So each variable and the constant, they're composed by the light chain and the heavy chain. All right. So this is VL, variable composed by the light chain, and the variable region composed by the heavy chain. So this is the heavy chain. Now, another thing that you need to understand that this antibody that I have shown is attached to the B cell, all right? And each B cell can bind to only one specific antigen, all right? So only one type of antigen, all right? So only one type of antigen can bind to one B cell. That's a super high yield information that you need to understand. Now, we talked about this. One B cell binds to one unique antigen. This is super high yield, and I'm repeating it one more time, all right? So the FAB region determines the idiotype. Only one antigen can bind to this antibody, and only one antigen specificity is expressed per B cell. All right. So this is super high yield, and I've repeated it multiple times because this is super high yield for USMLE exams. All right. Now let's look at the function of immunoglobulins in detail. So one of the most important function of immunoglobulins is to neutralize the antigens. All right. Whenever a foreign antigen is exposed in our body, immunoglobulins bind to this and render it neutral. All right. They neutralize them. They render it ineffective. Now, another function of immunoglobulin is that it acts as an agonist or antagonist. So let me give you an example of myasthenia gravis. So in myasthenia gravis, there are immunoglobulins or antibodies against the ACH receptor, right? Against the acetylcholine receptor. So in myasthenia gravis, immunoglobulins act as antagonist. All right. Now let's look at more functions. Immunoglobulins activate the natural killer cells, and then natural killer cell destroy a abnormal cell by apoptosis. All right. So as you can see, when immunoglobulins bind to this abnormal cell, these abnormal cells can be recognized by the natural killer cells. The natural killer cells only recognize these abnormal cells when there are some kind of immunoglobulins. All right. Another function is opsonization. So we talked about opsonization earlier. Whenever an abnormal cell is tagged by immunoglobulins, specifically IgG. All right, IgG is the only immunoglobulin which acts as an opsonin. So when an abnormal cell is tagged by IgG, macrophages, they know that, okay, this is the abnormal one, I have to phagocytose them. All right. So another function is activation of complement. This is probably one of the most important and high yield topic that will be tested on USMLE Step 1. So they will ask you a lot of questions about activation of complement. So antigen antibody complex triggers the complement reaction, and ultimately there'll be formation of MAC complex and the cell will be destroyed. We'll be talking about this more detail in our complement system. All right. So these are highly tested in the immunology questions in USMLE Step 1. Activation of complement, opsonization, and activation of natural killer cells. Similarly, these are pretty high yield too, but these three are the most important. So now let's talk about B cell activation. So in order to talk about immunoglobulins, we must understand B cell activation. Now there are two mechanisms of B cell activation, T cell dependent and T cell independent. We'll be talking about T cell dependent activation in our B cell activation video, which is a separate video, but let's talk about it in briefly. So T cell activates the B cell after binding of these receptors. All right, CD40 ligand binds to the CD40. Similarly, the T cell receptor binds to the MHC class 2 all right, and this activates the B cell. But there's another mechanism of B cell activation, in which is direct antigen binding to this antibody, which is IgM. When antigen binds to this immunoglobulin IgM, B cell can be activated as well. So when B cell is activated by these mechanisms, there'll be B cell proliferation. But in this stage, the B cells can only produce IgM. All right, always remember, IgM is expressed on the B cell surface, which binds to the antigen, and B cell proliferation occurs. Now, B cell proliferation occurs and produce IgM against only this specific and particular antigen which activated it. All right. Then after B cell proliferation occurs, B cell will divide into plasma cells and memory B cells. So plasma cells produce the other immunoglobulins such as IgE, E, and G. So after the B cells are activated, they undergo something called class switching and affinity maturation. We'll be talking about it in detail. But if you remember, I mentioned that the FC region determines whether an immunoglobulin is IgA, E, M, or G, right? So when changes occur in the FC region, they convert into IgA or IgE or IgM. That's called class switching, all right? We're switching from IgM to IgG, IgA, and IgE, all right? That's class switching. We'll be talking about this in detail. So like I said, plasma cells produce these IgA, G, and E. Now, we've talked about this, right? The naive B cells prior to activation have only IgM. All right. Now, this is the most important thing that you need to know from USMLE point of view. What triggers the isotype switching? Either the cytokines such as interleukin 4, 6, 21, or the CD4TL. All right. These are the triggers for isotype switching. Now let's talk about generation of antibody specificity. Now this concept is highly tested on the USMLE Step 1. So what you need to understand is when B cells are activated, these IgM have low affinity. All right, they have low affinity to the antigen. Now, once the B cell is activated, there'll be somatic mutation in this variable region of the antibody binding site, all right, in the FAB region, specifically in this variable portion, there'll be different mutations. Now, these mutations will cause the antibody to be more specific towards that one particular antigen. So, as the mutation helps the antibody to become more specific, it starts producing high affinity antibody. We call it high affinity antibody because it's more specific. It can bind to these antigens more specifically, all right? Now, this process of generation of antibody specificity is dependent on the antigen, all right? This is an antigen dependent process and it occurs by hypermutation. Hypermutation and affinity maturation. So, what is affinity maturation? So, this process of producing high affinity antibody from this low affinity antibody after going multiple mutations is called somatic hypermutation and affinity maturation. All right. Now, these alterations occur only in the variable region. That's why they are called variable region. These changes do not occur in the constant part of the FAB region. All right. Only in the variable region. Okay. Now, let's look at generation of antibody diversity. All right. So we talked about antibody specificity. Now let's talk how diverse group of antibodies are produced. Now this is a pretty difficult topic. Now I have only shown the genes in the heavy chain, and these genes are the V, D, and G gene. So these three, the interaction between these three genes produces antibody diversity. So this C gene that you can see here determines the immunoglobulin type. So although I have not shown here, there are genes such as CM, C epsilon, C gamma, C alpha, and these determine the immunoglobulin type. All right. So if there is a CM, then the antibody will be IgM. If there is C alpha, it will be IgA, so forth and so on. All right. So this is how the FC region changes based on this C or the constant gene. All right. Now, V is the variable gene, this is the diversity gene, and this is the joining gene. All right. So the interaction between these genes are going to produce hundreds and millions of types of different antibody. All right. So let's take an example. So here we remove the unwanted D and let's say J segment. So let's say in order to produce a typical type of antibody, we need 4V genes and let's say these 2D genes and let's say this J gene. All right. So we remove the unwanted gene. All right. So here we remove the unwanted portion. So after removing this, we recombine them. All right. Then again, we removed some unwanted V and D segments. So finally, we join all these remaining genes and we form a constant domain gene. All right. So after removing all these unwanted genes, we finally come up with this sequence. All right. And this will produce a specific type of antibody. And like I said, this antibody will also include constant domain gene. And the constant domain gene will determine the antibody type. All right. Whether it's IgG, IgM, IgA, or IgE will be determined by the constant gene. Okay. So this recombination is triggered by the RAG protein. All right. The RAG gene produces RAG protein 1 and 2, and it will produce this enzyme called VDJ recombinase. And this is what triggers this VDJ recombination, right? You can see that there is a lot of recombination going on, and that is done by VDJ recombination. And this RAG protein 1 and 2 combine to form this enzyme. This is super high yield. This RAG gene and RAG protein, these are super high yield from USMLE Step 1 point of view. The alteration or any kind of mutation in the RAG gene will produce severe combined immunodeficiency disease, all right, the SCID. So the mutation in this gene will cause immunodeficiency, and this is super high yield. So the random combination of certain gene during B cell maturation in bone marrow will produce the diversity, all right. So the light chain V and G genes, heavy chain V, D, and G genes. These are super high yield things. All right, you need to remember these things. Now, random recombination of light chain with heavy chain will produce further diversity. All right, now let's look at the clinical significance. We have already talked about it. All right, the autosomal recessive mutation, the loss of function mutation, cause a rare type of severe combined immunodeficiency. Super high yield from USMLE Step 1 point of view. So let's talk about IgG antibody. So this is an IgG antibody, all right? So from exam point of view, you need to understand that this is the antibody which will be produced in second exposure to the same antigen, all right? The first exposure produces IgM, and when there's affinity maturation, somatic hypermutation, class switching, there'll be specific IgG antibody against that particular antigen. But it's produced in the secondary response, not the primary response. The primary response produces IgM, all right? Now, this is the most abundant isotype in the blood. It activates complement and opsonization. We have talked about it earlier. All right. The IgG activates the complement and opsonization is done by IgG. These are super high yield from USMLE Step 1. You'll get numerous questions on these two functions. All right. And it also neutralizes the toxins and viruses. You might be wondering how it inactivates the toxins. So toxins are a type of antigens, right? So toxins bind to this antibody by binding to this antigen binding site. All right, the toxins can bind to these site, and when multiple IgG cover the toxin, it will be neutralized. Okay, now let's talk about another high yield point which will be tested on USMLE. IgG is the only isotype that crosses the placenta, all right? And this provides passive immunity for the child for up to 6 months. Now, this is super high yield. This is important because sometimes, even if the child has immunodeficiency, it won't present in the first 6 months because the child will be protected from the mother's IgG antibody, all right? And another high yield point that you need to know is IgG antibodies form against the Rh factor, against the rhesus factor, whereas IgM antibodies form against the ABO antigens. All right. So that's why when there is a Rh mismatch between mother and child, there'll be a severe hemolytic anemia in the child. But usually, EBO mismatch does not cause as severe reaction, hemolytic reaction, because IgM antibody cannot cross the placenta, but IgG antibody can cross the placenta. Another high yield point you need to remember is that IgG antibodies are associated with warm autoimmune hemolytic anemia. All right, remember, warm is good. All right, and G stands for good. So, warm is good. Now, let's talk about IgM antibody. So IgM antibody exists in monomer form when it's attached to the B cell, but when it's in the blood, it exists as a pentamer. All right. Now, IgM antibodies are the most important antibody which will be produced in the primary response against a bacteria or virus. All right. And it's the largest antibody. Among the subtypes, it's the largest. Now, the function of IgM is to activate the complement. All right. The IgG and IgM, these two are the antibodies that activates the complement. All right. So the pentamer structure of the antibody helps to bind to an antigen more avidly. All right. So let's look at this antigen. All right. Let's say this is a large antigen. Then the structure of IgM in the pentamer form helps to bind against this antigen more avidly compared to, let's say, the monomer form, or let's say the IgG antibody. All right, there are more binding sites. Let's say the antigen binds to this antibody here, here, also here, and here. All right, so there's more avid binding. Similarly, IgM antibody is associated with EBO blood group. All right. Whenever a person produces antibody against E antigen or B antigen of the RBC, it's the IgM that's produced. All right. So IgG will be produced against the Rh factor, but IgM will be produced against the ABO. All right. Similarly, IgM is associated with cold autoimmune hemolytic anemia, whereas IgG was associated with warm. All right. So remember my mnemonic. Warm is good. All right. Cold, not so much. All right. So IgM is associated with cold autoimmune hemolytic anemia. This is really high yield from exam point of view. So for USMLE step 1, you need to remember these clinical significance, all right? Complement activation, avid binding, associated with cold autoimmune hemolytic anemia, and this, all right? These are super high yield for exam. So let's talk about IgA. Now, IgA is the most abundant immunoglobulin in the body, but its concentration is pretty low in blood. So where does IgA go? So IgA exists in the secretions of the body, all right? So IgA is highly concentrated in the saliva, all right, or the GI secretions, all right? So now let's talk, how does the IgA antibody reach to these secretions from the blood, all right? And this is super high yield for USMLE step 1. So it uses transcytosis to cross the epithelial borders. So let's look at it. So this is how transcytosis occurs. So the IgA is endocytosed, all right, endocytosis occurs, and it is then released to the lumen, all right. So this is how transcytosis occurs. This is really important question for USMLE step 1. Now, IgA exists as a monomer when it's in the blood, but when it's in the secretion, it exists in the dimer form. All right, IgA is a dimer in the secretion. Now, we talked about how IgA is found on the mucosal surfaces and the secretions. All right, it's not present in the blood. It's released into the bodily fluids such as saliva, mucus, tears, and the breast milk. So, what do you think is the function of IgA in these secretion? It prevents the attachment of bacteria and viruses to the mucous membrane. All right, so the first step of invasion is prevented by the IgA, the attachment. IgA blocks the attachment. Unlike IgG and IgM, IgA has no role in complement fixation, all right? It does not activate the complement. Now let's talk about IgE. Now, whenever you hear about IgE, you have to think about type 1 hypersensitivity, all right? This is super high yield. This is the most important thing you need to know about IgE antibody. Now, IgE antibody normally binds to the mast cells, and when it is exposed to the antigen, degranulation occurs and type 1 hypersensitivity occurs. So we'll be talking about this in much detail in our hypersensitivity video, all right? Another super high yield point from USMLE step 1 is this. So it induces eosinophils to act against the parasites. All right, this is super high yield. And IgE also binds to the basophils. All right, so the way a question is asked is a patient has diarrhea and abdominal pain for really long time. All right, and when blood investigation was done, eosinophils were increased and IgE level were increased in the body. So whenever you get such question, you have to think that, okay, there must be a parasitic infestation in the GI tract, which is causing this abdominal pain. All right. So this is how the question comes up. Whenever you see increased IgE and increased eosinophils, you have to think about parasites, super high yield. Now let's do a USMLE style question. So let's look at this. A 23-year-old male presented to your office with complaints of sore throat, fever for 3 days. On examination, his tonsils are erythematous and exudative. All right. So this looks like a bacterial infection. The patient has fever and the tonsils are exudative. All right. So this looks like a bacterial infection. There's no lymphadenopathy. Other studies are normal. Rapid antigen test for Streptococcus pyogenes is positive. Macrophages opsonize this bacteria and the inflammation is mediated by complement activation. Which of the following site on the immunoglobulin does the complement attach? Now, I talked about this in the earlier part of the video. So let's see where the complement attaches. Is it A, B, C, or D? So what is the right answer? If you choose option C, then you're correct. So this is where the complements bind in the FC region. All right, super high yield. I hope you enjoyed this video. Thank you. Hello everyone, I'm Dr. Ashish Guragai and today we'll be studying about complement system and its disorders. So let's get it started. So what are complement proteins? So they're nothing but plasma proteins which are formed by the liver and they play an important role in the innate immunity of our body and they play a significant role in causing inflammation. So I know that a lot of students have a huge fear when they study complement system because it it's kind of intimidating, right? The entire cascade of reaction, it looks intimidating. But my job today is to teach you in such a way that you can simplify the entire complement system and just focus on the exams, right? You don't need to know the entire complement system by heart to get a really good score in exam. We just need to focus on the stuff that is asked in the exam. So I'll be teaching you about that. So the most important fact that USMLE exam wants you to know is that there'll be a cascade of reactions, right, in the complement system, which ultimately forms a membrane attack complex. Now, this MAC is really important in defending our body against gram-negative bacteria. Now, this is high-yield information. This is what USMLE exams want you to know, right? The entire function of complement system is to ultimately form a membrane attack complex which destroys specifically gram-negative bacteria. So there are three main pathways which activates the complement system. So let's study each of them. So the first one is classic. It's called the classic pathway because it was first discovered, right? So what activates the classic pathway? It's the antigen antibody complexes which activates the classic pathway. Now, antigen antibody complexes are formed when IgG or IgM antibody binds to their specific antigen. All right. So you need to know that it's the IgG or IgM, not other antibodies, only these two, which activates the classic pathway. Why? Because these are the antibodies which usually form the antigen antibody complexes. All right. So the classic pathway is IgG or IgM mediated. Now, there's a mnemonic. GM makes classic cars. All right. This is a really famous mnemonic for the classic pathway. And the G stands for IgG and M stands for IgM and classic cars stands for the classic pathway. All right. So let's look at another pathway. It's called the alternative pathway. Now, unlike the classic pathway, which was activated by IgM or IgG, alternative pathways are activated by the surface molecules of the microorganism. Now, there's one more pathway which is called the lectin pathway. Now, unlike the classic and alternative pathway, this pathway is activated by sugars, mainly mannose. All right, these sugars are present on the surface of microbe. Now, I have a mnemonic for this, licking the sugar. All right, so licking sounds kind of like lectin, and sugar represents the mannose or other sugar on the surface of the microbe. Now let's look at the pathways. I know this looks a bit intimidating, but if you understand the simple concept of all these pathways, this will be much more simpler than it looks. So in order to make it simple, just remember that the end goal of all the pathways, whether it's alternative pathway, classical pathway, or lectin pathway, the ultimate goal is the formation of the C5 convertase. Did you notice that all the pathways, they end up forming the C5 convertase, all right? So just remember, the ultimate goal is to form C5 convertase. And the middle step is also common between all the pathways, which is the formation of C3 convertase. It's only the triggering point or the trigger which initiates these pathway, that's the difference, all right? So let's start with classical pathway. Now, like I said earlier, classical pathway is triggered by the antigen or the surface antigen present in the microbes. All right. So IgG antibody attacks these antigens. Now, this forms antigen antibody complex. And this antigen antibody complex will trigger the complement reaction. Now, C1 complement will bind to these antigen antibody complex, which will initiate the classical complement pathway. Now, this C1 complement protein will cleave C4 complement protein. All right, that's the keyword, cleave. Now, the cleavage of C4 complement protein will form C4a and C4b. Now, I have not mentioned about C4a in this image because it will just complicate the things, right? For the time being, just remember all the complement proteins, when they cleave, they form a and B. For example, if C2 is cleaved, it forms C2A and C2B. And if C4 is cleaved, it will form C4A and C4B. So this C1 complement will cleave C4 as well as C2 complement protein. And the products C4B and C2A will combine to form C3 convertase. All right. This combination of C4B and C2A is called C3 convertase. Now, this C3 convertase, like its name suggests, will convert C3 into C3A and C3B. All right, so this complex C3 convertase will cleave C3 complement protein into C3A and C3B. Now, again, this C3B will combine with C4B, C2A to form C5 convertase. Now, like the name suggests, it will convert C5 into C5A and C5B. All right. Now, these steps are common in all the pathways. The ultimate goal is to form C5A and C5B, and you'll understand why the formation of C5B is so important. Now, let's look at alternative pathway. So unlike classic pathway, it is activated by these surface molecules on the microbe. Now let's look at it. Here, the C3 complement protein is cleaved into C3b and C3a. C3b binds with factor B to form a complex called C3bb. All right, I know it sounds funny, but just remember that factor B combines with C3b to form C3 convertase. All right, just remember this. This is called C3 convertase. Now, you might be confused. Hey, you just said that C3 convertase is C4b, C2a, but you need to remember that there are two kinds of C3 convertase. All right, I know this sounds confusing, but just remember the main goal of all the pathway is to form C3 convertase, then form C5 convertase, and ultimately cleave the C5 complement protein. All right. So now in this pathway, C3 convertase is this molecule. All right. C3b, factor B cleaved into smaller proteins. All right. So C3b, BB. Now, cleavage of C3 by C3 convertase. Now, this is the common thing which is happening in all the pathways. All right, this happens in all the pathways. Now, similar to classic pathway, C3 is broken down into C3A and C3B. Now, C3B combines with this, right, with C3 convertase to form C5 convertase. All right, so it will cleave C5 into C5A and C5B. Now, I think you have seen the similar pattern in alternative pathway and classical pathway, right? It sounds intimidating, it looks intimidating, but if you simplify it, complement pathway can be really simple. All right, now let's look at lectin pathway. Now, unlike classical pathway and alternative pathway, this pathway is activated by the sugars, right? Remember the mannose. Now, similar to classic pathway, here C4 and C2 are cleaved into C4A, C4B, and C2A and C2B. Now, C4B and C2A form C3 convertase. Now, I'm pretty sure now you're comfortable with this, right? So C3 convertase cleaves C3 into C3B and C3A. Again, the same thing. C5 convertase is formed and C5 is cleaved. All right. So C5 is cleaved into C5A and C5B. Now what? Right? So what was the role of cleaving C5? So the main role is to form membrane attack complex. All right? Remember what I said earlier. The entire USMLE test, the most important thing they want you to know is that complement pathways form membrane attack complex. All right? So that's the basic thing happening in all the pathways. Now, C5A also has its important role, right? It acts as an anaphylotoxin, but I'll be talking about this later. Here, the most important thing is C5B, all right? Now, this C5B combines with factor C6, 7, 8, and 9 to form membrane attack complex. Now, this MAC induces lysis of the target cell. Now, what are the function of major complement proteins, right? We studied about so many different complement proteins, C3A, C3B, C4, C5, right? It's kind of intimidating, but everything has its own function, all right? Let me simplify it. Now, C3B, all right, its most important role is opsonization. Now, this is kind of silly mnemonic, but it works. All right. So this B, if you flip it, it kind of looks like a P. All right. So C3B has a role in opsonization. So opsonization is nothing but coating of an abnormal cell. All right. So it just tags it. And then neutrophils and macrophages, they know which cell to phagocytose. All right. So they're just like markers for phagocytosis. Whenever a cell is coated with this C3b, macrophages and neutrophils, they know, okay, this is the abnormal cell, we need to phagocytose it. That's it. That's opsonization. Now, besides opsonization, C3b has some other really important functions. All right. Now, everyone remembers opsonization, but students tend to forget that C3b has a really important role in immune complex transport and clearance. Now, this is really high yield for exam, all right? You need to know that C3b has a role in clearance of the immune complexes and transport of the immune complexes which are formed in the body in various infection or, you know, whenever a immune complex is formed, it triggers inflammation, right? So you need to stop it, right? After its job is done, it needs to be cleared. Now, that clearance is done by C3b. Now, besides that, it also promotes cleavage of cofactors C3b and C4b. So, C3b cleaves itself and C4b. Now, this cleavage of this C3b and C4b blocks the formation of C3 convertase, right? So why do we need to block the formation of C3 convertase? So we need to stop this chain of reaction which we studied just now, right? After the inflammation is over, after the infection is, handled by the immune system, we need the complement system to stop. We cannot let it run continuously, all right? So it needs to be stopped, and that is done by C3b. Now there are other complement proteins like C3a, C4a, and C5a. Now, if you noticed it, I've highlighted all the A's, right? And they're really important for anaphylaxis because these three are called anaphylotoxins because they have a huge role in causing anaphylactic reactions, all right? Now, C5a, besides being an aflatoxin, has one more function, which is neutrophil chemotaxis. All right. Now, these are high yield information for your exam because they do not expect you to memorize the entire complement pathway. They do not expect you to know each and every cascade of reaction. But the test makers really expect you to know the role of complement proteins. So, for example, they'll give you a question on anaphylactic reaction after, let's say, taking penicillin, all right? And then they will, give you all the clinical features of anaphylaxis and they will ask you which of the following complement proteins triggered this, right? And they'll give you C3b, C3a, C5b, stuff like that. And you have to choose C3a. Now, we have talked about MAC already, but I cannot emphasize its importance again. All right. So C5b2 C9 is called MAC, membrane attack complex, and it causes cytolysis. All right. Now I have a mnemonic. Use your MAC from 9 to 5. All right. So remember, it's the complement from C5b, C6, 7, 8, and 9. All right. So these complements together, they are called a MAC. Now, some high yield information. So we learned that C3b has a really important role in opsonization, right? But there's one more, which has a really important role in opsonization, and that molecule is IgG, all right? So C3b and IgG, they cause opsonization, and that's why they are called opsonins. Now, another high yield information and really important point from exam point of view is this CH50 test and AH50 test. Now, I know it looks confusing, but CH50 test is used to screen for classical, right? That's why this is CH50, right? This tests for classical pathway. And AH50 test, if you can guess it, it would be amazing. So was your guess alternative pathway? If If your guess was alternative pathway, then you're right. So AH50 test is used to screen for alternative pathway. All right. So if these tests are positive, we can say that the pathways are activated. All right. So if CH50 test is positive, we can say that, okay, classical pathway is activated. If AH50 test is activated, then we can say, okay, the alternative pathway has been activated. All right. Now, another high yield information for this neutrophil chemotaxis. We learned that C5a is a potent neutrophil chemotactic agent, but there are some more. From exam point of view, this is super high yield, right? So the exam loves to ask this question: which of the following molecules triggered the neutrophils to come to the site of inflammation? Which of the following molecule caused the neutrophil chemotaxis? So we learned about C5a. Another is interleukin 8, leukotriene B4, 5-HETE, which is a leukotriene precursor, kallikrein, platelet activating factor, and N-formyl methionine. All right. So these are neutrophil chemotactic agents. Super high yield from exam point of view. The USMLE loves to ask this question. Which of the following molecules invited, right, invited the neutrophil into this inflammation? Now, let's look at this image. So I'll be briefly summarizing whatever I've said. So antigen antibody complex is formed, right? Complement pathway is activated. C5a is formed, which is a chemotactic agent, invites the neutrophil, right? It calls the neutrophil into the site of inflammation. Then neutrophil releases this reactive oxygen species and destroys the cells, right? Again, antigen antibody complex ultimately leads to formation of MAC, all right, cell lysis. So this is a quick summary of what we have just studied and a visual representation of what's happening. Now, this is what opsonization means, right? So these C3b molecules tag this abnormal cell, right? So there it is. They're tagging that this is the abnormal cell. Then macrophage recognizes, okay, this looks like an abnormal cell. There is a tagging of C3b, so I need to destroy this. We have studied about complement system activation, but we also need to know what prevents complement system from being activated when it's not needed, when it's not wanted, right? So there are molecules called decay accelerating factor, DAF, also known as CD55, and C1 esterase inhibitor, right? So these two prevent complement system from being activated when they're not needed. Now, I'll be talking about these two in detail later on, but before that, let's start with complement disorders. All right. Now, let's start with complement protein deficiencies. Now, there are mainly two types. The first one is early complement deficiencies. Now, the word early complement means that there'll be deficiency of early complement proteins like C1, C2, C3, and C4. If you remember the pathways that I taught, these four molecules or these four proteins were the first one to be cleaved, right? Remember, that's why they're called early complements. Now, if these complements are deficient, there'll be severe recurrent pyogenic sinus and respiratory tract infection. Now, you might be wondering why, right? Now, if you remember what I have taught, these complement proteins cleave into active complements, right? Which triggers a chain of reaction. And that chain of reaction forms different other complement proteins and ultimately forms membrane attack complex. Now, if these proteins are deficient, there won't be formation of these active complements. Let's take example of C3b, right? If there's no C3b, do you think it can tag bacteria and abnormal cells so that the macrophage can phagocytose it? It cannot, right? So that's one example how early complement deficiency will cause infection. Now, if you remember classic pathway, the first step which occurred was C1 causing the cleavage of C4 and C2. Now, if these early complement proteins are absent, do you think the classic pathway will, go on? No, right? That pathway won't go on, right? The chain of reaction won't occur. So there won't be inflammation. There won't be destruction of the bacteria by neutrophils. Why? Because neutrophils need chemotactic agents like C5a, right? So that's how early complement deficiencies will cause severe infection. Now, there's one more function of C3b besides opsonization, and that is clearance of antigen antibody complexes. Now, if there's no C3b, we cannot clear the antigen antibody complexes formed after an infection, right? So if these antigen antibody complexes are not cleared, they will deposit in different tissue and increase the risk of SLE, right? So the mnemonic is sleep early, right? This SLE in sleep represents SLE, and early represents the early complement deficiency. So it's really important for you to remember that early complement deficiency increases the risk of SLE. Now, this is really important from exam point of view because the examiners love to ask you about these kind of associations. All right. Now, terminal complement deficiencies. Unlike early complement deficiencies, in terminal complement deficiency, there'll be deficiency of C5, C6, 7, 8, and C9 complement proteins. Now, if you remember, these are the main components of MAC, right? C5b to C9. That forms membrane attack complex. Now, if you remember, I told you that the main function of membrane attack complex, or MAC, is to destroy gram-negative bacteria. And the high-yield information is that terminal complement deficiency will prevent this destruction of the gram-negative bacteria, especially the Neisseria infection, right? So if there is no formation of MAC, we cannot destroy Neisseria, right? And these patients are highly susceptible to recurrent Neisseria meningitis, Neisseria gonorrhea, right? So this is how the examiners are going to ask you a question, right? Let's say they'll say, okay, there's a 10-year-old boy who has had 10 episodes of meningitis, and each time there was isolation of Neisseria meningitis. Now, they might trick you with other congenital immunodeficiencies, but here the classic hint is there'll be recurrent infection of only Neisseria meningitis. All right. If there's other immunodeficiencies, there'll be deficiency of B cell or T cell, and there'll be viral infections, bacterial infections, sinopulmonary infection, right? But there won't be recurrent Neisseria infection. So this is high yield information. Terminal complement deficiency will cause recurrent Neisseria infection. All right. Now let's talk about complement regulatory protein deficiencies. And the first one we'll be talking about is C1 esterase inhibitor deficiency. Now, before we talk about the deficiency, first I want you to know the main function of C1 esterase inhibitor. All right. So its first function is to regulate the classic complement pathway. All right. It prevents its unregulated activation. So that's the first function of C1 esterase inhibitor. All right, it regulates the complement pathway, mainly the classic pathway. And the second function is that it regulates the formation of kallikrein. All right, it prevents excessive formation of kallikrein by preventing prekallikrein converting into kallikrein. All right, so it stops that process. Now, just look at what will happen if there's deficiency of this enzyme. Number one, there'll be excess unregulated activation of kallikrein, all right, which will cause angioedema. Now you need to understand how activation of kallikrein will cause angioedema. But in order to understand that, you need to know the function of kallikrein. So what it does is it converts high molecular weight kininogen into bradykinin. All right. And this increased bradykinin will cause vasodilation, which will result. So the C1 esterase inhibitor deficiency is autosomal dominant in inheritance, and it will cause hereditary angioedema. All right. And it is characterized by decreased C4 levels. Now, you might be wondering how it will cause decreased levels of C4. If you remember what I said earlier, the normal function of C1 esterase inhibitor is to regulate complement pathway. If complement pathway is not regulated, there'll be excess cleavage of C4, which will cause decreased C4 levels. All right. Now, this is what angioedema looks like. All right. Now, another thing that you need to know is in patients who have C1 esterase inhibitor deficiency, ACE inhibitors are contraindicated. Now, this is super high yield from exam point of view. All right. So you need to really understand why this happens. Now, one of the side effects of ACE inhibitors is that it causes excess bradykinin. All right. Now, in patients who have C1 esterase inhibitor deficiency, they already have excess bradykinin. Now, if you prescribe ACE inhibitors to these patients, there'll be further increase in bradykinin, which will, you know, cause severe angioedema. All right. So in these patients, ACE inhibitors are contraindicated, and this is really high yield point from exam point of view. Examiners love to ask you about this question. Now let's talk about paroxysmal nocturnal hemoglobinuria. Now, this is a super high yield topic from exam point of view. All right. Examiners love to ask this question as well. Now, in this disease, there's a defect in PIGA gene which prevents the formation of glycosyl phosphatidyl inositol, GPI, anchors for complement inhibitors. So this GPI is an anchor for complement inhibitors such as decay accelerating factor, DAF, which is also known as CD55. Remember what I taught you earlier? C1 esterase inhibitors, DAF, they function to regulate the complement system, all right? They inhibit unwanted activation of complement system. So, like DAF, there's one more inhibitor, which is called membrane inhibitor of reactive lysis, MIRL, or CD59. Now, what GPI anchors does is it holds this inhibitors, all right, which are present in RBCs. Now, just imagine this defect in formation of anchor, which was holding the inhibitors of complement system, such as CD55 and CD59. Now, if there's defect in the anchor itself, do you think the anchor will be able to hold the inhibitors? No, right? So anchors are defective. It cannot hold the inhibitors. The inhibitors cannot function. All right. So this will prevent inhibition of complement activation against RBCs. So if there is unwanted complement activation against RBC, what do you think will happen? There'll be lysis. All right. There'll be complement mediated intravascular hemolysis. All right. Which will cause definitely decreased haptoglobin and dark urine. Right. These are expected findings from hemolysis. The destruction of RBC, it will cause release of hemoglobin, right? Hemoglobin binds to haptoglobin, so there'll be decreased haptoglobin. And why will there be dark urine? Because hemoglobin is a pigment, right? When it's excreted from the urine, it's going to cause dark urine. All right. Now, one more thing that paroxysmal nocturnal hemoglobinuria will cause is atypical venous thrombosis. All right, that's the key word, atypical venous thrombosis. Now, examiners love this part. All right, so this is how they will ask you a question. They'll say there's a 24-year-old lady who has Budd-Chiari syndrome, and she has a history of portal vein thrombosis, and she has multiple episodes of dark urine. You know, they will give you a scenario similar to this, right? Now, this is really unique, all right? Having multiple atypical venous thrombosis is a classical features of paroxysmal nocturnal hemoglobinuria. Combined with episodic dark urine, this will just confirm the diagnosis. So this is how the examiners will ask you question, all right? Now, what will be the findings in paroxysmal nocturnal hemoglobinuria? Anemia, right? That's expected. Thrombocytopenia, pancytopenia, and there'll be increased reticulocytes. Reticulocytes are increased because there's excessive hemolysis. Now, why do you think there'll be thrombocytopenia and pancytopenia? For the same reason, there's anemia, right? This excessive formation of complement pathway will trigger excess formation of membrane attack complex. There'll be inflammation, there'll be destruction of platelets, neutrophils, macrophages, all right? So there'll be pancytopenia. Now, in hemolysis workup, like I explained earlier, there'll be haptoglobin. Why? Because haptoglobin will bind to the free hemoglobin, which is released after the lysis. So there'll be decreased haptoglobin, there'll be hemosiderin there'll be hemoglobin. All right? Now, do you think the Coombs test is going to be positive here? No, because this is not an immune-mediated lysis of the RBC. This is complement-mediated lysis of the RBC. So the direct Coombs test is going to be negative. Now, how do we confirm the diagnosis? If we do a flow cytometry, there'll be deficiency of DAF and MIRL protein. All right, so that's how we can confirm. Now let's deal with some USMLE style questions. So let's look at this. 44-year-old female presented to emergency room due to sudden onset facial swelling 1 hour back. She has no itching or pain. All right, this information is really important. She has no itching. She was diagnosed with otitis media, for which she is taking amoxicillin. The patient has had similar episodes of facial swelling that resolved spontaneously after a few days, which is happening from childhood. All right. Vitals are normal. Examination shows non-pitting edema of lips and tongue. There's no tenderness. Which of the following lab values will be abnormal? Now, this question is trying really hard to trick you with anaphylactic reaction. All right. She recently started amoxicillin. So, you might be thinking, okay, this could be anaphylactic reaction. But you need to notice that she has no itching. Now, if there's anaphylactic reaction, there'll be severe itching. But the unique thing about this disease that you'll be diagnosing does not have itching. All right, so let's look at the options. Let's look at the option first. Serum tryptase level, serum Ig level, serum C3a level, serum C4a level. Sorry, serum C4 level. So what do you think is the right answer? Is it anaphylactic reaction or is it something else? So if you're thinking about anaphylactic reaction, like I said earlier, there is no itching. All right, that's a key thing. This is not anaphylactic reaction. All right, so this is angioedema. If you notice, there's a key information in her past history as well. She has had similar episodes of facial swelling which resolved spontaneously, and this has been happening since her childhood. All right. Now, another key information is that there's no itching. So these two information helps us to rule out anaphylactic reaction. So the right answer is not tryptase, it's not IgE. The right answer is serum C4 level. All right. Now let's look at another question. A 7-year-old girl is brought to the clinic after developing fever and sore throat. Physical examination shows exudative inflammation of pharynx and cervical lymphadenopathy. Rapid antigen test is positive for strep pyogenes. Antibiotics are prescribed and she feels better, right? Now, 2 months later, she develops similar symptoms and strep test is positive again. This time, which of the following facilitates phagocytosis of the bacteria? Let's look at the option. Is it C3A, IgM, IgG and C3A, IgM and C3b? Or is it IgG and C3b? So what do you think is the right answer? Now, you need to understand what's happening in this question. What are they trying to tell you? So the patient first had a bacterial infection, right? It got resolved. Now, second time when there's a similar infection, IgG antibodies are excessively present in the blood, right? These memory cells, they can produce specific antibodies against strep pyogenes. So whenever an infection occurs second time, instead of IgM antibody being the predominant antibody, IgG is going to be the predominant antibody. All right, that's one more thing that you need to understand. Now, besides this information, you need to understand What facilitates phagocytosis? Now, I have mentioned this multiple times in this topic today. Opsonin helps in phagocytosis, right? Opsonins like IgG and C3p, they coat the bacteria, which will help the macrophages to identify which cell needs to be phagocytosed. Now, the question is asking which of the following facilitates phagocytosis? Now, the right answer is IgG and C3p. Now, the reason I explained a bit more about IgM and IgG antibody is sometimes in exam you might forget whether IgM is the opsonin or whether IgG is the opsonin. In that case, if you know which antibody is predominant in second infection or the reinfection with the same bacteria, it might help you further narrow down the options. All right. So it's not IgM, it's IgG. All right. IgG is the predominant antibody which will be produced during the reinfection. This information should help you further to choose the right answer. So the right answer is IgG and C3b. I want to repeat this one more time. The opsonins which help facilitate phagocytosis are IgG and C3b. All right, I hope this lecture was really helpful for you. Thank you. Hello everyone, I'm Dr. Ashish Guragai and today we'll be studying about cytokines. So before we talk about types of cytokines, let's understand what cytokines are. So cytokines are signaling proteins which modulate the immune response, inflammation, hematopoietic cell proliferation, and differentiation. So cytokines are nothing but simple proteins which modulates the functions that I just described: immune response, inflammation, hematopoietic cell proliferation, and differentiation. So let's look at the types of cytokine. There are interleukins, chemokines, monokines, and lymphokines. But from exam point of view, interleukins and chemokines are the most high yield for USMLE Step 1. So we'll be talking about these two in detail. So let's look at some of the interleukins and chemokines secreted by the macrophages. The most important interleukin secreted by macrophages is interleukin 1. Now, this is really high yield from exam point of view. All right, they love to ask you about interleukin 1 as it causes fever, vasodilation, and inflammation. Now, we get fever in hundreds of disease, right? There are thousands of conditions which cause inflammation. So, the way they ask the question is a patient presents with this infection, the patient has fever, which of the following interleukin caused fever? So this is how they ask the question. All right, so you need to know interleukin 1. It's a pyrogen and it causes fever. But besides fever, it also causes vasodilation and inflammation. Now, interleukin 1 activates endothelium to express adhesion molecules, right? And it also induces chemokine secretion to recruit WBCs. Now, whenever there is inflammation, you need to recruit WBCs, right? And that is done by interleukin 1. Hematopoietic growth factor. Interleukin 1 also causes proliferation of granulocytes by acting like hematopoietic growth factor. Interleukin 1 is also called osteoclast activating factor because it activates the osteoclast, right? Pretty simple. Now, let's look at another interleukin secreted by the macrophages, and it's interleukin 6. Now, this is again high yield interleukin. Interleukin 1 and 6 both cause fever, but what is the unique feature of interleukin 6? Its function is to stimulate the liver to produce acute phase proteins. Now, besides that, similar to interleukin 1, it also causes proliferation of granulocytes. But unlike interleukin 1, it also causes proliferation of lymphocytes. Now, besides these two functions, interleukin 6 plays a huge role in differentiation of B cells and cytotoxic T cells. Now, another high yield information for USMLE Step 1 about interleukin 6 is that its antagonist, that is interleukin 6 antagonist, plays a huge role for the treatment of giant cell arteritis and COVID-19. Now, interleukin 6 antagonist is called tocilizumab, right? It's just example, one of the example of interleukin 6 antagonist. Now, let's look at another interleukin. This is interleukin 8. Again, this is a really high yield information from exam point of view. It is a major chemotactic factor for neutrophils. Now, the way they will ask the question is that they will give you a clinical feature of infection, right? And they might give you a biopsy picture and might tell you that there are neutrophils seen in the biopsy, right? And then they will ask you which of the following interleukin caused these neutrophils to migrate to this site of inflammation or something like that. So you need to understand that major chemotactic factor for neutrophil is interleukin 8. And there are hundreds of ways to ask a question in exam, but all you need to know is interleukin 8 attracts neutrophils. That is, it's a chemotactic factor. Now, besides interleukin 8, there are other really important chemotactic factors for neutrophils, and they are super high yield for the exam. They are C5a, complement 5, right? LTB4, leukotriene B4, 5-HETE. Now, this is a precursor for leukotrienes. Kallikrein, platelet activating factors, and N-formylmethionine. Now, this is present in bacteria. Now, let's look at one more interleukin. It's interleukin 12. Now, the major function of interleukin 12 is to activate the natural killer cells. All right? Macrophage becomes activated, it secretes interleukin 12, and that interleukin 12 activates the natural killer cells. Now, what is another function of interleukin 12? It's to induce the differentiation of T cells into Th1. Again, high yield information for the exam. They love to ask you which of the following interleukins cause this differentiation of T cell into Th1. And the answer will be interleukin 12. Now, another high yield information for exam is tuberculosis. Interleukin 12 plays a huge role in tuberculosis by facilitating the formation of granuloma. Now, we know that tuberculosis is a granulomatous disease. So, what helps in this formation of granuloma? It's interleukin 12. Now, pharmacologically, interleukin 12 has a huge role in psoriasis. So, interleukin 12 inhibitors like ustekinumab is used for the treatment of psoriasis. Now let's look at one more important cytokine, and this is tumor necrosis factor alpha, right? TNF alpha. Now, its function is to activate the endothelium. It causes WBC recruitment, vascular leak. Now, this is really important from exam point of view. Whenever there is infection or inflammation, WBC has to be present in that site, right? So you need to understand what are the chemotactic factors for WBCs, and TNF alpha is a really important one. Now, another high yield information about TNF alpha for exam point of view is that it causes cachexia and malignancy. So they will give you a feature of malignancy, and then they'll mention that the patient had 12 kgs of weight loss, right? This is just an example. And then they will ask which of the following molecules played a huge role in this weight loss. And then the answer will be TNF alpha. Now, similar to interleukin 12, TNF alpha has a huge role in granuloma. Now, interleukin 12 facilitates the formation of granuloma, whereas TNF alpha maintains the granuloma. So, the granuloma formed by interleukin 12 is maintained by TNF alpha. This is really high yield information. Now, there are numerous TNF alpha inhibitors, but we'll be looking at adalimumab, certolizumab, golimumab, and infliximab. Now, these are high-yield TNF-alpha inhibitors, and they love to ask you questions about this in USMLE Step 1. But besides these four drugs, there is one more really high-yield drug, and it is etanercept. But unlike the four drugs that I mentioned, etanercept is a decoy. So it's a decoy TNF-alpha receptor, and it's not an antibody. So adalimumab, certolizumab, golimumab, infliximab, they are monoclonal antibodies. All right, but etanercept is not an antibody, it's a decoy receptor. So TNF alpha thinks that etanercept is its receptor and binds to etanercept, but it cannot function because it's not a true receptor, right? It does not have any function. So TNF alpha inhibitors are used for the treatment of IBD, rheumatoid arthritis, ankylosing spondylitis, and psoriasis. Now let's look at some of the cytokines secreted by T cells. Now, the most important interleukin secreted by T cells is interleukin 2. It is mainly secreted by CD4 plus cells. Interleukin 2 stimulates proliferation and differentiation of T cells into regulatory T cells, helper T cells, cytotoxic T cells, and natural killer cells. So basically, interleukin 2's main function is proliferation and differentiation of T cells. Besides that, it also activates macrophages. Now, pharmacologically, interleukin 2 antagonist, which is basiliximab, is used for renal transplant rejection. Its main function is to prevent the rejection. All right. Now, there are other synthetic interleukin 2 analogs like aldesleukin, which is used in the treatment of metastatic melanoma and renal cell carcinoma. Now, in the exam, they'll give you a question about renal cell carcinoma, and then they might ask you which of the following drug, which is secreted by T cells, is used for the treatment. And they might ask you about aldesleukin. All right. Now let's look at interleukin 3. It is a hematopoietic growth factor. Its function is similar to GM-CSF, right? Granulocyte monocyte colony stimulating factor. So its function is for the proliferation of these hematopoietic stem cells. Now, interleukin 3 causes proliferation of granulocytes and bone marrow stem cells. It's a high yield interleukin, and its major function is hematopoietic growth factor. Super high yield for exam. Now let's look at some of the cytokines secreted by Th1 cells. The most important is interferon gamma. This is one of the most important cytokines from the exam point of view. They will love to ask you a question about interferon gamma. Now, besides Th1 cells, it is also secreted by natural killer cells. Its major function is to activate macrophages, which increases the phagocytosing capacity of the macrophage and the phagocytosing capacity of natural killer cells to kill virus-infected cells. So the major function of interferon gamma is to activate the macrophage and to activate the natural killer cells. Now, another function is that along with tumor necrosis factor, interferon gamma stimulates macrophages to form granuloma, right? Super high yield from exam point of view. So not just TNF alpha, interferon gamma also plays a huge role in stimulating macrophages to form granuloma. And this is a small mnemonic. Gamma sounds similar to granuloma, all right? So you can remember interferon gamma helps in the formation of granuloma. Now, another function of interferon gamma is to suppress Th2 response. Now, another high yield point from exam point of view is that interferon gamma induces IgG isotype switching in B cells. So whenever a B cell is activated, it produces IgM, right, at the beginning. But we need more than IgM to fight bacteria and other infections in our body. We need other immunoglobulins like IgGs. So interferon gamma helps in isotype switching so that B cells can produce IgG. All right. Now let's look at other interferons. We just talked about interferon gamma, but there are other high yield interferons like interferon alpha and interferon beta. Now these are super high yield from exam point of view. So in exam, they'll give you a viral infection. They might give you a patient, 6-year-old presents with cough, rhinorrhea, fever, and the doctor diagnosed it as viral infection. So, which of the following interferons helps in our defense against these viruses? So, this is how they might ask you a question. All right. So, you need to understand that cells infected with a virus synthesize these proteins, interferon alpha and interferon beta, which prime other local cells for viral defense by down-regulating protein synthesis to prevent viral replication. So what happens is interferon alpha and beta down-regulates protein synthesis, so they do not have enough proteins to replicate. So basically, they prevent viral replication. So when virus replication is prevented, viral infection can be contained. And besides preventing the replication, it also promotes the expression of MHC class 2 and class 1 molecules. And we have discussed this extensively, right? MHC class 2 and 1 present antigen, all right? They present antigen to CD4 and CD8 cells. So interferon alpha and beta play a huge role in our host immunity. So let's look at one more major function of interferon alpha and interferon beta, and that is to activate the antitumor immunity. So tumor cells are abnormal cells which have many abnormal proteins. So by activating the expression of MHC class 2 and class 1, it helps our body to recognize these abnormal proteins, and we can activate our host defense to destroy these tumor cells. So that's one mechanism, all right? And besides that, interferons play a huge role in activating natural killer cells, right? So this is how they destroy tumor cells. Now, there are numerous pharmacologic uses of interferon alpha and beta. For interferon beta, you don't have to remember a whole lot of diseases. All you have to do is remember multiple sclerosis. And this is super important from exam point of view. All right. Now, let's look at some pharmacologic uses of interferon alpha. So like we said, it prevents the replication of viruses, right? So definitely there'll be a use in viral infection. So chronic hepatitis B, acute and chronic hepatitis C, all right? And similarly, interferon alpha is used in Kaposi sarcoma, adjuvant therapy for malignant melanoma, renal cell carcinoma, condyloma acuminata, hairy cell leukemia, and essential thrombocythemia. All right, these are high yield uses of interferon alpha. So let's look at some of the cytokines secreted by Th2 cells. Interleukin 4, it promotes differentiation of helper T cells into Th2 cells. It also activates and promotes growth of B cells and T cells. Similarly, it induces proliferation of mast cells and basophils. Probably one of the most high yield function of interleukin 4 is to enhance the class switching to IgE and IgG. Like we studied, interferon gamma helps in class switching of IgG. So, similar to that, interleukin 4 enhances class switching to IgE and IgG. So, from exam point of view, interleukin 4 is pretty high yield. Let me give you an example. They will give you a scenario where a child with asthma presents with asthma exacerbation, right? And then they will say something like the patient was treated with bronchodilators, steroids, now the patient is stable. When the blood test is sent, there was increased IgE, right? And that happens in asthma. IgE is increased. Then they will ask you which of the following interleukins played a huge role in class switching to IgE. And then the right answer will be interleukin 4. All right. So let's look at interleukin 5. It stimulates growth and differentiation of eosinophils and B cells. Similar to interleukin 4, which enhance class switching to IgE, interleukin 5 promotes class switching to IgA. Now, these are really high yield information. They will ask you which of the following interleukins helped in class switching to IgA. If they ask that, it will be interleukin 5. If they ask which of the following helped in class switching to IgE, then the answer will be interleukin 4. Super high yield for exams. All right. Now, another function of interleukin 5 is to promote wound healing. Now let's look at interleukin 10. It is secreted by Th2, Treg cells, and macrophages. So besides Th2 cells, interleukin 10 is secreted by T regulatory cells and macrophages. Now, the unique thing about interleukin 10 is that it's a anti-inflammatory. All right, it's an anti-inflammatory cytokine. It suppresses the immune system. So whenever our body realizes that the infection is curtailed, the infection is treated, now the inflammation has to be stopped, then interleukin 10 will be secreted by macrophages, Treg, and Th2. It inhibits the activated macrophages, it inactivates the dendritic cells, and the overall inflammatory response. It decreases MHC class 2 expression, and it also inhibits secretion of Th1 cytokines. So this is how interleukin 10 plays a huge role in suppressing the immune system. So Once an infection occurs, there'll be a inflammatory surge, right? But once the infection is over, we need signals to tell our immune system, okay, the infection is over, let's stop all the inflammation, and that is done by interleukin 10. Super high yield for exam. Now, let's look at this mnemonic. I extracted this mnemonic from first aid because this is super high yield. All right, this is really important and you must know this mnemonic. All right, high yield for the exam. Let's look at the mnemonic. Hot T-bone steak. So this represents effects of interleukin 1 through interleukin 6. So let's look at the first word. It's hot, right? So the first interleukin, interleukin 1, it induces fever, and the word hot represents that. Let's look at the second word. It's just the T, all right? Not the T-bone. It's only the T. So interleukin 2 causes proliferation and differentiation of T cells. So the major function of interleukin 2 is to proliferate and differentiate T cells. So let's look at the third word. It's bone. All right, so interleukin 3 causes proliferation of granulocytes and stem cells in the bone marrow. Now, if you notice at the word steak, only E, A, and K are in uppercase. The S and T of the steak are in lowercase. So only the E, A, K part represent the mnemonic. All right, so let's look at the fourth word, which is E. So it is interleukin 4. It causes class switching to IgE, super high yield. Now, the fifth, it's interleukin 5. It causes class switching to IgA. And the final word is K. So, interleukin 6 causes synthesis of acute phase reactant. All right? So, instead of C in the acute, we have replaced it with K so that you can remember that interleukin 6 causes synthesis of acute phase reactant. All right? So, high yield mnemonic, hot T-bone steak. Now, this is the summary of another high yield information. Fever, systemic inflammatory response, and sepsis is caused by interleukin 1, interleukin 6, and TNF alpha. This is super high yield information. Interleukin 1, 6, and TNF alpha play a huge role in inducing systemic inflammatory response. And we know that fever is one of the systemic inflammatory response. So besides fever, it induces other systemic inflammatory response and it also plays a huge role in sepsis. So in exam, they'll give you a question about septic shock. Let's say the patient had infection, let's say pneumonia, and then they developed sepsis and they had septic shock. And then they will ask you which of the following interleukins helped in these systemic inflammatory response. And they'll give you one of these three. So they might give you interleukin 1 or interleukin 6 or TNF alpha, and you have to choose one of them as the answer. All right. Now, another summary. Cachexia is induced by TNF alpha, interferon gamma, interleukin 1, and interleukin 6. Another high yield information. They will give you numerous questions about malignancy, and then they will mention the patient had 10, 20 kg of weight loss, right? This is just an example. And then they will ask you which of the following interleukins played a role in causing cachexia in this patient. And then you have to look for TNF alpha, interferon gamma, interleukin 1, and interleukin 6. Now let's look at some of the recombinant cytokines. All right, super high yield from exam point of view. So the first recombinant cytokine that we'll be discussing is recombinant erythropoietin analogs. And the example is epoetin alpha, super high yield. All right, so as it is a recombinant erythropoietin, its function is same as erythropoietin, right? It promotes erythropoiesis in bone marrow by stimulating erythrocyte colony forming units. Now, you can imagine the uses of erythropoietin analogs, right? It's definitely used in anemia. So, it's commonly used in anemia due to CKD, chemotherapy-induced myelosuppression, and anemia in AIDS. So, there are other illicit uses of recombinant erythropoietin analogs as well. So, besides pharmacological use, some athletes illegally use recombinant erythropoietin for doping. All right, you might have heard athletes being arrested for doping. So, what they do is they inject erythropoietin, which would increase their RBCs, right? So, when RBC increases, their oxygenation carrying capacity increases, which will help them for better endurance, for better stamina, right? Which will give them an unfair advantage in the sports. So let's look at some of the adverse effects of erythropoietin. These are super high yield from exam point of view, all right? So let me just give you an overview how the examiners will test you on this. So they'll say that there's a patient with CKD stage 5 who has anemia, right? And doctor prescribes erythropoietin. 2 weeks later, the patient presents with tachycardia and hypertension. Then you also noticed on ultrasound of the legs is that the patient also has deep vein thrombosis, right? So this is how they give you a scenario. And then you need to understand that this is not DVT caused because of stasis. The main cause in this patient is erythropoietin. All right. So this is how they will ask you. So let's look at another recombinant cytokine, which is filgrastim. So filgrastim is a recombinant granulocyte colony stimulating factor, GCSF. So it promotes mitosis, differentiation, and activity of granulocyte colony forming units. And it also stimulates stem cells to develop into mature granulocytes. It promotes neutrophil activity. So let's talk about the uses of filgrastim. As it is a granulocyte colony stimulating factor, and as it promotes the activity of granulocyte colony forming units and stimulates the stem cells to mature into granulocyte, you can imagine that its uses will be to replenish the neutropenia. All right. So any disease which causes neutropenia, for example, chronic neutropenia and neutropenia following chemotherapy and radiation therapy, you need mature granulocytes. All right. So in these patients, you can give filgrastim to increase the number of mature granulocytes. Similarly, it stimulates granulocyte precursors following bone marrow transplantation. This helps in bone marrow recovery and normalization of the WBC count. So after a patient undergoes bone marrow transplantation, it needs to produce the granulocytes. And filgrastim helps in stimulation of granulocyte precursors, so it will normalize the WBC count. Now let's look at one more recombinant cytokine, and it is sargramostine. It is a recombinant granulocyte monocyte colony stimulating factor. It induces stem cells to develop into mature granulocytes. So let's look at the uses. So similar to filgrastim, it is also used in neutropenia following chemotherapy or radiation therapy. It is also used in myelodysplasia, aplastic anemia, reconstitution of myeloid after bone marrow transplant, which is similar to filgrastim. So the way they ask question in USMLE exam is they'll give you a patient with neutropenia, right? Maybe following chemotherapy. Then they will ask you which of the following drugs will help in stimulating or normalizing the WBC count. So this is how they will ask you a question. All right. So let's look at some USMLE style questions. So a 42-year-old man comes to the office with chief complaints of swelling, pain over the forearm for 3 days. 5 days back, he was bitten by a dog on the forearm. The wound was clean and suturing was done 5 days back. Then 2 days later, he started developing severe pain and swelling. Blood pressure is 120 by 80, so that's normal. Pulse rate is 102, that's slightly tachycardic, right? And temperature is 102 degree Fahrenheit. So pulse rate is explained by the fever, right? Whenever you have fever, you get tachycardia. When incision and drainage was done, it revealed extensive pus accumulation. Which of the following molecule helped in the accumulation of pus? So this is a high yield question. So let's look at the options. Is it interleukin 2, 8, 10, or bradykinin? Or is it complement 1? So in order to get this question right, you need to understand the composition of pus. So pus is mainly formed by dead neutrophils, all right? So pus is nothing but accumulation of proteins and dead neutrophils. So which interleukin do you think helped in accumulation of pus? As the major composition of pus is neutrophils, you need to choose an answer which attracts neutrophils into the site, right? So you need to choose an answer which is a chemotactic factor for neutrophils. So if you remember what we have studied, the answer is interleukin 8 because it's a major chemotactic factor. So interleukin 8 is a chemotactic factor. All right. So whenever there is inflammation, it recruits WBCs into the site. So when these WBCs, specifically neutrophils, they die, they accumulate and form pus. So dead neutrophils accumulate and form pus. So the right answer is interleukin 8. So let's look at another USMLE style question. Researchers at the university have developed a new drug for the treatment of renal cell carcinoma. This drug acts as interleukin 2 analog and has recently completed a phase 4 trial. Oncologists at that hospital plan to use this drug as chemotherapy agent in RCC diagnosed patient. How does interleukin 2 work in these patients? So let's look at the options. Decrease the tumor burden by activating natural killer cells, decrease the tumor burden by activating neutrophils, direct cytotoxic effect on cancer cells, inducing apoptosis of cancer cells. So, like we studied, interleukin 2's major function is to activate natural killer cells. All right. So, when natural killer cells are activated, it can help in decreasing the tumor burden by directly destroying or killing the tumor cells. All right. So, the right answer is interleukin 2 works by decreasing the tumor burden by activating natural killer cells. So, these both questions are super high yield. All right. I hope you enjoyed this video. Thank you. Hello everyone, I'm Dr. Ashish Guragai and today we are going to study about hypersensitivity reactions. So let's get this started. So there are basically four types of hypersensitivity reactions: type 1, type 2, type 3, and type 4. So now let's talk about type 1 hypersensitivity first. First, I'll be explaining about type 1 hypersensitivity with anaphylactic reaction as reference, and then later I'll show you other different examples of type 1 hypersensitivity. So let's discuss the pathophysiology of type 1 hypersensitivity. So you need to understand that there are different proteins or different substances which are allergic to humans, right? So one person might be allergic to peanut, the other human being might be allergic to, let's say, pollen or danders or different kind of stuff, right? Anyone could be allergic to anything. And this is determined by their genetic predisposition, right? Everyone who eats peanuts won't get a hypersensitivity reaction, right? You have to be genetically predisposed. So in a patient who is genetically predisposed, when they take when they consume peanuts for the first time, they won't get this severe hypersensitivity reaction, right? They will get sensitized. So let's discuss how a person who is genetically predisposed to any allergen gets sensitized. So let's say someone who is allergic to, let's say, pollen or dander, right? Let's say they breathe this allergens, and then there are dendritic cells in the mucosa which identifies this allergen and captures this allergens as foreign bodies. Then dendritic cells present these allergens to naive T cells in the lymph nodes. Then naive T cells will be converted into Th2 helper cells. Then what Th2 cell does is it stimulates B cells to produce antibodies. And B cell gets converted into specific antibody producing cell called plasma cell. And for type 1 hypersensitivity, we'll only focus on IgE antibody because this is what causes the chaos, right? This IgE antibody. Now, we have a plasma cell which recognizes any allergen, and every plasma cell has a specific allergen, right? So for example, this plasma cell produces IgE antibodies specific to, let's say, peanuts, right? So Now we have got a plasma cell which produces allergen-specific IgE antibodies. Now these IgE antibodies, what they do is they go and get attached to this receptor in the mast cell called Fc epsilon Ri receptor, right? If you find epsilon to be lengthy, you can just say this receptor as FCERI, right? It's easier. Then let's say that same person is exposed to, for example, peanuts again, right? After being sensitized. So this time, a person who is pre-sensitized, if they get exposed to allergen, this allergen directly binds to this allergen specific IgE antibody, which is attached to Fc epsilon Ri receptors in the mast cell. Then, after this binding, the mast cell undergoes degranulation, and that is what causes anaphylactic reaction. Now, let's get into detail of how this happens. So now we have studied how a person who is genetically predisposed gets pre-sensitized, right? Now, once a person is sensitized, and then if they are exposed to the same allergen again, there occurs a severe allergic reaction. And it occurs in two phases. We call them immediate phase and late phase. So these are the immediate and late phases of an anaphylactic reaction. So in the immediate phase, everything happens within minutes, right? You need to understand that. It happens within minutes. So within minutes of exposure, antigen cross-links pre-formed IgE on a pre-sensitized mast cells, causing immediate degranulation. And what degranulation means is it releases granules containing histamine, tryptase, and leukotrienes. So let me explain this with a figure, right? So let's say someone who is allergic to pollen, right? So this is the pollen antigen. Then this antigen binds to IgE antibodies, and this IgE antibody is attached to its Fc epsilon Ri receptor in the mast cells. Now you could see this multiple granules inside mast cells, right? So once antigen binds, something called cross-linking occurs. So what is cross-linking? So cross-linking is nothing but different IgE antibodies on on the same mast cell attaching to the same antigen, right? So this is cross-linking. So this multiple IgE antibodies binding to an antigen is called cross-linking. So higher the number of antibodies binding to antigen, the severe the reaction occurs, right? Because higher the number of antibodies attaching to the antigen, more degranulation occurs. And higher the number of granules which get released, higher the number of histamine, tryptase, and leukotrienes get released into the system. Now, why are these histamine and leukotrienes and tryptase so dangerous? So let's see what histamine does. So histamine is a vasoactive amine, right? So it causes profound bronchoconstriction. It increases airway mucus production. It increases vascular permeability, which is also called vasodilation, right? And this increased permeability and vasodilation causes erythema, hypovolemia, hypertension, and histamine also causes pruritus, right? So how does vasodilation cause erythema, hypovolemia, and hypertension? So when there's increased vascular permeability, the fluid which is present inside the vessel, which is called intravascular volume, that volume gets released into the extracellular space, right? So the effective circulating volume decreases. That causes hypovolemia and hypertension. Now just imagine if there's increased permeability, all the RBCs are going to leak right into the tissue. So that causes erythema. Now, what is the function of tryptase? The function of tryptase is that it acts as a marker of mast cell activation. It itself does not cause a lot of havoc, but it is a marker of mast cell activation. So if we measure tryptase level in someone who has uh, anaphylactic reaction, we can be confident that, that it is an anaphylactic reaction because it is a marker of mast cell activation. So tryptase has a role for diagnostic purposes. So the main culprits are histamine and leukotrienes. So what histamine and leukotrienes does is it causes a severe bronchoconstriction, which causes difficulty in breathing. The patient has wheezing, right? So that's what causes immediate difficulty in breathing, histamine and leukotriene. And histamine is more involved with increased permeability, vasodilation, which causes erythema, hypovolemia, and hypotension. Okay, so now let's see what happens in late phase of the reaction. So it occurs within hours and lasts 24 to 72 hours. But what happens during late phase? So like histamine, tryptase, and leukotrienes, which were released immediately, there are other chemicals which gets released, but in a slower manner, right? So these chemicals are called chemokines. So mast cell secretion of these chemokines and other pro-inflammatory mediators attracts eosinophils and neutrophils, right? It's called chemotaxis. Now we know that eosinophils and neutrophils can cause inflammation and tissue damage because what eosinophil and neutrophils, when stimulated, what they do is release reactive oxygen species, right? And they cause phagocytosis, they release reactive oxygen species, which damages the cells, right? And that causes inflammation and tissue damage. Now let's see other examples of type 1 hypersensitivity. So we talked about anaphylaxis and we have learned about its symptoms, right? Pruritus, edema, rash, rhinitis, bronchospasm, and abdominal cramping. Other examples are angioedema. Due to mast cell activation in the dermis and or subcutaneous tissue, it causes a localized inflammation, which is called angioedema. But unlike anaphylactic reaction, they are limited to dermis and subcutaneous tissue. And another classic manifestation of type 1 hypersensitivity is urticaria, commonly known as hives. And all the atopic conditions that you hear, such as conjunctivitis, rhinitis, allergic asthma, right? So these are all examples of type 1 hypersensitivity. Now, there are certain tests that you can do to identify which molecule or which substance is causing these reactions. There are some of tests like skin test, like skin prick test, skin scratch test, and intradermal test. So these are nothing but the variation of the same mechanism. So what we do in skin prick test is we prick the allergen into the skin, right? We prick. But in scratch test, instead of pricking, we just scratch the skin with the allergen. And in intradermal test, we inject it intradermally. And then we see whether there is any edema or swelling, erythema, that kind of stuff. And there are certain blood tests, ELISA test for allergen specific IgE. So let's study about type 2 hypersensitivity, or as I like to call them, antibody dependent cell mediated cytotoxicity. I know this is mouthful, but this term gives you a summary of the entire pathophysiology of type 2 hypersensitivity. So type 2 hypersensitivity is a cytotoxicity which is cell mediated, but this cell mediated cytotoxicity is antibody dependent, right? So let's see what happens. So IgM and IgG antibodies bind to surface antigens of the cells in the body and cause cellular destruction, inflammation, or impaired cellular function. I know it sounds confusing, but let's see each pathophysiology in detail, right? But before that, I'd like to give you a brief overview of what happens. So let's say our IgM and IgG antibodies recognize these antigens as foreign, right? They might be our own antigens or they might be antigens outside the body, right? It does not matter. Sometimes our body recognizes our own tissue as foreign, and that causes autoimmune diseases, right? So let's suppose there are IgM and IgG antibodies in our body which bind to this antigens in the cell. Then what happens is after binding, there is something called antigen antibody complex, right? An antigen antibody complex triggers complement system, and this activation of complement system causes inflammation, right? This is just a brief overview of type 2 hypersensitivity, but there are a lot of specific things going on during cellular destruction, inflammation, and impaired cellular function. So let's go into detail of every mechanism behind type 2 hypersensitivity reaction. So let's talk about cellular destruction and how it happens. So cellular destruction has two main components. Either there'll be an antibody-dependent cell-mediated cytotoxicity mediated by natural killer cells or macrophages, or there'll be a target cell opsonization. Now, I'll explain what opsonization is in detail in a while. But before that, let's talk about antibody-dependent cell-mediated cytotoxicity first. So let's assume that this is an antigen which our body thinks is foreign, right? It might be our own tissue antigen or it might be antigen exposed from outside. But let's say our immune system, because of genetic predisposition or some pathology, right, genetic condition, somehow causes the immune cells to recognize these antigens as foreign. After that, IgG or IgM antibody binds to this antigen, right? And natural killer cells has a receptor for these antibodies. So once natural killer cells bind to this antigen, natural killer cells get stimulated, right? And once natural killer cells get stimulated, it releases perforin and granzymes. And this causes apoptosis. So what is perforin? Perforin is nothing but a protein which inserts in the membrane and forms a pore, right? And once a pore is formed in a cell, the cell swells and gets destroyed. And what is granzymes? Granzymes is nothing but a granule which contains cytotoxic enzymes and substances which destroys a cell by causing apoptosis. Now let's see what target cell opsonization is and how it causes cellular destruction, right? So like I said earlier, binding of IgM or IgG antibodies triggers complement cascade, right? Once complement cascade occurs, these little proteins called complement proteins and specifically C3b proteins are formed during the cascade, right? And IgG antigen itself, along with this C3b complement protein, they act as a trigger or stimulus for neutrophils to cause phagocytosis. So after C3b are formed, right, it binds to the cell. And this acts as a marker for neutrophils to, phagocytose. So they serve as a signal, and neutrophils identify these signals and know which cell do they have to phagocytose. So any cell which is marked with C3b complement proteins or marked with IgG antibodies These cells are recognized by neutrophils and they undergo phagocytosis. So these are two basic mechanisms behind cellular destruction in type 2 hypersensitivity. So let's study how inflammation occurs. So Fc receptor of antibodies mediate immune cell activation, right? So once antibodies bind to the cell surface, it acts as a trigger for activation of complement system. I have told you this previously as well, but let's study in detail how activation of complement system causes inflammation. So, like I said, binding of antibody to antigen triggers complement cascade. And like I mentioned previously, C3b complements are formed during the cascade. Not only is C3b a marker for phagocytosis, but it is a chemotactic agent, right? So once C3b complement proteins are formed, they signal the neutrophils to, you know, come there and cause inflammation. It is a chemotactic agent. It causes chemotaxis. Then, once the neutrophil sees these signals, it knows that it needs to go to that place and cause havoc, right? So once neutrophils are called into the site where antigen antibody binding is occurring, neutrophils release these granules containing reactive oxygen species. And we know that reactive oxygen species causes cell destruction and inflammation. Reactive oxygen species can single-handedly destroy a cell, right? So let's see other things which happens when complement cascade is triggered. So once complement cascade is triggered and in the final stages of complement cascade, there is something called MAC, right? So once a MAC complex is formed, it inserts into a cell, right? So MAC is membrane attack complex. So this is an end product of complement cascade, right? So membrane attack complex is nothing but a protein which inserts itself into the abnormal cell which had these abnormal antigen which triggered the immune system. So once the MAC inserts itself there, it acts as a channel, right? And the entire water in the cellular space, right, enters inside the cell and causes swelling and then causes destruction of this particular cell, which had these abnormal antigens, right? So this is how inflammation occurs. Now let's see how impaired cellular function occurs in type 2 hypersensitivity reaction. Now, antibodies bind to cell surface receptors, right? So these receptors are the antigens. And once the binding occurs, it either causes inhibition or activation of downstream signaling pathway. So let me explain this with a figure, right? So normally when a ligand binds to a receptor, it has multiple relays which causes a response, right? So binding of a ligand to a receptor causes a series of signaling inside a cell which leads to a response. Now, there are two things which can happen when antibodies bind to this receptor. Either this relay mechanism gets hyperstimulated and there is exaggerated response, or there is inhibition. So now let's study some examples of type 2 hypersensitivity reaction. And I have multiple mnemonics and I'm just going to list them for you at first, and then we'll talk into some specifics. So the first mnemonic is RBCs and blood. So autoimmune hemolytic reaction, immune thrombocytopenia, transfusion reactions, and hemolytic disease of the newborn. Now, did you notice something common in these four, right? If you did, you're correct. They're all related to blood or RBCs, right? So let me give you example of transfusion reaction. So let's say you are A positive, but for some condition, let's say severe anemia, you received B positive blood. Now, this B positive blood is going to be foreign to your body, right? So the antigens in B cells, B positive cells, are going to be completely new. But we have preformed IgM or IgG antibodies against these antigens in the B positive RBCs. All right. And like I said earlier, it causes type 2 hypersensitivity by causing cellular destruction. Now let's see another mnemonic. Good room for transplant. It includes Goodpasture syndrome, rheumatic fever, and hyperacute transplant rejection. Now let me give you example of hyperacute transplant rejection. Let's say you receive a kidney transplant, but let's say there was some error in cross matching, right? Let's say there was HLA mismatch. Then that kidney tissue is going to be antigenic, right? It's going to be foreign to your body. It will trigger immune response. Now, what happens in hyperacute transplant rejection is if there are pre-formed IgG or IgM antibodies against these proteins, it's going to cause type 2 hypersensitivity reaction by causing inflammation. Now let's see another mnemonic. Myasthenia gravis, Graves' disease, pemphigus vulgaris. Now, did you notice that I have highlighted gravis? And Graves sounds similar to Gravis, and we can twist the word vulgaris as vulgravis, right? So these are other examples of type 2 hypersensitivity reaction, and the mechanism behind these diseases is cellular inhibition or stimulation. Let's take example of myasthenia gravis, right? So if there are antibodies against ACH receptors, it causes myasthenia gravis. So once antibodies bind to this ACH receptor, it will completely inhibit the relay reactions or downstream relay chemical signaling which occurs from ACH receptor, and nothing is going to happen downstream. So this is an example of inhibition, cellular inhibition, and myasthenia gravis is a perfect example. Now, let's continue with type 3 hypersensitivity reaction. Now, what is type 3 hypersensitivity reaction? So in type 3 hypersensitivity reaction, what happens is an antigen binds to IgG antibody to form an antigen antibody complex. Then this antigen antibody complex gets deposited in tissue, for example, blood vessels. Then this causes activation of complement cascade, causing release of lysosomal enzymes from neutrophils, which ultimately leads to inflammation. And in our example, it causes vasculitis. Now, let's look at this image. If you look at this is an antigen antibody complex. Now, the unique thing about type 3 hypersensitivity compared to type 2 hypersensitivity reaction is that this antigen antibody complex was not formed in this tissue. It was formed somewhere else in the body, but it is being deposited in this tissue. Now, once this antigen antibody complex is deposited in blood vessel, it will activate complement cascade, causing a numerous chain of reaction which causes formation of C3b complement proteins. Now, if you remember, the function of C3b protein is to attract neutrophils into the site of inflammation, right? Now, this C3b causes chemotaxis. Now, once neutrophils arrive in the blood vessels, it will get activated. Now, once neutrophils are activated, this causes release of lysosomal enzymes. causing tissue destruction and inflammation, and ultimately leading to the damage. Now, I'd like to give you one more example of post-streptococcal glomerular nephritis. Now, PSGN is a common complication among children after strep throat or some kind of skin infection from streptococcus. Okay, so once a child gets infected with streptococcus causing, let's suppose, pharyngitis, right? Now, this group B hemolytic bacteria, which is group B hemolytic streptococcus, has some unique antigens. Now, if our body forms antibody against this antigen, in most children, the bacteria gets destroyed and they get well after suffering from pharyngitis. Now, in some people, this antigen antibody complex, which was formed during infection, gets deposited in another tissue. And in PSGN, this tissue is the glomerular basement membrane of the kidneys. Now, once this antigen antibody complex gets deposited in the glomerular basement membrane, again, complement cascade is activated, causing neutrophil chemotaxis and ultimately leading to glomerular damage and inflammation. Now, let's look at other classic prototype type 3 hypersensitivity reaction, which is serum sickness. Now, in serum sickness, what happens is when you inject antivenom after a venomous snake bite, it will lead to fever, urticaria, arthralgia, proteinuria, lymphadenopathy, and these all occur after a week or two, which is 7 to 14 days after the antigen exposure. And in this case, our antigen is the antivenom. Now, what happens is this antivenom is a foreign protein, right? These antivenom are something new that our body has not seen, and this is foreign to our immune system. Now, antibodies are produced against these foreign proteins. Now, 7 to 14 days later, antigen antibody complex form and deposit in tissues. Now, you need to understand that this does not happen in everyone, but among few people who get antivenom, antibody antigen complex form and gets deposited in tissues, which will again cause complement activation and lead to inflammation and tissue damage. Now, I have highlighted this low serum C3 and C4. Now, why is it important? Now, you need to understand that once complement activation occurs, these complement proteins get used up, right? Now, once it is used up in the process of inflammation, their level will be low in the serum. Now, another similar reaction is serum sickness-like reaction, which are associated with some drugs like penicillin, allopurinol, cephalosporin, monoclonal antibodies, and they're associated with some infections like hepatitis B and rabies. Now, you might be wondering what is the difference between serum sickness-like reaction and serum sickness. So usually the clinical features of serum sickness-like reaction and serum sickness is almost identical. The difference is in their etiology. Serum sickness is associated with anti-venom. Let's suppose anti-snake venom, anti-spider venom, or they are associated with antitoxins like botulinum toxin, right? So serum sickness is associated with anything which contains animal or any other serum proteins. Now, serum sickness like reactions are associated with drugs like penicillin, allopurinol, cephalosporin, monoclonal antibodies, and infection. So the difference lies in their etiology, but the clinical feature is the same. Now, you need to understand that not everyone who takes penicillin or allopurinol gets serum sickness-like reaction. But as these drugs act like haptens, in some people, these drugs, which act like hapten, they bind to other proteins, let's suppose albumin, right? And then this albumin-hapten combination works like an antigen and it triggers the immune system. Now let's look at another classic type 3 hypersensitivity reaction, and we call it Arthur's reaction. Now, the unique thing about Arthur's reaction is that it is localized to the skin. Now, the classic condition in which Arthur's reaction occurs in a child is if the child has got the first dose of a vaccine, and vaccine is an antigen, right? So if the child is injected with vaccine and later, let's suppose after a month, gets a booster dose or gets another dose of the same vaccine, then our body forms antibodies against the antigen because the child was pre-sensitized during the injection of first dose, and during that first dose our body formed IgG antibodies. Now when the child gets the second dose, antigen antibody complex form and get deposited in the skin, which causes enhanced local reaction. This antigen antibody complex deposition causes activation of complement. This leads to inflammation, edema, erythema, and possibly fibrinoid necrosis. Other classic examples of type 3 hypersensitivity reactions are vasculitis like polyarteritis nodosa, drug-induced hypersensitivity vasculitis, rheumatoid arthritis, systemic lupus erythematosus. It also causes IgA nephropathy, membranous nephropathy, post-streptococcal glomerulonephritis. Now let's continue with type 4 hypersensitivity reactions. Now, the unique thing about type 4 hypersensitivity reaction is unlike other types of hypersensitivity, this is a T cell mediated hypersensitivity reaction. Now, type 1, type 2, and type 3 hypersensitivity had some kind of interaction between antigen and antibody. But in type 4 hypersensitivity, there'll be interaction between antigen and T cell. Now, it involves two major steps. Now, the first step is T cell sensitization, which takes 10 to 14 days. In order to explain T cell sensitization, I'll be taking example of antigen which penetrates the skin. For example, the oil produced by poison ivy. Now let's assume that a patient is exposed to poison ivy. Now this oil from the poison ivy leaves penetrates the skin. Now this oil, which is antigenic, is taken up by Langerhans cells. Now Langerhans cell is an antigen presenting cell. Now, Langerhans cell migrates to lymph nodes and presents these antigens from the poison ivy to the T lymphocytes. Now, after being presented with antigens, there'll be formation of sensitized T lymphocytes. Before, before being sensitized, the T cells are called naive T cells. Now, after the activation, by being exposed to an antigen, this naive T cell converts into CD4 and CD8 cells. Now, after being sensitized to an antigen, if the person is exposed to that antigen again, then there occurs elicitation phase. This occurs only in people who are pre-sensitized. After repeated contact with the antigen, elicitation phase occurs rapidly and it does not take 10 to 14 days, unlike in the sensitization phase. CD4 T cells recognize the antigens on the antigen presenting cells. This will cause release of inflammatory lymphokines, cytokines like interferon gamma, TNF alpha. Now these molecules, they cause activation of macrophages. Now once the macrophages are activated, they cause phagocytosis of the target cells. Not only that, the CD8 plus T cells also recognize the antigens on the somatic cells and cause cell-mediated cytotoxicity, causing direct cell destruction. Now let me explain all this using a beautiful image. Now, this is the antigen that I was talking about. For example, urushiol, which is a molecule present in poison ivy leaves, but it could be any other antigen like the antigen used for tuberculosis test called purified protein derivative, or it could be a candida antigen used for candida test, right? It does not matter what the antigen is, it will be taken up by the Langerhans cells in the skin or any other antigen presenting cells depending on the tissue. Here I'm taking example of the skin. Now once the antigen is taken up by the Langerhans cells in the skin, it will then move to the draining lymph nodes. Now once the antigen presenting cell is in the draining lymph node, it interacts with the naive T cell. Now, this is the antigen presenting cell, and this is the naive T cell. Now, once there's an interaction between antigen presenting cell and naive T cell, the naive T cell then differentiates into CD4 plus and CD8 plus T cells. Then, the next time the antigen is exposed to the skin, these CD4 plus and CD8 plus T cells immediately will recognize the antigens. This recognition triggers series of reactions causing inflammation and destruction of the tissue. Now let me give you some common examples of type 4 hypersensitivity reactions. Some of them are severe cutaneous adverse reactions such as the DRESS syndrome, which is also known as drug reaction with eosinophilia and systemic symptoms. Another one is Stevens-Johnson syndrome and toxic epidermal necrolysis. Other examples are xanthomatous drug eruptions like drug reactions caused by antibiotics like ampicillin. Now, the symptoms of xanthomatous drug eruption includes morbilliform rash, pruritus, and fever. Like I said earlier, after the exposure to the drug, it takes about 1 to 2 weeks for these reactions to occur. But if the same person is exposed to ampicillin, the next time it won't take 2 weeks. The reaction will occur pretty quickly. Another example is allergic contact dermatitis. Now, this is a local reaction following topical application of antigens like poison ivy, nickel, etc. Like I said earlier, there are certain skin tests which are based on the principles of type 4 hypersensitivity reaction, like Candida skin test and Montu tuberculin skin test, also known as PPD test, which is used for latent tuberculosis. And we use Candida skin test to test the immune function of T cells. If a person does not react when Candida antigen is inserted into his skin, we can know that the T cells are not functioning properly. Some other examples of type 4 hypersensitivity which are pretty high yield are Hashimoto thyroiditis, multiple sclerosis, and type 1 diabetes mellitus. Now let's look at some USMLE style questions. Let's look at this question. A 14-year-old boy is brought to the emergency room after experiencing 45 minutes of difficulty breathing, abdominal pain, dizziness, throat, tongue, and lip itching. Now, this occurred minutes after he started eating shrimp for lunch. Which of the following substances were most likely released as a result of this immunologic event? Now let's look at the options. Is this immunologic event caused by histamine and serotonin? Or is it caused by histamine and bradykinin, histamine and tryptase, bradykinin and tryptase? I know the options look a bit confusing because bradykinin also has some kind of vasodilatory effect, right? And option 1 and 2 both contain histamine. But if you remember what I have taught so far, this reaction is caused by histamine and serotonin. Now, although tryptase is also released during type 1 hypersensitivity, tryptase is a marker of type 1 hypersensitivity, but it itself does not cause immunologic event. So the answer is histamine and serotonin. Now let's look at what we have discussed during type 1 hypersensitivity reaction. Like I said previously, after degranulation, there is release of histamine, tryptase, and leukotrienes. But the symptoms are caused by histamine and leukotrienes, not tryptase. Tryptase is a marker of mast cell activation, but it itself does not cause bronchoconstriction or vasodilation. The bronchoconstriction effect, mucus production, increased vascular permeability, vasodilation is caused by histamine, and leukotrienes cause bronchoconstriction and inflammation. Now let's look at some USMLE style questions. So this 14-year-old boy is brought to the emergency room after experiencing difficulty breathing, abdominal pain, dizziness, throat, tongue, and lip itching. Now this occurred minutes after eating shrimp. Which of the following substances were most likely released as a result of this immunologic event? So was it histamine, bradykinin, tryptase, and adrenaline? So what do you think is the right answer? Now, here the confusing option is bradykinin because even bradykinin causes vasodilation, right? So that might, confuse you. And another tricky option here is tryptase because we studied that tryptase is released during type 1 hypersensitivity reaction, right? But you need to know that tryptase itself does not cause symptoms or any signs. It is a marker of mast cell activation, but it does not cause symptoms. So here the right answer is histamine. So let's quickly revise what we talked during type 1 hypersensitivity reaction. So the most common molecules released during degranulation are histamine, tryptase, and leukotrienes. But the majority of symptoms are caused by histamine and leukotrienes. Now let's look at another question. A 5-month-old boy is brought to the doctor because of painful rash on his left leg. The day before he received all of his scheduled childhood vaccination, including second dose of DTaP vaccine, which was injected into his left thigh. A physical examination reveals 2 centimeter ulcer with surrounding induration on the left anterolateral thigh. A skin biopsy of the lesion reveals localized edema, skin necrosis, neutrophilic infiltration, and complement deposition. Which of the following is the most likely cause of his symptoms? Let's look at the options. Is it because of immune complex deposition, acantholysis, dermal infection, or is it because of CD8 cell mediated hypersensitivity reaction? Now, what do you think is the right answer? If you thought the right answer is immune complex deposition, then you are correct. This is Arthur's reaction, right? Look at the clinical vignette. The child received the same vaccine 2 months back, right? So during that phase, IgG antibodies were formed against the antigens present in the vaccine. Now, next time the child received the vaccine, his body got re-exposed. Now, during this stage, everything occurred rapidly because he had pre-formed IgG antibodies. And then antigen antibody complex were formed and then were deposited in the skin, which activated complement. That's why in the skin biopsy, you could see complement deposition and neutrophilic infiltration were result of chemotaxis by complement proteins like C3b. Now, let's look at other questions. A 45-year-old woman comes to the physician because of weakness for 2 months. At the end of the day, she feels too tired to cook dinner or climb up the stairs. She also complains of double vision after she reads for long periods of time. All of her symptoms improve with rest. Physical examination shows drooping of upper eyelids. Strength is initially 5 out of 5 in the upper and lower extremities, but decreases to 4 out of 5 after a few minutes of exercise. Which of the following best describes the pathogenesis of this patient's condition? Now, did you identify which disease this is? If you guessed myasthenia gravis, then you are correct. But what is the pathogenesis behind it? Is it type 2 hypersensitivity reaction? Is it the peripheral nerve demyelination? Is it impaired acetylcholine release? Is it impaired acetylcholine release? Or is it anterior horn cell destruction? Now, we have studied about myasthenia gravis a lot, and we know that antibodies are formed against AChR receptors, right? But we never give a lot of emphasis on which type of hypersensitivity reaction it is. So if you guess the right answer is type 2 hypersensitivity, then you are correct. But let's look into some more details. So now let's look at how myasthenia gravis occurs, right? Now, this is the antibody formed against the AChR receptor in the myasthenia gravis. Now, once the antibody binds to the AChR receptor, the downstream signaling pathways are inhibited. Now, this is the pathogenesis behind myasthenia gravis. Now, let's look at another question. A 35-year-old woman comes to doctor because of rash on her face. The rash increases when she stays in the sun for a prolonged duration. She also complains of oral ulcer, joint pain, fever, and fatigue. Her hemoglobin is 9.8 and her ESR is increased. Which of the following is expected on her lab reports? Now, did you diagnose this condition? If you diagnosed her as SLE, then you are correct. Now, let's look at the options. Will you see high serum C4? Or will you see low serum C3? Or will there be high tryptase? Or will there be low CRP? Now, if you remember what I have taught so far, this is type 3 hypersensitivity reaction, and the right answer is low serum C3. But let's quickly revise. Now, in SLE, there are antibodies to dsDNA, right? So there's anti-dsDNA antibodies which react with the antigen, which is the dsDNA. So this antigen antibody complex gets deposited in different tissue. Once they get deposited in different tissues, there'll be widespread complement activation in different tissue, right? So this widespread complement activation causes inflammation and tissue damage, but in the process, all the complements get used up, right? So once there's extensive complement activation, there'll be low serum C3 and C4. Why? Because all the complement proteins got used up in the process. So the right answer is low serum C3. Now let's look at one more question. A 46-year-old woman who immigrated from Southeast Asia comes to a physician for a pre-employment checkup. The doctor explains that she needed to be tested for latent TB. The physician injects 0.1 ml of purified protein derivative extract on the mid-volar surface of the right arm intradermally. After 72 hours, there is a palpable induration of 22 millimeters. This reaction is most likely a result of the release of which of the following substances? Now, if you remember what I've taught so far, this is a type 4 hypersensitivity reaction, but which of the following substance will be released? Is it tryptase? Is it interleukin 10? Is it lysozyme? Or is it interferon gamma? Now, I know all these options look pretty tricky, right? But the right answer is interferon gamma. But let's quickly revise. Now, if you remember, in a pre-sensitized person, CD4 T cells recognize antigens on antigen presenting cells, right? So in a person who has latent TB, they're already pre-sensitized to the tubercular proteins. So once we inject the PPD into the forearm, the CD4 T cells quickly recognize them. And then there will be a release of inflammatory lymphokines and cytokines such as interferon gamma, TNF alpha, which will cause macrophage activation, and there'll be phagocytosis of the target cells. So the right answer is interferon gamma. Thank you. Hello everyone, I'm Dr. Ashish Guragai, and today we'll be studying about transplant rejection and its treatment. So let's look at the types of transplant rejection. So we have four types of transplant rejection, and they are hyperacute transplant rejection, acute transplant rejection, chronic transplant rejection, and graft versus host disease. All right, so these are the main four types of transplant rejection that we'll be talking about in this video. So let's get it started. So let's look at hyperacute rejection first. So like the name suggests, it happens within few minutes, all right? That's why it's called hyperacute. So the onset is usually within a few minutes, but generally speaking, if there is an hyperacute rejection, it will happen within 48 hours of transplant, all right? And let's look at the risk factors. There are two main risk factors, and they are ABO incompatibility and HLA incompatibility. Now let's look at the pathophysiology of the disease. If there are pre-existing recipient antibodies, then these antibodies will react to the donor antigens. And this is a type 2 hypersensitivity reaction. This antigen antibody reaction will activate the complement and trigger inflammatory reaction. Now let's look at this image. So let's assume that this is the donor antigen. All right, this is the donor cell which has different antigens. Now, if there are pre-existing antibodies, let's assume this is an IgG antibody, then this antibody will go and bind to this antigen. All right, this antigen antibody complex will trigger the complement reaction and will cause inflammation. Let's assume this is a natural killer cell. Then natural killer cells have receptors for the antibody, right? So the antibody which was bound to this antigen can bind to the natural killer cells, and then natural killer cell can directly destroy this cell. All right. We'll be talking about this in much more detail in our hypersensitivity videos. Now, usually preformed antibodies against HLA antigen result from exposure to foreign HLA haplotypes, usually during pregnancy, blood transfusion, or any other transfusion of blood products, or a previously rejected transplant. So this is how our body is introduced to these foreign antigens. And when we are previously exposed to these antigens, we will already have antibodies. So the time when there is a transplant, and if there are preformed antibodies, then like I explained earlier, there'll be inflammatory reaction and there'll be rejection of that organ. All right. Now, what happens when there is inflammation of that transplanted organ? This leads to thrombosis of graft vessels. So this inflammatory reaction will cause thrombosis of graft vessels, and it will result in graft ischemia and fibrinoid necrosis. All right. So what are the histology findings? If we do a biopsy, we can find small vessel thrombosis, ischemia, and necrosis. So what is the treatment of hyperacute rejection? The only treatment is removal of the rejected graft immediately. All right. So now let's look at acute rejection. So what is the onset of acute rejection? Unlike hyperacute, this occurs within weeks to months. So usually acute rejection occurs within the first 6 months. All right. So what are the risk factors? Again, HLA incompatibility is one of the most important risk factors for all types of rejection, all right? And the another risk factor is inadequate immunosuppression. So usually after organ transplant, we start the patient on prophylactic immunosuppressive. If it is inadequate, then it can lead to acute rejection, all right? And sometimes medication non-adherence. If the patient is not adherent to their therapy, then it can cause acute rejection. Now let's talk about the pathophysiology. Mainly there are two distinct pathophysiology involved in acute rejection. First is cellular rejection. So what happens in acute cellular rejection? It is a type 4 hypersensitivity reaction. Now, if you remember type 4 hypersensitivity reaction, it is a cell-mediated hypersensitivity reaction. There'll be no antibodies involved. So direct toxicity from CD8 plus T cells or CD4 plus T cells will result in acute rejection. So these CD4 or CD8 cells react against the donor MHC molecules, all right? And another mechanism is humoral rejection. Now, this is type 2 hypersensitivity reaction, and it is similar to the one we talked earlier during hyperacute rejection, all right? But the exception is that these antibodies develop after the transplant. In hyperacute, there are preformed antibodies. But in acute rejection, these antibodies develop after the transplant. Now, this is really high yield. All right. Now, you might be wondering if the mechanism is similar, how are we going to distinguish acute rejection from hyperacute rejection, right? Because the type 2 hypersensitivity is the common thing which occurs in both. So one of the most important thing that you need to notice in hyperacute and acute rejection is the onset. So hyperacute occurs within minutes, but acute rejection takes weeks to months, all right? So this is how you distinguish hyperacute and acute from the onset. This is really important. Now, histology, there'll be vasculitis of graft vessels with dense interstitial lymphocytic infiltrate. Similarly, there'll be C4D deposition, which indicates humoral rejection. If there is no C4D deposition, then it indicates there is cellular rejection. Now, if you want to distinguish hyperacute from acute, another high yield distinguishing feature is the biopsy finding. So if you have vasculitis of graft vessels, it's acute rejection. If there is thrombosis, it's hyperacute rejection. And similarly, in acute rejection, there'll be interstitial lymphocytic infiltrate. This is pretty high yield of acute rejection. And one of the most important distinguishing feature is C4D deposition. Now we find C4D deposition by staining, all right? So when we do staining of the C4D molecule, if there is deposition, it indicates humoral rejection. Now this is how we distinguish hyperacute and acute rejection from the biopsy finding. And this is super high yield from exam point of view. This is how they will ask you in the exam, all right? They'll give you a vignette of organ transplant, then they'll give you features of rejection. There'll be pain, swelling, stuff like that. And then they will say a biopsy was done, and then biopsy showed C4D deposition. Then you'll understand, okay, this is acute rejection. All right. So this is how they test you in the exam. Now let's talk about prevention. Now, one of the most important thing that we can do pre-operatively is proper cross-matching and ABO grouping and HLA matching. If there is ABO grouping mismatch or HLA mismatch, then there'll be high risk of acute rejection. If we can do proper cross matching, then we can definitely prevent acute rejection. Now, another thing that we can do post transplant is adequate immunosuppressive therapy. Now, let's talk about treatment. So, despite adequate preventive measure, acute rejection can occur, right? So the first thing we should do is adjust the dose or regimen of the immunosuppressive therapy that we used for prophylaxis. Now, despite that, if there is features of rejection, depending on whether it's acute cellular rejection or acute humoral rejection, our treatment plan will differ. So how do we find out whether it's cellular rejection or humoral rejection? If you said C4D deposition, then you're correct, right? So if there is no C4D deposition, then we can be sure that it's cellular rejection, and the first line treatment is glucocorticoids. Now, the second line treatment is lymphocyte depleting antibodies. And the classic example is muromonal. All right, it's a monoclonal antibody targeted at CD3 receptors. Now, do you remember which lymphocyte has CD3 receptor? If you said T cell, you're absolutely correct, right? So T cells have CD3 receptor. So if we inject someone with monoclonal antibody targeted against CD3, then we will destroy the T cells, all right? So this is how lymphocyte depleting antibodies work. They will destroy T lymphocyte. Now, if it is acute humoral rejection, then the treatment is plasmapheresis, IVIG, anti-CD20 antibodies. Now, unlike T cells, B cells have CD19, 20, and 21 receptors, right? So if we inject someone with anti-CD20 antibodies, then they will destroy the B lymphocyte, all right? And similar to acute cellular rejection, we can also use lymphocyte depleting antibody in acute humoral rejection. And we can use corticosteroids as an add-on therapy, all right? We can use it as an adjunct. Now let's talk about chronic rejection. So the word chronic suggests that the onset is delayed, right? So usually it occurs after few years, but for the definition, if a rejection occurs after 6 months, we call it chronic rejection, all right? So what are the risk factors? If there is partial HLA match, inadequate immunosuppression, or non-adherence to medication, then chronic rejection occurs. Unlike HLA mismatch, which would result in acute rejection, partial HLA match will cause chronic rejection. All right. Now let's talk about pathophysiology of chronic rejection. So there is combination of type 2 and type 4 hypersensitivity reaction. That is, there is both cellular and humoral component. Now, if the CD4 T cells responds to the recipient antigen presenting cells, presenting the donor antigens or peptides, then it will cause it to differentiate into Th1 cell. All right. So upon the exposure to the foreign antigen, CD4 T cells will differentiate into Th1 cells. Th1 cells will then secrete interferon gamma. This will activate the macrophage. And this activation of macrophage will cause inflammation of parenchyma and the endothelium. So let's talk about the biopsy features. So after we do biopsy on histology, we can find that chronic rejection is dominated by arteriosclerosis. Now, this is super high yield from exam point of view. Like I suggested earlier, you have to distinguish between hyperacute, acute, and chronic. So chronic rejection is identified by arteriosclerosis. This is the key finding, all right? This is super high yield from exam point of view. Now, other findings in histology are proliferation of vascular smooth muscle obstruction, graft atrophy, and interstitial fibrosis. These are super high yield features of chronic rejection, and this is how they will test you in the exam. All right, they will give you features of rejection, and then they will say, on the biopsy, we found vascular smooth muscle obstruction, atrophy, interstitial fibrosis, and there is predominant arteriosclerosis. What is the type of rejection? And then you have to choose chronic rejection. Another useful way to distinguish different types of rejection is from the onset. All right, that is also super high yield. But usually there's some kind of overlap between acute rejection and chronic rejection. Let's say the onset is around 6 months, right? So that is a timeline which overlaps between acute and chronic rejection. That timeline of 6 months, right? So in that case, histology finding will help you distinguish acute and chronic rejection. Now let's talk about the treatment of chronic rejection. Unfortunately, we don't have any immunosuppressive which can be used for chronic rejection, and the only way to treat it is graft removal. Another unfortunate thing is that we don't have any preventive measure. There are no known prevention for chronic rejection. So if there is chronic rejection, we have to remove the graft. Now let's talk about organ-specific features of rejection. So in hyperacute rejection, there'll be swelling of the organ and severe pain. So let's take an example of kidney. So if there is hyperacute rejection after kidney transplant, there'll be severe flank pain and swelling of the organ, right? Now, if there is acute transplant rejection of the kidney, then there'll be features of organ dysfunction. There'll be increased blood pressure and kidney function lab values, that is, raised urea, raised creatinine, right? And there'll be decreased urine output. There might be features of acute tubular necrosis, urinary leakage, renal vein thrombosis, which presents as pain, hematuria, oliguria, right? And if there is urinary tract obstruction, there'll be colicky pain. And again, like renal vein thrombosis, there'll be hematuria and oliguria. So these are features of acute transplant rejection of the kidney. Now let's take another example of lungs. Usually acute transplant resection of lungs might be even asymptomatic, or if the patient is symptomatic, there'll be cough, shortness of breath, tachypnea, fever, hypoxemia, and crackles. And in severe cases, there'll be ARDS. So what you can understand from these examples of kidney and lungs is that if there is resection of a particular organ, you'll get features of organ dysfunction of that particular organ. So if there is failure of kidney, there'll be raised urea, creatinine, decreased urinary output. You get the idea, right? And if there is rejection of lungs, there'll be features of lung disease. So now you get an idea how acute transplant rejection of a particular organ will present. So the classical thing is, it doesn't matter which organ it is, if there is acute transplant rejection, there'll be organ dysfunction of that particular transplant, right? If there is kidney transplant and there's rejection, decreased urinary output, raised blood pressure, hematuria, oliguria, features like that. If there's rejection of the lungs, there'll be shortness of breath, cough. So you just need to understand that in exam, if there is an organ transplant rejection, there'll be organ dysfunction. All right, that's how they present. Now let's talk about organ specific examples of chronic rejection. If there is chronic rejection of the kidney, it will present as chronic allograft nephropathy and glomerular sclerosis. So there'll be slow and gradual dysfunction of the organ. That's how chronic rejection presents. Slow and gradual dysfunction of the organ. If there is lung rejection or chronic lung rejection, there'll be features of bronchiolitis obliterans. If there is chronic rejection of the heart, there'll be accelerated atherosclerosis of the coronary arteries. And if there is chronic rejection of liver, it's called vanishing bile duct syndrome. All right. So these are organ specific examples of chronic rejection. Now let's talk about graft versus host disease. So this is the fourth type of transplant rejection. So let's talk about the risk factors first. So any transplantation of lymphocyte-rich organs can cause graft versus host disease. And the classic example is transplant of allogenic hematopoietic stem cell. All right. So stem cell transplantation are a classic example which can cause graft versus host disease. And if there's transfusion of non-irradiated blood products in immunosuppressed, it can also cause graft versus host disease. As liver is lymphocyte-rich organ, liver transplant can also cause graft versus host disease. So let's talk about two types of graft versus host disease, and it's acute and chronic. Now let's talk about acute graft versus host disease first. Now let's talk about the onset. So the classical acute GVHD occurs within 100 days after transplantation, and the late onset type occurs after 100 days. So just by looking at that, you can see that just from the onset, we cannot distinguish whether it's acute or not because there's a late onset type and that can confuse you in the exam. All right. So the most important way to distinguish acute graft versus host disease is from its pathophysiology and clinical features. So let's talk about pathophysiology first. So donor T cells trigger a type 4 hypersensitivity reaction in the recipient organs. Now, unlike other rejection where the host reacted against the recipient organ, graft versus host disease is unique because the donor T cells trigger hypersensitivity reaction against the recipient body. All right. So the graft fights against the host, unlike host fighting against the graft and other types of transplant resection. All right, this is unique about graft versus host disease. It's the donor T cells that trigger type 4 hypersensitivity reaction against the recipient organ. Now, the classic clinical features involve skin, GI tract, and liver. So if GI tract is involved, you'll get nausea, vomiting, diarrhea. In skin involvement, you'll get maculopapular rash. And this rash could be itchy, painful, or both. Another classic feature is cramping abdominal pain. And when liver is involved, you'll get hepatosplenomegaly and jaundice. So these are the classic features of acute graft versus host disease. And you have to remember that skin, GI tract, and liver are classically involved in acute graft versus host disease. So if you get a question, and if these three systems are involved, you have to suspect acute graft versus host disease. Now let's talk about the findings. So the classic finding in the blood is anemia, thrombocytopenia, or leukopenia, or you could get any combination of these three. All right. And another classic feature is raised ALP. Now, the most important finding is on biopsy. All right. So, biopsy of skin or rectum or liver will show endothelial damage and lymphocytic infiltration. So, this is a classic feature and high yield for exam point of view. All right. So, it will show endothelial damage and lymphocytic infiltration. So, what are the ways to prevent acute graft versus host disease? So transfusion of irradiated blood products in immunocompromised people and pharmacotherapy with cyclosporin plus either methotrexate or mycophenolate mofetil can prevent graft versus host disease. So what is the treatment? So despite preventive measure, we can get graft versus host disease, right? So in that case, you have to use immunosuppressive drug. And again, it's cyclosporin. So maybe you have to increase the dose which was used for prevention or adjust the regimen. All right. Now, depending on the skin involvement, if there's less than 50% involvement, you can use topical steroid. If there is involvement of GI tract, liver, or more than 50% of skin, you can use systemic steroid and or topical steroids. Now for diarrhea, you can use octreotide. All right. So let's talk about chronic graft versus host disease. Now, like we talked earlier, usually the time of onset of chronic GVHD is more than 100 days. But this is the previously defined onset, all right? So nowadays, we identify chronic graft versus host disease from the clinical feature regardless of the time of onset, all right? So the time of onset is not significant. It's the classical features of chronic GVHD. So let's look at the clinical features. So one thing you need to understand is any organ can be involved in chronic GVHD. So unlike acute GVHD, in which skin, GI tract, and liver were involved, in chronic GVHD, any organ can be involved. So there'll be all the features of acute GVHD because all the organs or any organs can be involved, right? So there'll be definitely features of acute GVHD, plus there'll be features of bronchiolitis obliterans, which will present as chronic cough, wheezing, dyspnea. So if you have a patient who has liver involvement, skin involvement, diarrhea, and coughing and wheezing, it won't be acute GVHD. It will be chronic GVHD because in acute GVHD, you won't have features of bronchiolitis obliterans. All right. So this is how you distinguish chronic GVHD. And this is how they will test you in exam. Because usually when we say acute GVHD, we think about, it has to be present within first 100 days, right? But like I said, for chronic GVHD, onset does not matter. It's the clinical feature. So even if the patient presents within 30 days, if there is involvement of lung, you have to choose the answer chronic GVHD, not acute GVHD. So besides bronchiolitis obliterans, you can have features of myasthenia gravis, polymyositis, scleroderma-like and lichenoid skin changes, and fasciitis. All right. So these are features of chronic GVHD. But one thing you need to remember, any organ can be involved. All right. And that is how you distinguish chronic GVHD. Now let's talk about the treatment. So the treatment is corticosteroids and cyclosporin. Now let's talk about immunosuppressants used in organ transplant. So what is immunosuppressant? Any drug that blocks lymphocyte activation and proliferation is an immunosuppressant, all right? So it reduces acute transplant rejection by suppressing the cellular immunity. And that's why we use immunosuppressants as prophylaxis, right? In order to prevent the rejection. Usually we use a combination of drug to achieve greater efficacy, all right? Now let's start with glucocorticoids. Now, glucocorticoids are one of the most important immunosuppressive agent that we'll use in transplant rejection. All right. So the classic examples of steroids that we use in transplant rejection are prednisolone, hydrocortisone, and dexamethasone. And one thing you need to understand is that we use these glucocorticoids in high dose. All right. So let's look at the mechanism of action of glucocorticoids. Now, this is super high yield from exam point of view. They love to ask you questions about mechanism of action of glucocorticoids in USMLE Step 1. All right. So one thing you need to know is that it causes inhibition of NFKB, so nuclear factor kappa B. All right. And it is a transcription regulator. This is super high yield point. It's a transcription regulator. So inhibition of NFKB suppresses both B and T cell function by direct influence on the gene. All right. So it decreases the transcription of cytokines. So NFKB is a transcription regulator and glucocorticoids inhibit this transcription regulator. So there'll definitely be decreased transcription of the cytokines. And when there are decreased cytokines, B cell and T cell cannot be activated. When they cannot be activated, their function is suppressed. All right. So this is one mechanism of action. Another mechanism of action of glucocorticoids is that it induces T cell apoptosis. All right. So these two are one of the most important mechanism of action of glucocorticoids. There are numerous mechanism of action of glucocorticoids, but these two are the most important. So let's talk about the uses. So besides organ transplant resection, glucocorticoids has numerous uses, all right? So besides transplant resection, it is used in many autoimmune and inflammatory disorders. It is used in adrenal insufficiency, it is used in atopic condition and asthma. And sometimes we even use it in malignancy. So it is used in CLL and non-Hodgkin lymphoma. All right. So this is just a brief overview of uses of glucocorticoids. These are just some examples. Now let's talk about the side effects. Now we can have a separate video on just the side effects of glucocorticoids, right? So glucocorticoids has numerous side effects, but for now, we'll just make it brief, all right? So the classic side effects are Cushing syndrome, osteoporosis, hyperglycemia, amenorrhea, adrenocortical atrophy, peptic ulcer, psychosis, cataracts, glaucoma, avascular necrosis of the bone, commonly of the femoral head, all right? So these are the commonly tested side effects of glucocorticoids. They will ask you numerous questions about peptic ulcer, femoral head avascular necrosis, cataracts, glaucoma, amenorrhea, hyperglycemia. The exam will test you on each of the side effects of glucocorticoids. So you have to remember these side effects. All right. Now, another side effect of glucocorticoid is that it causes demargination of WBCs. So there'll be artificial leukocytosis. Why? Because the WBCs cannot be released into the tissue, all right? They cannot move into the tissue from the blood vessel because the demargination is prevented and they are restricted within the blood vessel. So that's why there'll be artificial leukocytosis. Now, another classic thing that they will ask you in exam is adrenal insufficiency if the drug is stopped abruptly after chronic use. So after chronic use, there'll be negative feedback inhibition of the hypothalamic pituitary axis, right? So because of that, there'll be decreased ACTH secretion from the pituitary. Now, once you abruptly stop glucocorticoids and there is decreased ACTH from the pituitary, this decreased ACTH cannot stimulate the adrenal glands enough to produce the glucocorticoids, right? And other adrenal hormones. So there'll be adrenal insufficiency. Now that we have talked about glucocorticoids, let's start with calcineurin inhibitors. And the classic example that you'll get in your USMLE Step 1 is cyclosporine. They will ask you so many questions about cyclosporine, all right? So it is super high yield. So let's start with mechanism of action of cyclosporine. So cyclosporine binds to cyclophilin, all right? Now, binding to cyclophilin causes inhibition of calcineurin. Now, once this molecule called calcineurin is inhibited, it will inhibit NFAT. Normally, calcineurin activates NFAT, but as calcineurin itself is inhibited, it cannot activate NFAT. If there is inhibition of NFAT or nuclear factor of activated T cell, it cannot stimulate the gene for interleukin 2 transcription. All right. So NFAT is a transcription stimulator. All right. It activates the transcription of interleukin 2. But as NFAT itself is inhibited, there'll be decreased interleukin 2 transcription. Now, we know that interleukin 2 is really important for T cell activation, right? As there is decreased interleukin 2 transcription, it blocks the activation of T cell. Now, we know that if the T cell is not activated, it's useless, right? It cannot do its function. So this is how calcineurin inhibitors work. They decrease the interleukin 2 transcription, all right? So this is the common thing in all the immunosuppressive drugs. We have to decrease the cytokines or interleukins, which ultimately prevents the function of B cell and T cell. That's the bottom line of all the immunosuppressive. Decrease the cytokines so that T cell and B cell function is inhibited. All right. Now let's talk about the uses. So besides transplant resection, we can use cyclosporine in psoriasis and rheumatoid arthritis. So what are the side effects? Now this is super high yield. They will ask you so many questions in USMLE Step 1 about the side effects of cyclosporine, super high yield. So most important is nephrotoxicity, hypertension, hyperlipidemia, hyperglycemia. It is a diabetogenic drug. all right? And besides that, it will also cause neurotoxicity. But the unique feature of cyclosporin is gingival hyperplasia and hirsutism. So these two, hirsutism and gingival hyperplasia, are the classic side effects of cyclosporin. Besides that, nephrotoxicity, neurotoxicity, hypertension, these are overlapping side effects with other drug. These side effects won't help you identify cyclosporin, but if in the question stem there is gingival hyperplasia and hirsutism, along with nephrotoxicity, neurotoxicity, or hypertension, then you can definitely tell that the patient has side effects of cyclosporin. All right. Now let's look at another calcineurin inhibitor, which is tacrolimus. So it has a similar mechanism of action to cyclosporin, but the difference is that it binds to FK506 binding protein, all right? And binding to this protein causes inhibition of calcineurin. So this is the distinguishing feature between cyclosporin and tacrolimus. That's the only difference. Everything else is similar. So like we said earlier, inhibition of calcineurin inhibits NFAT activation. If NFAT is not activated, there won't be transcription of interleukin 2. And like we said earlier, without interleukin 2, the function of T cell is inhibited, all right? T cell cannot be activated without interleukin 2. Now let's look at the uses. Like I said earlier, besides transplant rejection, we can use tacrolimus for psoriasis, all right? So that's the similarity with cyclosporin. But unlike cyclosporin, there is a topical tacrolimus which can be used for atopic dermatitis. So that's the unique use of tacrolimus. Now, we talked about side effects of calcineurin inhibitors briefly, right? And I said that there are a lot of overlapping complications. So both calcineurin inhibitors, tacrolimus and cyclosporin, are neurotoxic, they are nephrotoxic, and they're diabetogenic. All right, so these are the overlapping side effects. But unlike cyclosporin, tacrolimus does not cause gingival hyperplasia or hirsutism. All right, tacrolimus does not cause gingival hyperplasia and hirsutism. This is how you distinguish whether the patient has tacrolimus side effect or side effect from cyclosporin. Super high yield gingival hyperplasia and hirsutism are features of cyclosporin. Now let's talk about another drug, sirolimus. All right, and it is also called rapamycin. Now, like I said earlier, the bottom line of all the immunosuppressive is to decrease the cytokines, all right, to decrease the interleukins. So similarly, sirolimus also decreases interleukin 2, all right, but the mechanism of action is slightly different. So sirolimus binds to FKBP, and it is an mTOR kinase inhibitor. And when mTOR kinase is inhibited, it decreases interleukin 2 response, all right. Let's look at the uses. So all the drugs that we are talking about today are used in transplant resection, right? That's the bottom line. But what are the other uses of sirolimus? It is used in drug-eluting stents, all right? Now let's look at the side effects of sirolimus. Now this is a mnemonic, pants and shirt, all right? So you usually wear shirt and pants together, right? So sir represents the shirt, all right? And the pants represent pancytopenia. So the classic side effect of sirolimus is pancytopenia. But the thing you need to remember is that a lot of immunosuppressive drugs cause pancytopenia, all right? Besides pancytopenia, it also causes insulin resistance, dyslipidemia, but it is not nephrotoxic. This is super high yield. Sirolimus is not nephrotoxic. This point will be tested in your exam again and again. All right. So they will ask you a question: which of the following immunosuppressive should be used if there is renal disease? All right, if the patient already has renal disease, if you use a nephrotoxic drug, it will exacerbate it, right? So in that situation, you should use a drug which is not nephrotoxic. So this is how they will test you in the exam. They will test you about mechanism of action, and they will test you about the unique side effects. All right, remember, sirolimus is not nephrotoxic. Now there's another drug called basiliximab, all right, and it is a monoclonal antibody, all right. And its mechanism of action is simple. It blocks interleukin 2 receptor. So other drugs that we talked so far inhibited interleukin 2 production, right? It affected at the genetic level and there was no transcription of interleukin 2. But basiliximab is a monoclonal antibody, and it blocks the interleukin 2 receptor. So even if interleukin 2 is formed, it cannot act on its receptor. All right, so that is how basiliximab works. Now let's talk about another immunosuppressive drug, which is azathioprine. So azathioprine is a purine analog. Let's look at its mechanism of action. It is an antimetabolite precursor of 6-mercaptopurine. So what this means is azathioprine, which mimics like the normal purine in our body, metabolizes itself into 6-mercaptopurine. So azathioprine converts into 6-mercaptopurine. Now this 6-mercaptopurine inhibits lymphocyte proliferation by blocking nucleotide synthesis. As it mimics the normal purines, instead of normal purines which are used for DNA replication, they will use the drug, all right? And because our body is using the drug instead of the normal purines, it will block the nucleotide synthesis. And ultimately, there'll be decreased proliferation of lymphocytes. So let's talk about the uses. Like we are discussing in this video, it is used in renal transplant resection, right? But besides that, it is used in autoimmune conditions like rheumatoid arthritis, Crohn's disease, glomerulonephritis, and it is also used as steroid sparing drug. That is, whenever a patient is using steroid for a long term, there'll be a lot of side effect, right? And when we want to stop the steroid and start another drug, we can use azathioprine. Similarly, if a steroid is not effective in a patient, we can switch to azathioprine. So it is used in steroid refractory disease. Now, talking about the side effects, it causes pancytopenia. Why? Because nucleotide synthesis is blocked, right? Once nucleotide synthesis is blocked, again, stem cell, hematopoietic stem cell forming RBCs, WBCs, platelets, this entire process is blocked as well. So it will cause pancytopenia because of blockage of the nucleotide synthesis. All right. And there'll be hepatotoxicity as well. So these are classic features of azathioprine, classic side effects of azathioprine. Now let's talk about one more immunosuppressive, and it is mycophenolate mofetil. All right. Now let's talk about its mechanism of action. It causes reversible inhibition of IMP dehydrogenase. And as IMP dehydrogenase is inhibited, there'll be inhibition of purine synthesis. And prevention of purine synthesis will cause decreased B and T lymphocyte proliferation. All right. Once purine synthesis is inhibited, there won't be cellular replication. All right. Cells won't divide. That's why ultimately the B and T lymphocyte will decrease. Now let's talk about the uses of mycophenolate mofetil. It is used in organ transplant resection, psoriasis, rheumatoid arthritis, and it is again used similar to azathioprine as glucocorticoid sparing agent. All right. Now let's talk about the side effects. Like I said earlier, as purine synthesis is inhibited, there'll be pancytopenia. All right, because the normal hematopoietic stem cell forming RBC, WBCs, platelets, this entire process will be blocked. So there'll be pancytopenia. As there's decreased B and T lymphocyte, there's increased risk of CMV infection. There'll be diarrhea, vomiting, nausea, hypertension, hyperglycemia. However, they are less nephrotoxic and less neurotoxic compared to cyclosporine, right? So you have to know this. They are less nephrotoxic and neurotoxic compared to drugs like calcineurin inhibitors like cyclosporine. This is super high yield. Like I said earlier, they might ask you which of the following drug can be used in a patient who has raised creatinine. That is, he or she, I mean, they already have decreased kidney function. If you use a nephrotoxic drug, it will exacerbate it. All right. So this is how they will ask you a question. Hello everyone, I'm Dr. Ashish, and today we'll be studying about congenital immunodeficiency disorders, but mainly we'll be only focusing on B cell disorders today. So let's get this started. Now, the first disease that we'll be talking about will be Bruton A gamma globulinemia. It's a mouthful, right? Okay, so it's also called X-linked A gamma globulinemia. Now let's study some clinical features of this. Now, for you guys, in order to make it easy for you, I've made this simple chart, which is like a mnemonic. And if you notice, all these letters start from B. So you can remember this as six B's, right? And you might be wondering, that three is not a B. But if you think about it this way, right? And if you remove this, right, it looks like a three. Okay, so let's get this started. Now, the first B I want you to know is boys, right? So as you can see, it is X-linked, right? So this way, it will be easy for you to remember that this disease is very common in boys and it's super rare in girls, right? So in a USMLE question, it's highly unlikely that if the question stem has, if the patient is a female, it's highly unlikely that she will be suffering from this. So, it will be easy for you to rule that out. Now, the next thing is obviously B cell, right? So in this disease, B cells are going to be low, right? Or completely absent, decreased to bare minimum or absent. Now, so the next thing is this. So the patients who will be suffering from Bruton A gamma globulinemia, they present after 3 to 6 months of age. Now you might be wondering why the patient would, not start from the birth, right? So you need to know about this thing called IgG, right? So immunoglobulin G. So the neonates, when they are born, they have this from their mother, right? And usually this remains in them till 3 to 6 months. So for the first 3 to 6 months, they'll be asymptomatic. But after that time period, they'll get all kind of infections and the clinical features that we'll be talking about later on. So you need to remember the onset. Now, obviously, another B is the causative gene, right? So it's BTK gene. Now, let's see another B, which is bacterial and viral infection. Now, this is not a very high yield information because all the immunodeficiency syndromes, all the diseases, they will have bacterial and viral infection, right? So it won't help you in exam, but you must know this. Okay, now, the next thing, very high yield, now this is super high yield, is absent or hypoplastic adenoids and tonsils. So this is so high yield. Now you might be wondering why would there be absent or hypoplastic adenoids and tonsils, right? So you need to know one really important thing is that these lymphatic tissues are really rich in B cells, right? So don't you think it's intuitive that if B cells are decreased, obviously, then this tissue will be hypoplastic or even absent. So that's the reason. Now let's move to next slide. Now we'll be talking about clinical features. So if you remember from the previous slide, I said that there'll be a lot of bacterial and viral infections, right? So there'll be recurrent and chronic sinopulmonary infection, right? There'll be a lot of upper respiratory tract infection, pneumonias, otitis media, things like that. Now, okay, we talked about that. Okay, sinusitis, right? Now, among them, recurrent otitis media is the most common one. Now, let's see. This is pretty high yield information. So sometimes, the child might just have, respiratory tract infection, just a benign form. The kids get sick. But if the child has growth delay, if there's failure to thrive and recurrent infections, right? So you must be really aware. So that's pretty high yield information. Now, another thing that we have already talked is B cell rich tonsils and adenoids would be absent. Okay. However, this is pretty unique now. Peripheral lymph nodes, the other lymph nodes in your body, they might appear normal because of hypertrophy of T cells. So you need to understand that these lymphatic tissue will have B cells, right? And then there'll be T cells, right, scattered around. Okay, now if these B cells are depleted, they are going to take over, right? They're going to increase. So they'll just balance it out. So they would these lymph nodes would appear normal because of hypertrophy of T cell areas. Okay, so let's move to next slide. Now let's talk about diagnosis and treatment. Diagnosis. So what do we think will be, present clinically? Recurrent infections, right? And as there's genetic component and as it is X-linked, there will be family history. It might not be present, but if it's there, it will be really helpful for you to, get that answer correct in your exam. Now, this is very high yield information. Low immunoglobulin of all classes, right? All classes. So if there are no B cells, there won't be plasma cells, right? So B cells, when they're activated, they get converted into plasma cells. Now, plasma cells make specific antibodies. Now, if B cells are decreased, all the immunoglobulins will be decreased. So that's intuitive. Now, flow cytometry, this is very important thing, but the thing is in USMLE, if they give you this absent or low B cells, it would be so easy, right? So they would do some tricky things, like they'll never mention there are low level of B cells. They'll say things like there are low levels of cells having CD19 or CD20 um, receptor, right? They will trick you. So you need to know these B cells have CD19, 20, and 21. Now, genetic test. Now, again, usually USMLE test, they won't give you such easy points, but sometimes they do, right? But when they give you such really easy things like the child has defect in BTK gene, you cannot forget about it and then make a mistake. So you have to remember defect in BTK gene. Okay, so let's talk about treatment. Now, the one of the best treatments that we can do is hematopoietic cell transplant. So remember, there's genetic defect, there are low B cells, right? Because of genetic defect. Now, if we can transplant hematopoietic cells, we can solve the main problem that's going on, right? Which is low B cells. So this is amazing treatment for Bruton A gamma globulinemia. Now, another temporary thing that we can do is IVIG replacement. So usually this IVIG replacement is done 2 to 4 weeks, depending on situation, right? So every, let's say, a month, immunoglobulins are replaced externally so that we have some defense mechanism to fight against bacteria and viruses. Now, another thing which is really intuitive is prophylactic antibiotics, right? So, what is the thing going on with these kids, right? Infection. So, obviously, if you can give prophylactic antibiotics, it will help them. Okay, now let's move to a new topic, selective IgA deficiency. Now, again, I've made a chart for you guys so that, you know, it's easy to remember about the classical features of selective IgA deficiency. Now, like previous chart, this is a mnemonic. And if you notice, right, why do you think I've highlighted all these A here, right? So this is a mnemonic, IgA deficiency. Now, let's start with the first, mucosal surface. So what this means is there'll be a lot of infections, recurrent infection of these surfaces. So you'll get a lot of upper respiratory tract infection, you'll get a lot of diarrhea, right? Things like that. Now you need to think, why is mucosal surface so highly affected in IgA deficiency? Now, for this, you need to remember some basic knowledge that IgA is the immunoglobulin which is present in secretions, right? It's present in saliva and other secretions of the body, and it protects the mucosal surface. So obviously, if the protective immunoglobulin is deficient, the bacteria and viruses and parasites, they are going to attack these mucosal surfaces, right? So you'll have a lot of infections of these surfaces. Now, another high yield information is atopy. So, selective IgA deficiency is associated with atopic conditions like asthma and atopic dermatitis, things like that, right? Now, another unique thing about selective IgA deficiency is that there might be false positive tests like false pregnancy test, false celiac disease test. So, this is pretty high yield information. Okay, now another high yield, probably one of the most important thing that you have to remember is that selective IgA deficiency is associated with anaphylaxis, right? So what happens is whenever a patient who is deficient is transfused with, let's say, blood or any product which contains IgA immunoglobulins, they'll get an anaphylactic reaction, and this might be the first symptom that they have selective IgA deficiency. Now, another high yield information is there'll be a chronic and recurrent giardiasis infection in selective IgA deficiency. And I've already explained the mechanism previously why this happens, because IgA protects the gut surface, right? It lines the stomach, intestine, and all these things. They're present in the secretions, right? So IgA is present all over the mucosal surface. Now, this IgA helps the healthy people to combat giardiasis, right? It helps to combat Giardia lamblia. But if you have selective IgA deficiency, body cannot, defend itself from Giardia lamblia, and they will have a lot of recurrent giardiasis. Now let's move to next topic. Highlights, right? So what are the highlights of this selective IgA deficiency? One of the most unique thing is we still don't know the cause. And like I mentioned earlier, most patients are asymptomatic, and the first symptom could be anaphylactic reaction during transfusion, right? Now, this is very high yield information. This could be another A, right? I don't know why I didn't add it on the wheel. Okay, so another A, celiac, and autoimmune disease. So you just have to remember that these diseases are associated with IgA deficiency, selective IgA deficiency. Now, let's talk about diagnosis. So it's really intuitive, right? So if you just measure serum immunoglobulin A levels, obviously that's going to be low. And IgG and IgM are going to be normal. Now, this information is going to help you distinguish selective IgA deficiency from other immunodeficiencies. So this is really high yield information. Now let's do some USMLE style questions. So, a 4-year-old boy is admitted to the hospital after suffering from abdominal cramps and recurrent bouts of foul smelling, greasy diarrhea for 4 months. He's had recurrent pneumonia and otitis media in the past. Giardia lamblia cysts are discovered in the stool. Which of the following is this patient more likely to develop in the future? Let's see the options. Recurrent fungal infection, blood transfusion reaction, COPD, cutaneous granuloma. So, this kid, who is 4 years old, has recurrent bouts of foul smelling, greasy diarrhea for 4 months. And we found the cause, right? It was Giardia lamblia. And he's had other recurrent infections of the mucosal surface as well. So, if you remember whatever I have taught so far, you should get this question correct in 10 seconds, right? So, the child will have a risk of blood transfusion reaction in the future. Okay. Let's move to new topic. Common variable immunodeficiency. Now, let's see the clinical features. So the most cases are diagnosed only after puberty. Now, this is the most high yield information here, right? If you if you remember about prudence, the presenting age was really young, right? Usually after first 3 to 6 months. And IgA deficiency has a variable course because many patients are asymptomatic. And the unique thing about CVID is that the patients are diagnosed after puberty. Very high yield information after puberty. So usually many patients are uh, in their 20s, 30s, or even the 40s when they're first diagnosed with this condition. Now, what is the pathogenesis? So here the unique thing is the B cells are normal, right? So if you do cytometry, the B cells are going to be fine, right? Their number is going to be fine. The problem is not in their number. The problem is that they cannot differentiate into specific immunoglobulin producing plasma cells, right? So that's the problem. B cells are there, but they cannot, you know, uh, differentiate into plasma cells. And if you don't have plasma cells, you won't have immunoglobulins, right? You won't have IgG, IgM, IgA. So all of these are going to be low. Now, the unique thing about CVID is that they are associated with Hodgkin and non-Hodgkin lymphoma and gastric carcinoma. So this is really high yield information. So USMLE loves to test about such, unique features, right? So I want you to remember this point. Now, another unique thing about CVID is that they are associated with autoimmune disorders. Now, this can be confusing with IgA because even they are associated with autoimmune, but you just need to know this fact. Now, the common autoimmune disorders in CVID are rheumatoid arthritis, pernicious anemia. Okay, so how do we diagnose this condition? So again, flow cytometry, right? So here the problem is with the plasma cells, not B cells. So there'll be only decreased plasma cells, right? And there'll be low levels of IgG, IgM, and IgA. So what is the treatment? Again, like other immunodeficiencies, the treatment is immunoglobulins, right? If you have low levels of IgG, IgM, and IgA, we're just going to give them this immunoglobulins externally. Again, antibiotics, right? This is kind of intuitive. Now, let's deal with another USMLE style question. So a 32-year-old man presents with, history of recurrent infections, right? He has had pneumonia twice, otitis media 4 times, and sinusitis 6 times in the past year. Now, if you notice, he was fine before that, right? Before 6 months, he was good, and all of a sudden, he's getting these recurrent infections. He's otherwise healthy. He has no other medical problems. Lab tests show a decreased level of IgA, IgG, IgM. Flow cytometry shows normal B cells and T cells. What is the diagnosis? Now, the first option is kind of tricky because whenever you see recurrent infections in an adult, your mind goes towards HIV. But here they have mentioned that the T cells are normal. And if you know the pathogenesis of HIV, the CD4 cells, which are the T cells, they are going to be low in HIV, right? So that's a hint. And usually in exam, the question might be even trickier because they might give you a history of, let's say, unsafe sexual practices, right? So even that might trick you further into choosing HIV. But remember, the T cells are normal, and in HIV, the CD4 count is low. And here the right answer is CVID because we have been talking about CVID all the way. But the another tricky option here is carcinogenesis, right? Because even in carcinogenesis, there'll be a lot of pneumonia, bronchiectasis, things like that. But the high yield information about carcinogenesis is that the problem is with ciliary motility, right? And there'll be situs inversus, right? So we don't have those kind of features of, let's say, the heart is on the right side, things like that. So we can rule out carcinogenesis from that. Okay, now let's see a USMLE style question. So let's read this question. So 18-month-old boy is being evaluated for recurrent infections, right? So he was healthy till 6 months of age, but since then he has experienced 6 episodes of otitis media and 5 episodes of bacterial pneumonia. His height and weight measurement reveals a failure to thrive. Further workup shows very low serum levels of all immunoglobulin types. Examination of his head and neck will reveal what? So let's look at the options. Option 1, absence of tonsil, hypertrophy of tonsil, cleft lip, cleft palate, twitching of facial muscles, and gentle tapping of the cheek. Now, if you remember all the things that I have taught so far, this should be a really easy question for you, right? So this question gives you a really good hints. So he was healthy till 6 months of age. You know why. But since then, he has experienced 6 episodes of all these things, right? So there's recurrent infection. His height and weight measurement reveals failure to thrive. And there is low serum levels of all immunoglobulin types. So you know that this is Bruton A gamma globulinemia. Now, like if you remember what I've taught you so far, what do you think we will see in examination? If you said absence of tonsils, you're right. Hello everyone, I'm Dr. Ashish Kuragai, and today we'll be talking about congenital immunodeficiency diseases, and we'll be focusing on T cell disorders, T and B cell disorders, and phagocyte dysfunction. So let's get this started. So in congenital T cell immunodeficiencies, we'll be talking about DJOS syndrome, autosomal dominant hyperimmunoglobulin E syndrome or JOB syndrome, interleukin 12 receptor deficiency, and we'll be talking about chronic mucocutaneous candidiasis. So let's start with DJOS syndrome. Now, this is one of the most high-yield question for USMLE Step 1. Now, you need to understand the defect in DJOS syndrome. So there'll be a developmental defect in third and fourth pharyngeal pouches. You have to remember this. Now, this will cause hypoplastic thymus and parathyroids. So if you can remember that there is a defect in third and fourth pharyngeal pouches, all the clinical features will make sense. All right. So third and fourth pharyngeal pouches are important for development of the face. So in this disease, there'll be abnormal feces. Similarly, third and fourth pharyngeal pouches are also important for the development of the aortic arch. All right. So if there is a defect in third and fourth pharyngeal pouches, there's a high chance that there will be defect in the aortic arches. So there'll be cardiac abnormalities as well. Now, like mentioned here, there's going to be a hypoplastic thymus. So T cell deficiency will occur and there'll be immunodeficiency. Now, as there are hypoplastic or absent parathyroids, the calcium homeostasis will be impaired and there'll be hypocalcemia. All right. So let's look at this. So these are the parathyroid glands which develop from the pharyngeal pouches and the thymus. So these are going to be defective. They are going to be hypoplastic or absent. Now, the etiology is autosomal dominant. This is pretty high yield. You have to remember that this is an autosomal dominant disease. And the microdeletion at chromosome 22 causes these defects. All right. So this is also pretty high yield. They love to test you about this on the exam. Now, Catch-22 is a mnemonic which ties up all the clinical features. So the C stands for cardiac anomalies. So there's going to be a conotruncal abnormality. The most common ones are tetralogy of Fallot and truncus arteriosus. You have to remember these. These are pretty high yield. So on exam, how they will ask you a question is they'll give you a child with abnormal face and let's say who has T cell deficiency, thymic hypoplasia, cleft palate, and hypocalcemia. Then they will ask you which of the following cardiac anomalies are likely in this patient, and they'll give you an option of tetralogy of Fallot, and they'll give you other options, and you have to choose tetralogy of Fallot. So this is how they ask you the question. So the catch-22, cardiac anomalies, abnormal facies, thymic hypoplasia, cleft palate, and hypocalcemia. These are super high yield. So this is the cleft palate. You have to remember these features, all right? They are very high yield for USMLE Step 1. Now, how do we diagnose DJOS syndrome? Well, the gold standard is obviously the detection of this 22q11.2 deletion, right? This is a micro deletion. So obviously the gold standard is to identify or detect the deletion itself. Then there are other tests such as parathyroid hormone test and calcium level, and they are going to be decreased. Similarly, the T cells are going to be decreased. Now, if you take a chest x-ray on these patients, the thymic shadow is going to be absent. Now, this is super high yield. So normally you can see the thymic shadow on the chest x-ray, but in these patients, this is going to be absent. This is super high yield. Now for the treatment, you can imagine as the patient has immunodeficiency, obviously the treatment is going to be antibiotics and antifungals, but these can be also used for prophylaxis against PCP, all right? So there's a high risk of pneumocystis jirovecii infection, right? So in order to prevent that, we give prophylactic antibiotics. Similarly, like all the other immunodeficiency syndromes, bone marrow transplant and IVIG are pretty effective treatment for DJOS syndrome. So for the exam point of view, you don't need to memorize antibiotics, bone marrow transplant, and IVIG for treatment because these are the same treatment for all the immunodeficiencies, all right? So for any immunodeficiency, if you write one of these, you are highly likely to be correct. Now, let's talk about autosomal dominant hyperimmunoglobulin E syndrome or JOB syndrome. So from the name itself, we know that this is an autosomal dominant disease and there's going to be increased immunoglobulin E. So we talked about this. It's an autosomal dominant disease and there's going to be a mutation in this gene, STAT3 mutation. This is super high yield. You need to memorize this. Now, because of this STAT3 mutation, there's going to be decreased Th17 cells. Now, if you remember, Th17 cells are highly important for the recruitment of neutrophils and macrophages. So when there's decreased Th17 cells, the recruitment is going to be affected. Now, the mnemonic for the clinical feature for job syndrome is credit for your job. All right. And this credit, this 1 and 7 representing the Th17 cells, they're kind of like I and T, all right? So credit for your job. Now, the C stands for coarse facies and cold abscesses. So there's going to be coarse facies, and the reason there's cold abscesses is because of impairment of recruitment of neutrophils and macrophages. So you know that these neutrophils and macrophages cause inflammation, all right? They go to the site of infection and cause inflammation. As there's defective recruitment of neutrophils and macrophages, the abscess will be cold, meaning there won't be inflammation. So this is the normal abscess, which is red, swollen, and warm. But the cold abscess, they won't have erythema, there won't be swelling, and they won't be warm to touch. So this is pretty unique to Job syndrome. Similarly, there'll be recurrent bacterial infection. Obviously, if there's no neutrophil and macrophages guarding your defense, there's going to be increased infection. But the most important one is staphylococcal. Other unique things about Job syndrome are retained primary teeth. So if you look at this figure, the patient will not lose their primary teeth, all right? So there's going to be supernumerary teeth. There's the patient will have more than 32 teeth, all right? This is super high yield, retained primary teeth. Similarly, you can imagine if there's hyper IgE, there's going to be increased eosinophils because IgE recruits eosinophils, right? So increase in IgE will cause increase in eosinophils. Similarly, eczema is also a unique feature of Job syndrome. Now, patients with Job syndrome have decreased bone density and it will cause recurrent fractures after minor trauma. Sometimes these multiple bone fracture can hint you towards child abuse, but don't be confused, all right? If the patient has recurrent fractures, but the patient also has eosinophilia, retained primary teeth, or any of these features, it's not child abuse. But if there are recurrent history of fractures and bone fractures in different stages of healing, then you can suspect child abuse, all right? So let's summarize the clinical feature one more time because these are super high yield. Coarse facies, cold abscesses, recurrent bacterial infection, retained primary teeth, eosinophilia, eczema, and decreased bone density. And the mnemonic, credit for your job. These are super high yield. Now let's talk about interleukin 12 receptor deficiency. Now, from the name itself, you can imagine that there's going to be decreased interleukin 12 receptors, right? So this is an autosomal recessive disease causing decreased interleukin 12 receptor, which will impair Th1 activation. Now, interleukin 12 is super important for activation of T helper cell type 1, all right, for Th1. Now, without Th1 activation, Th1 cannot release interferon gamma. Without interferon gamma, macrophages cannot be activated. All right. So interleukin 12 receptor deficiency will cause impaired macrophage activation, super high yield. All right. This is a very important pathophysiology. Now you can imagine the clinical features. Now macrophages are really important for killing intracellular bacteria. All right. And one of the most important one is Mycobacterium, tuberculosis, and salmonella. So these are intracellular bacteria causing infection. So without macrophages, there will be increased susceptibility to these bacterial infection as well as recurrent fungal infection. Now let's talk about chronic mucocutaneous candidiasis. So from the name itself, you can imagine that there's going to be an increased risk of candidiasis in the skin and the mucous membrane. All right, there'll be chronic mucocutaneous candidal infection in these patients. So let's look at the pathophysiology. So the defect is in the IR protein. All right, and this deficiency of IR protein will lead to defect in interleukin 17 and its receptor. Now, like I said earlier, interleukin 17 is very important for T cell function. Now, the unique thing about this disease is that there'll be only persistent non-invasive candida infection. The infection won't be invasive. It cannot spread into the blood and other system because neutrophils prevent the invasive candidal infection. The T cells are only responsible for protecting us against mucocutaneous candidal infection. But neutrophils are responsible for controlling candidal proliferation in the blood and other system. So as the neutrophils are functionally intact, they cannot invade into our body. This infection will be limited to mucous membrane and skin only. This is super high yield, and this concept is highly tested on USMLE Step 1. So this is chronic mucocutaneous candidiasis, all right? Now, talking about diagnosis, these diagnostic measures are also high yield for USMLE Step 1. Now, there'll be absent in vitro T cell proliferation when exposed to Candida antigen. So, the most important thing that you need to remember is that exposure to Candida antigen will trigger type 4 hypersensitivity, all right? And it is mediated by T cell. So, without this IR protein, T cell proliferation is impaired, and when exposed to Candida antigen, there won't be any in vitro T cell proliferation, super high yield. Similarly, when Candida antigen is injected into the skin, there won't be any cutaneous reaction. Absent cutaneous reaction. This is super high yield. Normally, the cutaneous reaction against Candida antigen is a type 4 hypersensitivity reaction, but as T cell function is impaired, that cannot happen. Now let's talk about some mixed disorders. Disorders which involve both B and T cells. They are severe combined immunodeficiency, Wiskott-Aldrich syndrome, hyper-IgM syndrome, and ataxia-telangiectasia. Now let's talk about severe combined immunodeficiency. Now there are many different causes of severe combined immunodeficiency, but we'll be talking about the three most common ones. Now the most common mutation is this X-linked recessive type in which there's mutation of gene encoding the gamma chain in the interleukin 2 receptor. Now, when the interleukin 2 receptor gamma chain is defective, its linkage with JAK3 protein will be affected. So normally the interleukin 2 receptor gamma chain is linked to the JAK3 protein. But because of the defect in the gamma chain, this link will be broken. Now, without the stimulation of JAK3 protein, the downstream reaction or the downstream signaling, which would normally cause the immune cells to proliferate and be activated, will be impaired. So now you can imagine that this mutation will ultimately impair the immune cell proliferation, and this will cause severe combined immunodeficiency. Now, this is the most common mutation, the interleukin 2 receptor gamma chain mutation. All right, super high yield for USMLE Step 1. Now, the another cause is autosomal recessive form, which causes adenosine deaminase deficiency. Now, you have to remember this enzyme. This is super high yield. Now, because of this enzyme deficiency, there'll be accumulation of toxic metabolites such as deoxyadenosine and DATP. Normally, adenosine deaminase would convert these metabolites into their byproducts. But as this enzyme is deficient, these metabolites will accumulate. Now, these metabolites impair the generation of deoxynucleotides. Now, you can imagine that without deoxynucleotides, the DNA synthesis will be affected. And again, without DNA, the cell proliferation will be impaired. All right. Now, the third mutation is the RAG mutation. Now, because of the faulty RAG protein, there won't be a proper VDJ recombination. Now, if you remember from the immunoglobulins video, VDJ recombination is really important for antibody diversity. So without VDJ recombination, our body cannot bind to a diverse group of antigens and there'll be immunodeficiency. So if you look at this image, accumulation of toxic metabolites will impair the generation of nucleotides, all right? And without nucleotides, the DNA will be disrupted. And without DNA, cell proliferation will be affected. This is super high yield. So you have to remember these three mechanisms of severe combined immunodeficiency for USMLE step 1. These are highly tested, all right? Similarly, sometimes they will ask you which of the following metabolites impair the generation of deoxynucleotides in this immunodeficiency. And then you have to choose accumulation of DATP. So this is also very highly tested. All right. Always remember deoxyadenosine and DATP. These are the toxic metabolites which impair the generation of deoxynucleotide. Now, on the exam, you'll get clinical features of recurrent bacterial, viral, fungal, or protozoal infections, but these are not unique to SCID, right? These are not unique to severe combined immunodeficiency. So you might be confused. But some of the unique features are lymph nodes and tonsils may be absent. All right. This is super high yield and unique to severe combined immunodeficiency. Now, another disease in which lymph nodes and tonsils may be absent is Bruton's A gamma globulinemia. All right. But in Bruton's A gamma globulinemia, there'll be deficiency of immunoglobulins, but the T cells will be normal. So if you look at the T cells, you can differentiate between these two conditions. All right. Now, other features such as chronic diarrhea, chronic candidiasis, and failure to thrive, this will also help you to narrow down to severe combined immunodeficiency. All right. So the child will be cachexic. All right. There'll be failure to thrive. And if you look, this is the normal oral cavity, and you can see the tonsils. But if you examine the patient who have severe combined immunodeficiency, the tonsils will be absent. So one of the most important diagnostic tests is this PCR. And this PCR will show decreased T cell receptor excision circles. So you need to understand what are Tregs. So Tregs are nothing but normal circular DNA present in mature T cells. As T cells are decreased in severe combined immunodeficiency, these Tregs will also be decreased. All right, this is very high yield. Now, we can use Tregs for newborn screening for SCID. All right. So this is also highly tested on USMLE Step 1. Similarly, if you do a flow cytometry, you can see absent T cells. Now, if you do a chest X-ray, there'll be absent thymic shadow. Now, this was present in DiGeorge disease as well, but you can differentiate DiGeorge and SCID from the calcium level, all right? So in DiGeorge, there'll be hypercalcemia, the parathyroid hormone will be decreased, there'll be cardiac anomalies, all right? But these features won't be present in SCID. So these are the differentiating features, and you have to know the differentiating features because the test makers they will try to confuse you between DiGeorge syndrome and severe combined immunodeficiency syndrome. The infective portion of the clinical features, such as recurrent infections, recurrent sinopulmonary infection, these are overlapping features. So you cannot distinguish the two conditions from infection, but you can distinguish them from other clinical features which I just mentioned. All right. Now, if you take a lymph node biopsy, there'll be absent germinal centers. Now, any disease which affects the B cell proliferation will cause absent germinal centers because germinal centers are the location where B cell activation, proliferation, class switching occurs. So if that function is impaired, the germinal center will be absent. So this is how flow cytometry looks. In normal patients, let's take an example that this is the signal for T cells. All right. So this is the fluorescence of the T cells. But in patients who have SCID, the absent T cells will prevent this from showing up in the cytometry. All right. You can see that this pattern is absent here, and that shows that there are absent T cells. Now let's talk about ataxia telangiectasia. So the name itself suggests that the patient will present with telangiectasia and cerebral dysfunction causing ataxia. All right. So this alone helps us to narrow down to ataxia telangiectasia because these are pretty unique features. So the mutation occurs in the ATM gene, all right, which will cause the failure to detect in DNA damage. So normally ATM gene produces proteins which detects DNA damage. Now, because of this mutation, these defective DNA will go unnoticed and they will accumulate. So once mutations accumulate, there will be immunodeficiency and tumor development. All right. So the classical features are these triad, a triad of angiomas, immunodeficiency, specifically IgA will be decreased. So other immunoglobulins such as IgM, IgE will also be decreased, but this is the peculiar one, IgA deficiency. This is pretty prominent, all right? And like I said earlier, ataxia alone suggests that there is cerebral defect. Now, for diagnosis, you can look at alpha fetoprotein. Now, any condition which will cause neurological dysfunction or any anatomical neurological defect will cause the AFP to increase. As there is defect in the cerebellum, the AFP will increase, all right? Similarly, like I suggested, the IgA will be decreased. This is the most prominent one. But like I said earlier, even IgG and IgE will be decreased. Similarly, there will be lymphopenia. The confirmatory test is to detect the mutation of the ATM gene. Now, as the cerebellar is defective, if you do an imaging such as MRI, you can see atrophy of the cerebral vermis and hemisphere. So if you do an MRI, the cerebellum will be hypoplastic or atrophic. All right, the hemispheres, the vermis, they're going to be atrophic. Now, like I said earlier, the defective mutations in the DNA will accumulate and it will cause different malignancies, right? So there's increased risk of lymphoma, leukemia, and gastric cancer. These are super high yield for USMLE Step 1. So they will give you a patient who has atrophy of the cerebral vermis, hemisphere seen on the MRI. The patient presents with multiple telangiectasia, ataxia, and recurrent infection. And then they will ask you a question asking which of the following is increased in this patient in the near future, right? And then you have to choose one of the three options which is present. Now let's talk about hyper IgM syndrome. So the name itself suggests that there's increased IgM, all right? So you need to understand class switching in order to understand hyper IgM syndrome. So hyper IgM syndrome is an X-linked recessive disorder due to defective CD40 ligand on the Th cells. Now the binding of CD40 to this CD40L stimulates class switching, all right? As there is defect in the CD40 ligand, it cannot interact with CD40, and this will cause abnormal class switching. And without class switching, we cannot produce IgA, IgG, and IgE. We'll only produce IgM. That's why there is hyper IgM in this patient. All right, you need to understand this pathophysiology. Super high yield for USMLE Step 1. Now let's look at the clinical features. So the patient will present with failure to thrive, but this is not a unique feature, right? There'll be recurrent severe pyogenic infection. Again, this is not something unique. However, the unique features are cryptosporidium diarrhea and CMV hepatitis. All right. Similarly, there's increased risk of opportunistic infection. So if a patient presents with immunodeficiency and they have chronic cryptosporidium diarrhea or there is hepatitis due to cytomegalovirus, then you have to suspect hyper IgM. Now, if you do a lab investigation, you will see increased IgM and decreased IgA, IgE, and IgG. All right. So in the serum, the IgM will be increased, but these A, G, and E are increased. Similarly, if you do a lymph node biopsy, there'll be absent or hypoplastic germinal center. Like I said earlier, any defect in B cell proliferation or any activation of B cell will cause absent or hypoplastic germinal centers. These are super high yield. So let's talk about Wiskott-Aldrich syndrome. Now, for USMLE Step 1, you have to remember that this is an X-linked recessive inheritance and there'll be a mutation in the WASP gene. Now, Another question they might ask you about the pathophysiology is what happens after the WASP gene mutation? So you need to know that because of this mutation, there'll be impaired signaling to the actin cytoskeleton. Now, just knowing this is not enough. You have to know that because of impaired signaling, the leukocyte and platelets cannot recognize the cytoskeleton. Now, another thing that you must know is as leukocyte and platelets are unable to recognize the cytoskeleton, there'll be defective antigen presentation. So you have to know the entire sequence from WASP mutation to the leukocyte and platelet being unable to recognize the cytoskeleton, causing the defective antigen presentation. So you have to know the entire pathophysiology because each step in the sequence can be a potential question in the USMLE step one. All right. So the clinical presentation is pretty unique and it presents with this triad of recurrent opportunistic infection, especially the encapsulated organism. There'll be eczema and purpura. All right. So this purpura is pretty unique. So whenever you have a patient presenting with purpura and infection, you have to think about Wiskott-Aldrich syndrome because this purpura is pretty unique to Wiskott-Aldrich syndrome. All right. So whenever there is any kind of bleeding manifestation, you have to think about Wiskott-Aldrich. This is the most unique thing. Now, another association they love to ask in USMLE Step 1 is there's increased risk of autoimmune disease and malignancy like leukemia and lymphoma in Wiskott-Aldrich syndrome. This is another highly tested thing in Step 1. So for diagnosis, the IgG and IgM, they can be either decreased or normal. The most important thing you need to know is that IgE and IgE are going to be increased. So this is pretty unique. The A and E being increased, whereas IgG and M being normal or decreased. So this is unique to Wiskott-Aldrich. So you have to remember this. So there'll be thrombocytopenia, which causes the purpura, all right? So this is the unique thing about Wiskott-Aldrich. If there is immunodeficiency symptoms such as recurrent infection, and if the platelet count is low, you can easily choose the option of Wiskott-Aldrich, all right? And like I said in earlier part of the videos, that gold standard test for identifying these immunodeficiency syndromes is the genetic test. So if you do a genetic test here, you'll see a mutated WASP gene. Now, another highly important question that they can ask is about the peripheral blood smear. So if you do a peripheral blood smear in patient with Wiskott-Aldrich syndrome, there'll be small platelets. Not only will there be thrombocytopenia, but the platelets are going to be small compared to the normal platelet. All right. So this small platelet is another unique feature of Wiskott-Aldrich syndrome. Now let's talk about phagocyte dysfunction. Now we'll be talking about leukocyte adhesion deficiency type 1, Chedick-Higashi syndrome, and chronic granulomatous disease. These are really high yield for USMLE step 1. Now let's talk about leukocyte adhesion deficiency type 1. Now, leukocyte adhesion deficiency type 1 occurs because of the defect in LFA1 integrin. It is also called CD18 protein. Now, this is really high yield. You have to remember the defect, okay? And because of this defect, it prevents leukocyte from migrating to the tissue. So whenever there is invasion of the skin by bacteria, there'll normally be inflammation. And why will there be inflammation? It's because the neutrophils can migrate to the tissue. It will release reactive oxygen species. It will destroy the bacteria. It will phagocytose them, right? So that will create inflammation. But as there is problem in migration, even if there is invasion of the skin, there won't be any inflammation. So this skin infection is just an example, all right? Now, normally if there is invasion by a bacteria, there'll be pus formation, there'll be inflammation, there'll be swelling because of the neutrophils. Neutrophils trigger this inflammation and pus formation. But in patients with leukocyte adhesion deficiency, there won't be a lot of pus, all right? There'll be absent pus and the inflammation will be barely minimum, all right? So you can compare these two. You can see how there is erythema and warmth and swelling here, whereas this looks pretty mild, all right? So the clinical features are recurrent non-suppurative bacterial infection, super high yield. Neutrophils cause suppuration, all right? So without neutrophils, there won't be any pus, really high yield. Now, another feature is poor wound healing. So like I said earlier, neutrophils trigger inflammation, right? And this inflammation triggers further steps which will ultimately help in wound healing. As there is poor migration of neutrophils, there won't be adequate signals for wound healing. So there'll be poor wound healing. Now, another unique feature of leukocyte adhesion deficiency is omphalitis. This will occur in newborns, all right? Super high yield. This is very unique feature of LAD. Now, similarly, there'll be delayed separation of umbilical cord, and delayed separation is defined as umbilical cord being intact for more than 30 days, all right? These are highly specific features of leukocyte adhesion deficiency. Now, if you see any newborn with omphalitis or there is delayed separation of umbilical cord, you can think about leukocyte adhesion deficiency on your USMLE step 1. Super high yield. So there'll be delayed separation of cord and there'll be poor wound healing. So now let's talk about diagnosis. Normally, whenever there is any kind of infection or trauma, neutrophils migrate to the site of infection or trauma and cause inflammation. But in leukocyte adhesion deficiency type 1, neutrophils are unable to migrate. So their number is going to be increased in blood. So there'll be increased neutrophils in blood, but the neutrophils in the site of infection is going to be low. This is super high yield information. So the neutrophils are absent at the site of infection, but they are increased in blood. Why? Because they cannot migrate. They are trapped inside the blood vessel. Now, if you do a flow cytometry, you can see that there is absent CD18. So this is the defective protein. Now, another defect that can occur is CD11 type A, CD11B, or CD11C. But the most important one is CD18. So when you do a flow cytometry, CD18 is going to be absent. Super high yield for USMLE step 1. Now let's talk about Chedek-Higashi syndrome. Now this is an autosomal recessive disease which affects the LIST gene. So it's lysosomal trafficking regulator gene. Because of this defect, the microtubule polymerization will be dysfunctional. And without microtubule polymerization, there won't be phagolysosome formation. So there'll be defective phagosome fusing with the lysosome. All right. So this is the polymerization of the microtubules. And this is important for the formation of phagosome and lysosome fusion. All right. So without phagosome fusing with lysosome, the bacteria cannot be destroyed. Normally, the phagosome fuses with the lysosome and the destructive enzymes inside the lysosome will cause the lysis of the bacteria. And this function is prevented in Chedek-Higashi syndrome. So let's talk about the clinical feature. So the unique clinical feature about Chedek-Higashi is albinism and degeneration of neurons, all right? And this will cause peripheral neuropathy. So whenever you have a patient who has recurrent staphylococcus or recurrent streptococcus pyogen or pseudomonas infection, and if they have neuropathy, you have to think about Chedek-Higashi, all right? And there'll also be lymphohistocytosis. Now, these are unique features. So if you have any of these clinical features on your USMLE Step 1, you can choose the option of Chedek-Higashi. Now, for diagnosis, if you do a peripheral blood smear, this is the normal granulocytes, all right? So the granules in granulocytes, this is the normal size. But in Chedek-Higashi, these granules are going to be really large, all right? There'll be giant cytoplasmic granules. So this is pretty unique feature. Now, there'll also be mild coagulation defect and there'll be pancytopenia. Now, let's talk about chronic granulomatous disease. This is highly tested topic on USMLE Step 1. Now, this is an X-linked disorder, which is the most common type. But there could be other causes as well, but this is the most common, X-linked disorder. Now, there'll be a defect of NADPH oxidase. Now, normally NADPH oxidase produces reactive oxygen species, which will cause respiratory burst in neutrophils, and this respiratory burst will destroy the bacteria. Now, because there's defect in NADPH oxidase, we cannot produce reactive oxygen species and we are not able to destroy the bacteria. So There's increased risk of recurrent infection due to catalyst positive organism. Now, this is highly tested on USMLE Step 1. Now, normally, even bacteria can produce these superoxide inside them because of their metabolism. Now, if it's a catalyst negative organism, it cannot produce hydrogen peroxidase and it cannot metabolize hydrogen peroxide into water and oxygen. So our body can use that to produce the reactive oxygen species and destroy the catalyst negative organism. But catalyst positive organism produces hydrogen peroxidase and it can metabolize the hydrogen peroxide into water and oxygen. So our body cannot use the bacteria's reactive oxygen species to kill the bacteria. So we are protected against catalyst negative organism, but we get recurrent infection from catalyst positive organism. Why? Because our body cannot use the reactive oxygen species produced by the bacteria because catalyst positive bacteria have hydrogen peroxidase. All right. And they can metabolize H2O2 into H2O and oxygen. Now, the catalyst positive organisms that are highly tested on USMLE Step 1 are Pseudomonas, Helicobacter pylori, Bordetella pertussis, Burkholderia, Nocardia, Listeria, Aspergillus, Candida, E. coli, Serratia, and Staphylococcus. These are the organisms that you must remember for USMLE Step 1. Now, the way they will ask you question is they'll give you a patient or a child who has recurrent catalyst positive organism infection, and they will ask you which of the following bacteria or fungus, right, can cause infection in the future. And they might give you Aspergillus and other non-catalyst positive fungi, and then you have to choose Aspergillus as an answer. All right. So this is one way they ask question. Now, another high yield information that you need to understand is there will be granuloma formation. That's why it's called chronic granulomatous disease. But why is granuloma being formed in this patient? So like I said earlier, body cannot produce reactive oxygen species to kill the bacteria, but they need some kind of mechanism to curtail the infection, right? So body starts forming granulomas to prevent the spread of infection and curtail the infection. So body produces granuloma and surrounds the bacteria so it prevents the spread of bacteria. That's why in chronic granulomatous disease, because of the defect in NADPH oxidase, reactive oxygen species are not formed. There won't be respiratory burst, but we need some kind of mechanism to control the infection, right? And that mechanism is granuloma formation. Super high yield for USMLE Step 1. Now let's talk about diagnosis. So if you do a flow cytometry, it will be abnormal and the dihydrorhodamine test will show decreased green fluorescence, super high yield for USMLE Step 1. They will mention this test on the question, right? They will say the patient has recurrent infection from catalyst positive organism. When dihydrorhodamine test was done, there was decreased green fluorescence. Now, which of the following will be seen in histology? And then there might be an option of granuloma formation, and you have to choose that. All right. So this is one way they might ask you a question on USMLE Step 1. Now there's another test which is obsolete. It was done in the past, but now it's not done. And that test is nitro blue tetrazolium dye test. So this is a reduction test and it fails to turn blue in patients who have CGD. All right. Although this test is obsolete, sometimes they will test you about nitro blue tetrazolium dye failing to turn blue on USMLE Step 1. I hope you enjoyed this video. Thank you. Hello everyone, I'm Dr. Ashish Kuragai and today we'll be talking about blood transfusion reactions. So let's get this started. So the first type of reaction that we'll be talking about is acute hemolytic transfusion reaction. Now, the way this question comes up in USMLE Step 1 is you'll get a patient who develops pruritus, hypotension, hemoglobinuria, flank pain, shock, right? After receiving blood transfusion for any condition. It could be a lot of blood loss during the surgery or after the trauma. So you'll get these symptoms after transfusion, right? Then you need to think of acute hemolytic transfusion reaction. Now, acute hemolytic transfusion reaction occurs within 24 hours. So usually it occurs within first few hours, but sometimes it takes up to 24 hours, all right? So the onset is within 24 hours. Now, the etiology is ABO blood group incompatibility. Now, this is the most common cause. Although rare, this is the most common cause. Now, sometimes even antibodies against minor antigens can cause acute hemolytic transfusion reaction, but the most common is ABO blood group mismatch. All right. Now, what you need to understand is different people have different types of blood group, right? You know that. Some people have A antigen, right? And that's why they are called A positive or A negative depending on their RH. But that's not the point right now. Forget about the positive and negative. Right now, just think about if you have A antigen in your RBC, you'll have blood group of A. Similarly, if you have B antigens, you have B positive or B negative. Similarly, if you have both A and B, you will have AB type of blood group, right? And if you don't have any of these two antigens, then you'll have O blood group, right? It could be positive or negative depending on the RH status, but that's not the point here. So you have these different types of major ABO compatibility. Now, with people who have A type of blood, they have antibodies against the B type, all right? And vice versa. Now, if you have both types of antigen, you won't have antibody against either of them, right? Now, if you don't have a single A or B antigen in your RBC, then your body will have antibodies against both the type. That is, you have antibodies against the A antigen and antibody against the B antigen. Now, let's say due to some error, a person with B positive or B negative blood group received a A type blood, right? Now, this person with B type blood will have antibodies against the A type blood, right? So this will cause acute hemolytic transfusion reaction. Now, the pathophysiology of this disease is type 2 hypersensitivity reaction. Now, this is super high yield from exam point of view. Now, the question makers are not going to ask you a simple question of finding the diagnosis that it's acute hemolytic transfusion reaction, right? That's easy. Now you need to understand the pathophysiology behind it, all right? And they might ask you which type of hypersensitivity reaction it is. And then you have to answer it's type 2 hypersensitivity reaction. Now, they might ask you further detail about type 2 hypersensitivity reaction, but we'll be talking about that in the hypersensitivity video. So type 2 hypersensitivity reaction, let's say this is A type RBC in a person who is a B type, right? So your body will form antibodies against the A type, right? So antibodies are going to attack these antigens. Now, this antigen antibody complex will trigger complement, right? And it will cause inflammation. Similarly, complement activation will cause C3b formation, which will tag the RBCs, and then the tagged RBCs will be phagocytosed. All right. Similarly, natural killer cells will recognize these antigen antibody complex and cause apoptosis of the RBCs. There are several other mechanisms of destruction in type 2 hypersensitivity, but we'll be talking about that in the hypersensitivity video. For time being, just remember that acute hemolytic transfusion reaction is a type 2 hypersensitivity reaction, and the destruction of RBC will cause hemolysis, and it's intravascular hemolysis. All right. Now, earlier I had talked about how the question will come up, right? You'll get a patient who developed fever, chills, right? After getting a blood transfusion, flushing. There'll be itching, urticaria, right? Similarly, there might be hypertension, tachycardia, flank pain, or chest pain, dyspnea, right? So this is how the question comes up. Now, the most high yield thing you need to know is hemoglobinuria. Now, these things, fever, chills, pruritus, hypertension, these are not something unique about acute hemolytic transfusion reaction. We'll be talking about this in anaphylactic reaction as well. Now, you need to understand that these symptoms are not going to help you distinguish that it is acute hemolytic transfusion reaction because this occurs in so many other diseases. Now, let's talk about how hemoglobinuria occurs. So, when the RBC are destroyed, hemoglobin will be released, right, into the blood. Now, hemoglobin usually is not present outside RBC in a large amount. Whatever hemoglobin that escapes or is outside the RBC, they're captured by haptoglobin, all right? Haptoglobin binds to free hemoglobin. So usually we don't have hemoglobin in the blood, so this hemoglobin is not excreted from the urine. Now, when there's a lot of free hemoglobin in the blood, it will be filtered in the glomerulus and it can escape into the urine. So whenever you get hemoglobin urea, you need to understand that there is hemolysis. So you need to understand why icterus occurs in acute hemolytic transfusion reaction. So after the lysis of RBC, hemoglobin breaks down into heme and globin. Now this heme is converted into biliverdin and then into bilirubin, right? And bilirubin causes icterus. When it deposits in your eyes, in the sclera, it causes icterus. When it gets deposited in skin, it causes yellowing of your skin. All right. Now, these two features, hemoglobin urea and icterus, are something which will help you distinguish that this is acute hemolytic transfusion reaction and not anaphylactic reaction, because these symptoms overlap between acute hemolytic transfusion reaction and anaphylactic reaction, which we'll be talking about later. Now, diagnosis is usually clinical, all right? But we need to repeat the blood typing and cross-matching to confirm that there was a mismatched transfusion. Now, this is high yield. Direct Coombs test is usually positive. You might get these hints in the question, which will help you distinguish that this is acute hemolytic transfusion reaction. Now, direct Coombs test won't be positive in anaphylactic reaction, but it will be positive in acute hemolytic reaction. Now, if there's a lot of destruction, you'll get anemia, and thrombocytopenia will develop only if this acute hemolytic transfusion reaction induces DIC. All right, so thrombocytopenia will develop only if there's DIC. So whenever you get a question of DIC after transfusion, you have to think that acute hemolytic reaction triggered this DIC. All right, disseminated intravascular coagulation. You need to think about that. Now, we talked about this earlier, right? How there's indirect bilirubin increased in hemolytic transfusion. Now, LDH is also present inside RBC. So when LDH is increased, you have to understand that it got spilled out. All right, there was destruction of the RBC and the LDH spilled out. That's why you'll have increased LDH. Now, I talked earlier about haptoglobin. So haptoglobin binds to free hemoglobin. So when a lot of haptoglobin binds to the free hemoglobin, its level is going to be decreased. Now, these are high yield stuff. All right, these lab investigations are going to help you distinguish that, okay, this is hemolytic transfusion reaction. Now, hyperkalemia occurs because potassium will leak out from RBC. All right. Now, coagulation panel will be altered only if DIC occurs. Now, DIC will occur after hemolytic transfusion reaction because a lot of hemolysis can trigger DIC. All right. Hemolysis can trigger disseminated intravascular coagulation. Now, this is another high yield information. All right. We've talked about how hemoglobin urea occurs. So now let's talk about management. So whenever you suspect any kind of transfusion reaction, the first thing you need to do is stop the transfusion, right? So if the patient is in shock, hypovolemic, then you have to start fluid resuscitation, right? Now, another important thing that you need to do is check for clerical error and contact transfusion service. This is super high yield, all right? You need to know that you have to contact transfusion service after a reaction occurs because you cannot let such error occur multiple times. And if this error occurred once, it might be occurring again, or there might be other mismatched blood distributed in the hospitals, right? So you need to contact the transfusion service. Now let's talk about anaphylactic transfusion reaction. Now a lot of my students get confused between anaphylactic transfusion reaction and acute hemolytic transfusion reaction because both of them start within few hours, right? Although hemolytic transfusion reaction occurs up to 24 hours, it usually occurs within first few hours. Now anaphylactic reaction, if it occurs within minutes, students do not get confused, right? They think about anaphylactic reaction if it occurs immediately, but sometimes it takes up to 3 hours. Now, this up to few hours, this is the overlapping feature between acute hemolytic transfusion reaction and anaphylactic reaction. Let's say a reaction occurred after 2 hours, right? Then that time period overlaps between anaphylactic transfusion reaction and acute hemolytic transfusion reaction. So a lot of students get confused. But the pathophysiology is completely different. This is a type 1 hypersensitivity reaction, all right? Now, this antigen which triggers anaphylactic transfusion reaction after blood transfusion is usually protein like IgA. All right, it could be other protein, but the most common one is IgA antibody, and especially in patients who have IgA deficiency. So, in people who have IgA deficiency, IgA is a foreign antigen to them, it's a foreign protein, right? So, IgA can trigger anaphylactic reaction in patients who have IgA deficiency. So IgE antibody in the mast cells will bind to IgA antibody and cause degranulation. And this mast cell degranulation will trigger anaphylactic reaction. Now, like I said earlier, type 1 hypersensitivity reaction could occur against plasma proteins, but the most common one is against the donor IgA in individuals with IgA deficiency. This is super high yield for USMLE Step 1, super high yield, all right? Now, clinical features are of that of anaphylaxis. Now, you know that there'll be hypotension, swelling, right? Facial puffiness, redness, bronchospasm, wheezing, urticaria, itching, right? These are the features of anaphylactic reaction. Now, like I said earlier, a lot of my students, they get confused between anaphylactic reaction and acute hemolytic transfusion reaction. Now, the reason they get confused is that this urticaria, itching, hypotension, these are common between the two types of reaction. But angioedema, swelling of the face, bronchospasm, wheezing, right? These are unique to anaphylactic reaction. These symptoms are not dominant in hemolytic transfusion reaction. Whereas in anaphylactic transfusion reaction, you won't get hemoglobinuria icterus, which are seen in acute hemolytic transfusion reaction. All right. So you have to know how to distinguish between these two. Super high yield. Now let's talk about diagnosis. Usually diagnosis is clinical, but we have to consider testing the recipient for serum IgA level and anti-IgA antibodies. Remember, these reactions are common in patients who have IgA deficiency, super high yield. Now let's talk about management. Like any other anaphylactic reaction, you treat anaphylactic reaction because of blood transfusion with epinephrine, IV fluids, and airway management. There's a high risk of airway obstruction because of facial swelling, the swelling of the oral cavity, the pharynx. So, if necessary, you have to intervene and intubate the patient early on. All right. Now, there are some adjunctive treatments like antihistamine and corticosteroids, which reduce the inflammation, urticaria, the swelling, all right, but these are adjunctive treatment. These are the most important management. Now, for prevention, always use washed blood products. It doesn't matter whether you're transfusing platelets or RBC, you have to wash them so that you can remove the plasma proteins. All right, washing the blood products will wash away the proteins, right? And in patients who have IgA deficiency, you have to use IgA deficient blood products. Super high yield from exam point of view. All right. Now let's talk about febrile non-hemolytic transfusion reaction. Now the word itself, febrile but non-hemolytic. Usually in hemolytic transfusion reaction, you'll get fever, flushing, right? But in febrile non-hemolytic transfusion reaction, the predominant feature is only fever. There won't be any hemolysis, but there'll be fever. Now this is most common in children, all right? Children are really susceptible for febrile hemolytic transfusion reaction. Now onset occurs within 6 hours. It could occur within few hours, but usually occurs within the first 6 hours. Now, the pathophysiology is quite unique. When the blood products are stored for a really long time, this will cause the cytokines inside the WBCs to leak into the blood product, right? And this cytokines will trigger inflammation and transfusion reaction. All right. Now, the most predominant feature are fever, chills, headache, and malaise. So, any patient, usually children, if they get fever, chills, right, malaise, but they do not have features like hypertension, urticaria, shock, right? If they do not have any feature of anaphylactic reaction or any hemolytic feature such as hemoglobin urea, icterus, then you have to suspect febrile non-hemolytic transfusion reaction. So for diagnosis, an increase of more than 1 degree Celsius from baseline, then you have to think about febrile non-hemolytic transfusion reaction. All right. Now, for management of febrile non-hemolytic transfusion reaction, all you need to do is stop the transfusion and make sure that it's not acute hemolytic transfusion reaction and make sure that it's not something serious like anaphylactic reaction. Now, after you have ruled out anaphylactic reaction and other hemolytic reaction, you can resume transfusion, all right? Febrile non-hemolytic transfusion reaction is not the absolute indication to completely stop the transfusion. You just stop it to rule out other diagnosis. But once you have ruled other diagnosis out, you can resume the transfusion, but you have to resume it slowly, all right, at a slower rate. Then you can give antipyretic like acetaminophen, right? Then that should be enough, all right? Now, another high yield transfusion reaction which they test you in USMLE Step 1 is TRALI, transfusion related acute lung injury. Now, this occurs within first few hours, usually within 6 hours, all right? The pathophysiology is quite unique and a bit complex. So please listen carefully. Now, if a patient has sepsis or let's say pneumonia or let's say severe trauma, right? In these patients, neutrophils are primed, all right? That means the neutrophils are activated and ready to fight, all right? They are in high alert. So, in these patients, when you transfuse blood, the anti-leukocyte antibodies or any other plasma proteins or lipids, they can trigger the activation of neutrophils. Usually, it's the anti-leukocyte antibody. Now, the neutrophils are already primed, right? So even a small trigger can release a huge amount of inflammatory mediators, which will increase the capillary permeability and and it will cause non-cardiogenic pulmonary edema. Now, the word non-cardiogenic is super high yield because cardiogenic cause, let's say decreased contractility or fluid overload, can also cause pulmonary edema. But here, the fluid in the alveoli are because of increased permeability and not cardiogenic cause. All right. Now, you can understand the pathophysiology of TRALI as two-hit theory. All right. The first hit is that the patient should have some comorbidity or pre-transfusion conditions like sepsis, pneumonia, or severe trauma. All right. And the second hit is the transfusion. So after transfusion, the activated neutrophils, the primed neutrophils, when they get even simple triggers like anti-leukocyte antibodies, there'll be huge inflammatory reaction. This pathophysiology is super high yield from exam point of view. It's a bit complex, so I repeated it multiple times. All right, super high yield. You need to know this trolley. Now, talking about the clinical features, the patient will present with respiratory distress. So the way question will be asked in USMLE Step 1 is a patient who has severe trauma, let's say after a road traffic accident, all right, received transfusion. Now, after transfusion, there was respiratory distress. The patient has high respiratory rate, use of accessory muscles, the saturation is decreased, the chest x-ray shows bilateral infiltrates, right? The features of pulmonary edema. Then you have to think about TRALI, all right? So this is how the question will present. After transfusion, the patient will get respiratory distress, but the patient should have some kind of comorbidity. That's the risk factor. Now, talking about the management, you have to supplement the patient with oxygen, all right? And if necessary, even intubation and ventilation should be considered, all right? Now, another super high yield question that you'll get asked in USMLE Step 1 is TACO. transfusion-associated circulatory overload. Now, a lot of students get confused between TRALI and TACO, all right, because both of them occur after transfusion reaction and both of them present with respiratory distress, all right? So that presentation will confuse a lot of students. Now, TACO, or transfusion-associated circulatory overload, occurs within first 12 hours, all right? So it has slightly extended onset compared to TRALI, but there's a lot of overlap, all right? Now, the pathophysiology, as you can understand from the word itself, circulatory overload, all right? So whenever a patient receives huge amount of transfusion in a short time, obviously there's going to be increased intravascular volume, right? Now, if the patient has premorbid conditions like heart failure, CKD, or if the patient already received a lot of IV fluids, then the patient is at higher risk of developing TACO. All right. So increased intravascular volume will increase pulmonary venous hydrostatic pressure, right? And that increased hydrostatic pressure will push out the fluids from the capillary into the alveoli, right? And it will cause pulmonary edema as well. But this pulmonary edema is cardiogenic, right? Now, like I said earlier, there must be some kind of risk factor. For TRALI, the risk factor were sepsis, trauma, pneumonia, right? Any kind of lung infection or systemic inflammation. Now, the risk factors for TACO are cardiac disease, renal disease, low serum albumin, and positive fluid balance. All right. The clinical features of respiratory distress overlaps between TRALI and TACO. Now, the unique thing about TACO is there will be signs of hypervolemia. There'll be raised JVP, all right? And you can hear S3. Now, you know that S3 occurs in heart failure, all right? So you'll have features of hypervolemia, raised JVP, and S3. This feature of increased JVP and S3 is going to help you distinguish TRALI and TACO, super high yield, all right? Now, for the management, you can understand that whenever there's fluid overload, we give diuretics to excrete that excess volume from the urine. All right. So diuretics will treat TACO. Now, if there's a lot of confusion, sometimes we even give diuretics trial. All right. So after diuretics, if the patient gets improved, then we can be pretty sure that it's TACO. But if a trial of diuretics does not help the patient with their respiratory distress, then we can be pretty sure that it's not TACO and we have to suspect TRALI. All right. Now let's talk about delayed hemolytic transfusion reaction. Now, the difference between acute hemolytic transfusion reaction and delayed type is the onset. All right. Delayed type usually occurs 1 to 2 weeks after transfusion. And for the definition, just remember it occurs after 24 hours. But commonly it presents between 1 to 2 weeks, whereas acute hemolytic transfusion reaction occurs within hours. All right. That's the first difference. The second difference is that acute hemolytic transfusion reaction occurs against major antigens such as A antigen or B antigen in the RBC, whereas delayed type occurs against minor antigens such as rhesus antigen or KIT antigen. The third difference is that delayed reaction occurs as destruction of the RBC by the reticuloendothelial system. That's why it's slow, all right? It takes a lot of time for the RBC to be destroyed in reticuloendothelial system such as spleen by phagocytosis, all right? Whereas acute hemolytic reaction occurs intravascularly, all right? That's why the reaction is much quicker. Now, we talked about onset, all right? Now, the pathophysiology. Now, delayed hemolytic transfusion reaction is an anamnestic response. That means the patient must be exposed to these minor antigens previous to the hemolytic reaction, all right? During the first exposure, there won't be any hemolysis, all right? But there'll be a lot of antibodies formed against these minor antigens. Now, these previous exposure could be during transfusion, pregnancy, or transplantation. Now, like I said earlier, delayed hemolytic transfusion reaction typically causes extravascular hemolysis. Now, this is super high yield for exam, all right? Acute hemolytic transfusion reaction occurs intravascularly, whereas delayed hemolytic reaction occurs extravascularly. These RBCs are destroyed by reticuloendothelial system, all right? Now, talking about clinical feature, the way USMLE Step 1 will ask you question is they'll give you a patient, let's say a 24-year-old male, presents to your office with features of fever, jaundice, and anemia. There's a history of transfusion of blood 2 weeks back. All right. So, whenever you get such clinical features or vignette in the question, you have to think about delayed hemolytic transfusion reaction against the minor antigens. All right. Now, for diagnosis, we can do a direct Coombs test. All right, which will confirm that there is hemolysis. And direct Coombs test is going to be positive. Why? Because there's hemolysis. So, whenever there's hemolysis, direct Coombs test is going to be positive. Now let's look at other complications of transfusion. One of the most commonly tested condition in USMLE Step 1 is hypocalcemia. So you have to understand that for storage of blood, we use citrate, all right? And citrate can cause chelation of the calcium. So whenever there's a massive transfusion, all right, there's a higher risk of hypocalcemia. Why? Because this calcium is chelated by the citrate in the stored blood, all right? And the patient will present with spasm, such as carpopedal spasm, or the patient will present with facial twitching when the patient's cheeks are tapped. All right, these are features of hypercalcemia. Then another complication is hyperkalemia. You need to understand that RBCs contain a lot of potassium inside them. Whenever there's lysis in stored blood, and when that blood is transfused, the recipient can get hyperkalemia. All right, this is another high yield question asked in USMLE. Similarly, the blood that is stored is cold. All right, we have to store the blood in cold temperature. Whenever patient is rapidly transfused without rewarming the stored blood, there can be hypothermia. Similarly, another commonly tested condition is coagulopathy. There's a risk of DIC, all right? And DIC occurs because of dilution of platelets and clotting factors after massive transfusion. So these four complications are common after massive transfusion rather than just few units of blood, all right? So whenever there's transfusion of blood in short duration, then there's a risk of hypocalcemia, hyperkalemia, hypothermia, and coagulopathy. Now let's do some USMLE style questions. So a 68-year-old woman who underwent laparotomy developed respiratory distress shortly after post-operative transfusion of 2 units of packed RBC. Her temperature is 100.8, respiratory rate is increased, it's 29, BP is dropping, right? The patient is in shock. Saturation is decreasing, right? It's only 75. There's no jugular venous distension or any abnormal heart sound, all right? Chest X-ray shows bilateral interstitial infiltrate. So it looks like there's some pulmonary edema. Which of the following is the most likely underlying mechanism of this patient's transfusion reaction? Now, if you remember, we talked about trali and taco, right? The most important thing we need to distinguish is whether the condition is trali or taco. Now, this chest X-ray does not help because you'll get bilateral interstitial infiltrate in both trali and taco. But this feature, no jugular venous distension and no abnormal heart sound, that is, there's no S3, will help us distinguish that this is Trali and not Taco. All right. And another feature is that the patient only had 2 units of RBC. All right. So it's highly unlikely that the patient will be hypervolemic because of only 2 units of packed RBCs. So let's look at the options. So is it activation of prime neutrophils, volume overload, hemolysis, or mast cell degranulation? So what do you think is the mechanism? If you said activation of prime neutrophils, then you are correct. All right. Here, the condition that caused the priming of neutrophils is trauma. All right. The patient had laparotomy. All right. And this is the condition which triggered the priming of the neutrophils. Now let's talk about another question. So this 23-year-old woman presented to the emergency department after crashing her car at high speed with a truck. The X-ray revealed a fracture of left femur, right tibia, and pelvic fracture. The PP 60 by 40, pulse rate is 120, After fluid resuscitation, she was rushed to surgery. During surgery, she received 4 units of packed RBC. After the surgery, examination shows an adducted thumb, extended fingers, and flexed metacarpophalangeal joints and wrist. Tapping on the cheeks lead to contraction of the facial muscles. Which of the following is the most likely cause? Now, if you remember what we talked earlier, after transfusion, there's a risk of hypocalcemia. And these features, such as tapping the cheeks leading to contraction of facial muscles and carpopedal spasm, right? Adducted thumb, extended fingers, these are features of hypocalcemia. So let's look at the options. Is it because of calcium chelation, laceration of liver, acute kidney injury, or hyperkalemia? So the right answer is calcium chelation. All right, the calcium chelation caused hypocalcemia, which led to these features. I hope you enjoyed the video and I hope you learned a lot. Thank you.